was loud. Good morning and welcome to our fourth meeting of the Joint Interim Standing Committee on Commerce and Labor. Secretary, will you please take roll?
Senator Ellison, Senator Flores,
Present.
Senator Pazina,
Present.
Senator Steinbeck, Assemblymember Kasama,
Here.
Assemblymember Miller,
Here.
Assemblymember O'Neill, Assemblymember Roth,
Here.
Chair Marzola.
Thank you. Please mark members present once they arrive. And also with Assemblymember O'Neill, please mark him absent excused. Welcome everyone that is here with us in Las Vegas, those joining us in Carson City, and anyone tuning in over the internet. Today we have a very long agenda. Today is what I call our healthcare day, and we will be hearing from several groups and perspectives on many issues relating to healthcare, health insurance, and the affordability of health insurance. My ask today was, please make sure that when you're presenting, we talk about what's working in our state, what's not working in our state, and at the end of the presentation, I would like to request some legislative ideas that we may be able to bring forth next legislative session. Before we get started, I do have a few housekeeping announcements. Members of the public may provide testimony in various ways, all of which are listed on the agenda. When testifying, please remember to turn on your microphone to speak and off to listen. Also remember to state and spell your name for the record. Committee information is available on Nellis, which can be accessed through the legislature's website. We will begin today with public comment. Please remember that public comment is 2 minutes. We want to make sure to accommodate everyone that is here, that is in Carson City, and also over the phone lines. I know the healthcare issue can be a very passionate issue. What I ask today is that everyone's presentation is done with respect, not only to the committee members, but each presenter as well. Please remember to turn off all of your electronic devices, especially your cell phones. With that, we will move to our first agenda item. We will start with public comment. Is there anyone in Las Vegas that wishes to provide public comment? Please remember to state and spell your name for the record. You each have 2 minutes. Once you are done with your testimony, if you can please get up so the next person can join. You may begin when you're ready.
Good morning. My name is Terry Chi, Terry-Chi for the record. I'm the Nevada Bill Director for End Workplace Abuse, a national nonprofit organization who's dedicated to eliminating workplace abuse. I'm joined again by other advocates and your constituents who have called in, written in, and testified for the past several months about the need for a Workplace Psychological Safety Act in Nevada. A Workplace Psychological Safety Act has been introduced in 3 states so far: Massachusetts, Rhode Island, and New York. Nevada has the opportunity to lead the West. Thank you.
My name is Rafaela Hurtado, R-A-F-A-E-L-A-H-U-R-T-A-D-O. Having witnessed and at times personally experienced an immense amount of psychological abuse, I have earned the right to speak on this topic. The damage from psychological abuse is never contained. It devastates the individual and it fractures our entire community. A person who is psychologically abused is affected tremendously across physical, emotional, and mental dimensions. This trauma manifests clearly through exhaustion, emotional volatility, sleep disturbances, impaired concentration, and frequent disassociation. It frequently escalates into severe depression, anxiety, substance abuse, and social withdrawal. Worst of all, it can lead to suicidal ideation, suicide attempts, or death by suicide, as it unfortunately did with Dr. Antoinette Candia Bailey, just days after being terminated after experiencing months of psychological abuse. In Las Vegas, our traditional tough it out culture has proven to be deadly. Data in our construction industry shows that workers are 5 times more likely to die by suicide than from a physical job accident. Workplace psychological abuse trauma spreads outwards to families, coworkers, and even strangers, like drops of water creating ripples. Healing from psychological abuse creates massive public and financial burden on healthcare. Crucially, the cost of healing this damage extends across generations, demanding resources for spouses, children, and even grandchildren. If physical safety on the job is a law, psychological safety should be a law also. By supporting the Workplace Psychological Safety Act, you can help ensure that future generations of workers never have to endure the trauma that so many of us have already survived.
Good morning, committee members. My name is Bridget Shiner, spelled BridgetScheiner, stage name Virginix. I was a dancer in the inaugural cast of Awakening at the Wynn. I was a voice for my castmates against sexual, verbal, and psychological abuse, as well as contract violating pay cuts and unpaid rehearsal hours. This put an immediate target on my back. Anytime safety concerns were referenced, management weaponized toxic labels to diminish our validity. We were gaslit, which led to excessive injuries, surgeries, and panic attacks while at work. This was considered a normal day for us. Those of us who spoke up were labeled as problematic or dramatic to systemically invalidate our concerns and protect the institution. Win contracts threatened an $80,000 lawsuit for breaking them, financially trapping us in terror and harm's way. Those who broke contract and tried to get out were sued by the Win, even with doctor's notes referencing psychological harm for more than what we made annually in a year. When I went to HR, the psychological abuse escalated to physical retaliation. I was denied accommodations. Others were granted despite a note from their own assigned workers' comp doctor. This deliberate neglect led to a catastrophic preventable stage accident, stuck inside my costume, unable to breathe, while multiple wardrobe techs struggled to take the costume off of my body. I am left with permanent lifelong spine damage, inhibiting my career abilities. This was not unique. Many have suffered severe damage, required preventable surgeries, or escaped near-death accidents. To silence the cast, the Win suspended me without pay, fired me while on workers' comp, and blacklisted me from future industry work on the Vegas Strip before threatening my workers' comp doctor to close my medical case prematurely. Systems like HR, NERC, and EEOC are broken in the state of Nevada. This is incredibly uncommon in the workplace of varied labored sectors because we have nothing in place to regulate workplace psychological abuse. We need legal accountability, but before we can pass a law, we need leaders like you to willing to champion it. Nevada ranks near last in mental health and suicide rates. Its correlation to lack of labor protections is very relevant. For the safety, health, and economic stability of Nevada workers statewide, I ask this committee to please prioritize sponsoring the Workplace Psychological Safety Act and help us take the first critical step towards safety, dignity, and justice. Thank you all for your time today.
Good morning. My name is Patrick Kelly, K-E-L-L-Y, and I'm the CEO of the Nevada Hospital Association. Today's agenda begins a discussion about healthcare costs in Nevada. Nevada hospitals are facing significant and unsustainable increases in the cost of providing care. According to the American Hospital Association's latest cost of caring report, hospital drug expenses increased 13.6% in 2025. Hospital supply costs rose 9.9%, and hospital workforce expenses increased another 5.6%. At the same time, hospitals continue to invest heavily in Nevada's healthcare workforce. Registered nurses in Nevada now earn average wages exceeding $100,000 annually, and Nevada continues to rank among the top states in the nation for nurse compensation when adjusted for the cost of living. These financial pressures are likely to intensify under the changes in H.R. 1, which significantly cut Medicaid supplemental payments to hospitals and will substantially increase the number of uninsured Nevadans. When people lose coverage, many delay care until their conditions become more serious, and they turn to hospital emergency departments for treatment. In many cases, that care goes uncompensated, adding even more financial strain on hospitals already facing rising costs. Nevada hospitals remain committed to caring for patients in every community across our state, but the reality is clear. Hospitals are experiencing substantial increases in workforce, pharmaceutical, supply, and uncompensated care costs, while major Medicaid cuts are coming. Thank you, and we look forward to working with the committee on this issue.
Hi, my name is Daniel Lopez. DANIEL LOPEZ. I joined the cast of Awakening at the start of its casted production in April of 2022 and performed there 3 years with the team. It was easy to see the risks that were involved in upkeeping this production, including every person, prop, and policy. Yet it was uneasy to feel how many of my friends of the cast dealt with an unintended, poor psychological experience. And I think many of us are diving into the characters that we play for the performance, so we're not always able to see how in the workplace it develops our own character. And I think what can help with that is people that provide a structure and a pathway for themselves and how they think, to maybe give them a structure to be better and to also not feel so shameful of what they give. Many of the cast have received injuries, or their injuries were magnified through the experience there. And I think each person that I've seen that has dealt with that has spoken up, but continue to receive unintended experiences, which dealt into further and some now permanent lifestyle. So if there are those that can provide policies or provide people and even props to help with their thinking, their behavior, and also less shame, then that can help people be better in the workplace and also be able to do that for each other. There's a lot of people involved and a lot of characters to be, but it definitely builds character. And I think this would be a nice thing to lean into. Thank you.
Thank you for your testimony. We will move to Carson City. Is there anyone in Carson City wishing to provide public comment? I don't see anyone. Broadcast, is there anyone on the line?
Thank you, Chair. If you would like to provide public comment today, please press star 9 to take your place in the queue.
Hello, my name is Donna Wiegert, DONNAWEGERT. I originated and starred as the lead performer of the Awakening show at Wynn Las Vegas since its inception April 2022 until my termination July 2025. During my 3 years there, I witnessed the managerial, production, and creative teams continuously enable a hostile and abusive working environment through means such as, but not limited to, harassment, intimidation, and retaliation. I witnessed ensemble members, dance captains, lead performers, specialty performers, even choreographers, people who I looked up to and admired professionally, who are often the most outspoken when advocating for better, safer working conditions, bullied into silent submission and at times even out of position. When sincere concerns were ever attempted to be addressed, whether by a group or by an individual, the managerial, production, and creative teams took every opportunity to ignore, dismiss, and at times even mock such conversations. Speaking from my own experience, I sought active mediation from the WINS HR department on 3 separate occasions, the first being sexual harassment from these departments, second, bullying, third, intimidation and retaliation. HR deemed that all 3 instances did not warrant their involvement, and therefore each case was handed right back to the departments that were causing the aggression. That system does not enable resolve, that system enables silence, to which I remained until my abrupt termination. Several months prior to my termination, I began steps in filing a claim with the EEOC. Upon my interview, although my interviewer shared their sympathies and acknowledgement towards my treatment, he remarked that such behavior is unfortunately, quote unquote, not illegal. Further investigation into my claim was denied. Although I am no longer with the production, I know the problems persist. They've recently hired a new performer to take on my responsibilities. She just turned 21 years old. I worry deeply for her, as everyone who I looked up to has either left or has since been silenced. I hope that if she is unable to advocate for herself, members here today will be able to put into act the Workplace Psychological Abuse Act. Thank you so much.
Morning. My name is Mark Hobrach, Hobraczk. I am the Policy Director for the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AI Arthritis for short. My comments today focus on two items on your agenda that we strongly support. These are efforts to increase transparency and oversight over abuses of the 340B drug discount program and anti-competitive PBM practices that ultimately increase out-of-pocket drug costs and otherwise harm patients. I'll follow up with details in a written statement, but in my 2 minutes here, I just want to highlight two new studies on these issues. The first was in December. The Milliman Consulting Group released a study that we commissioned demonstrating that profit margins for autoimmune drugs were significantly and consistently higher at 340B hospitals compared to non-340B hospitals, about 15 to 450 times higher. These results were not a surprise. They are consistent with prior studies for other disease states, including cancer. The findings reinforce the need for transparency and reporting requirements to ensure 340B providers are properly using these huge margins as Congress intended, which is to increase charity care, staffing or support services, or otherwise lower a patient out-of-pocket costs for 340B drugs. This is especially true in light of substantial evidence from federal and state investigations, especially Minnesota, revealing many larger hospital systems are instead using 340B for improper purposes that have harmful effects, such as acquiring physician practices that increases their market power and allows them to negotiate higher reimbursement rates from payers. Another 2025 study I want to highlight is from the USC Schaefer Institute. That one found that delinking PBM revenue from the list price of a drug and instead requiring flat fee reimbursement would result in substantial savings for states and the federal government, reducing net annual drug spending by 15% if implemented nationwide. So AI Arthritis is very supportive of all types of PBM reform, but would especially encourage Nevada to consider delinking legislation next session. California, Colorado, and recently Congress for Medicare Part D have already enacted delinking laws. Louisiana is very close to doing so this year. We believe removing that perverse incentive the PBMs have to cover the most expensive drugs for which they can get the highest rebates, that will do more to lower what patients pay for drugs than artificial price caps that were previously vetoed by Governor Lombardo. Thank you.
If you have recently joined us and have yet to speak but would like to provide public comment today, please press star 9 to take your place in the queue. Once more, if you would like to provide public comment, please press star 9 to take your place in the queue. There are no further callers wishing to provide public comment at this time.
Thank you. Just as a reminder, there will be another public comment period at the end of our meeting today. Next, we will have our approval of the minutes of our meeting February 18, 2026. Committee members, are there any questions in regards to the minutes? I don't see any. I will accept the motion to approve the minutes of the committee meeting on February 18, 2026. I have a first Vice Chair Pazina, a second from Senator Flores. Any discussion? I don't see any. All those in favor say aye. Aye. All those opposed say nay. Motion carries. We will now start with all our presentations. Our first presentation today is by the Culinary Health Fund. Joining us today is Maya Holmes, Senior Health Policy Director of the Culinary Health Fund. Welcome.
Thank you and good morning.
You may begin when you're ready.
Let me Great. Are the slides visible? Okay, great. Thank you. I am Maya Holmes. I'm the Senior Health Policy Director for the Culinary Health Fund, and I really want to thank the chair and the committee today for addressing healthcare access and affordability in Nevada. It's a critical issue, and inviting us to participate today. So the Culinary Health Fund, we are a nonprofit labor management trust fund that provides healthcare for benefits for the for the culinary and bartender union workers and their dependents, approximately 145,000 lives. We exist solely to provide high quality, comprehensive, and affordable health care for our participants. Again, we are nonprofit. We're funded through collective bargaining agreements that union members negotiate with their employers. In those agreements, we get a set amount of money over a 5-year period to pay providers for the care of our participants. But we're also a healthcare provider. Over a decade ago, our fund trustees wanted to improve access to primary and preventative care for our participants. We saw a real gap. As a result, we opened our first health center in 2017. And by the end of this year, we're going to have 4 culinary health centers around the Las Vegas Valley, concentrated in areas where our members live. We contract with medical providers to provide primary, pediatric, dental, vision, mental health, physical therapy, pharmacy, and other services. We're really looking at trying to provide whole person care. Most of these services at the culinary health centers have no copays, and those that do, they're very low copays. So this has been a very large undertaking for us, and we're always looking at how we can improve. Fortunately, so far, our members have been extremely happy with the health centers. And this is going to be no surprise to anyone here. Healthcare price affordability is the #1 concern of many Nevadans. A recent survey found once again that healthcare affordability is the #1 household economic anxiety in the country. And it's no surprise why. It's straining family, employer, and government budgets, and it's reducing resources for other critical needs. But it's not only a challenge, it's not sustainable, and it's reaching a breaking point. For decades, US healthcare spending has risen faster than the overall economy and inflation on nearly all other goods and services. And I think we've heard the statistics before, but I'm going to repeat it. The US spends twice as much per person as our peer countries do on healthcare, and we're not utilizing more healthcare, and we're not getting better outcomes. We're simply paying more because of the prices that we're charged, and that's primarily by hospitals and drug companies. And for nonprofit union health plans like ours, hospital and drug prices are the biggest and fastest growing spend. And hospital prices over the last 15 years, you can see that's the blue line at the top, have significantly outpaced. This isn't a recent phenomenon of the last few years. This has been going on for decades, and the delta is getting bigger, have significantly outpaced increases for physician services, prescription drugs, food, housing, and all other items combined. Drug prices are also a tremendous challenge. In the US, we're paying 2.5 to 3.5 times more for prescription drugs than our peer countries. Annual drug price increases typically outpace inflation. And drugs are also entering the market at higher and higher launch prices. In 2008, the median annual cost of a new drug was about $2,000. Now many new drugs are being launched at well over $200,000. GLP-1s are a major new cost driver, and brand name drug prices continue to escalate. There are areas in the drug supply chain that could be improved to bring down costs, but that's not going to stop the primary driver of high drug prices, which is the pharmaceutical companies who set the drug prices and stifle more affordable competition. This is why you often hear concern during the session when there are legislative proposals to mandate coverage of certain drugs. Those proposals are often backed by lobbyists and groups that are funded by the pharmaceutical industry. Mandates provide instant income for the sponsoring pharmaceutical companies rather than requiring those companies make their products competitive and affordable, and they force groups like ours to reduce coverage elsewhere. The impact of these high prices on workers and employers is significant. The average cost of a family premium in the US was nearly $27,000 in 2025, and workers contributed a little over $6,800 of that. That's just the premium. That does not include deductibles, coinsurance, or copays. And this slideshow shows how much increases in the family premium and worker premium contributions have far outpaced wages and inflation growth for decades. In a recent survey, employers pointed to rising drug and hospital costs as the major drivers of their higher healthcare costs. Employers often respond to higher healthcare costs by shifting more of those costs onto workers through higher premiums and other higher out-of-pocket costs. Employers also don't see an end in sight. They think healthcare spending is going to be higher in 2026. There's other drivers of high healthcare prices that we're concerned about. Research has consistently shown that hospital and physician consolidation drives up healthcare prices without improving quality. Consolidation leads to market power that reduces competition and allows hospitals and providers with market power to demand higher and higher prices. And they're able to do it simply because patients and plans like ours, we don't have options to go elsewhere when you're in a highly concentrated market. And our urban markets in Nevada are highly concentrated. 2 large national health systems control 3/4 of the Las Vegas hospital market. And 1 major system has about 2/3 of the Reno hospital market. We've supported legislation in the past that fortunately the legislature has passed a number of these bills to increase transparency and restore competition to our healthcare markets, but still more can be done. And another driver of high healthcare costs are problems with the Federal No Surprises Act. And we really just wanted to flag this with you. This is a little bit of a weedy issue, but we wanted to have it on your radar screen. Nevada passed its own version of the No Surprises Act in 2009 for emergency services, essentially services in emergency rooms. A year later, Congress passed a federal bill. The intent of both of these bills was to stop hospitals and providers from balance billing patients if the patient, through no fault of their own, ended up at an out-of-network hospital or treated by an out-of-network physician. And also the intent of the bills was to stop wasteful out-of-network provider price gouging. Prior to these laws, an out-of-network hospital or provider would bill the patient's plan. The plan would pay what they thought was reasonable, which was usually around a network negotiated rate. And if the provider wanted more, they would balance bill or surprise bill the patient. Both of these bills prohibit that surprise billing of patients. The federal bill did not preempt our state law, but it is broader and includes non-emergency services. Despite all the good intentions of the federal law, lawsuits, primarily driven by large private equity-backed physician groups, have undermined the regulatory guardrails for determining payments between plans at this federal level. And the results have truly been alarming. Providers have flooded the dispute resolution system with nearly 5 million claims since the law was implemented in 2022. The feds had originally estimated that there would be about 17,000 claims a year. 40% of these claims are estimated to be ineligible, but because of flaws in the IDR, the independent dispute resolution system, 20% of those claims are still getting awards. And many of these awards are grossly inflated, 3 to 9 times network rates. This is an incredible waste of precious healthcare dollars. And a majority of these claims have been filed by 4 parties. 3 of them are private equity backed. Georgetown researchers have estimated that the flawed federal dispute resolution system has generated, since its implementation, at least $5 billion in excess costs. So just to wrap up, for nearly 3 decades, we've worked on state-level healthcare policies, including efforts that range from addressing high drug prices to protecting our true safety net hospitals. We look forward to continuing to work with you on these issues and really focusing in on healthcare access and affordability. Now I'd like to turn the presentation over to my colleague, Stacy Sasso from the Health Services Coalition. Thank you.
Good morning, Chair Marzola, committee members. For the record, I'm Stacy Sasso, Executive Director for the Health Services Coalition. Thank you for inviting us to present to you today on the challenges of healthcare access and affordability we and the 300,000 lives we represent face in Southern Nevada. Who's the coalition? We're a nonprofit group located in Southern Nevada that's dedicated to improving the quality, affordability, and accessibility of healthcare for its members in the community. We're comprised of both large and small self-funded employer health plans and collectively bargained union health plans committed to affordable and accessible healthcare in the Silver State. We proudly represent 27 member groups, which combined cover more than 300,000 employees and their dependents, majority of which live throughout Southern Nevada. Nonprofit, self-insured health plans that exist solely to provide high-quality, comprehensive, affordable benefits for our members and their families. Self-funded plans do not pay an insurance company a fixed amount per member per month to provide coverage where the insurance company is at risk. That's known as fully insured. Self-funded union plans are paid for through collectively bargained multi-year agreements with employers to trust that directly pay providers for the health care for their employees. Employers make contributions to the plans, which are jointly run by labor and management trustees, and tailor healthcare coverage to meet the needs of workers in our industries. However, just like Medicaid, all healthcare dollars are extremely limited, and the more that goes towards healthcare means less is available for other critical needs. In the union plan context, the more dollars that need to be allocated to healthcare means less dollars allocated to the wage, on the paycheck, or to retirement funds. We all need to make sure precious healthcare dollars are not squandered and are used to pay fairly for the appropriate level of care. As a coalition, we directly contract with the hospitals for services for our member groups. Every contract cycle, we sit down with the hospital systems and negotiate reimbursement rates. We're in contract with all Southern Nevada acute care hospitals today. The large health systems are listed here. Dignity, Sunrise, and Valley Health Systems are all part of some of the largest national health systems in the country. A particular challenge for us in the Las Vegas area is the growth of extremely expensive care that's not needed, primarily the rapid proliferation of high-cost freestanding emergency rooms and trauma designations without a demonstration of need. The growth of high-cost care can increase profits for large hospital systems, while also driving up healthcare costs for patients and employer and government payers and nonprofit health plans like our member groups. In the Las Vegas area, we've seen the number of FSERs increase from 1 in 2016 to what will be 17 by the end of this year. We first flagged our concerns to the legislature about the rapid growth of these high-cost facilities in the 2019 session. Since then, the number of freestanding emergency rooms has grown 240%, and we're not alone in seeing the impact on their cost of care. The map that's shown shows you the acute care hospitals, which all have emergency departments with an H, and their freestanding ERs marked with a plus sign. They're color-coded by system. Dignity is maroon, Valley blue, HCA is dark pink. As the map shows, hospitals are often building freestanding ERs within a few miles of a competitor's freestanding emergency room or a hospital-based ED, and they're not building them in areas of that are underserved for emergency care, like rural or low-income areas. MedPAC, the independent, nonpartisan agency that analyzes Medicare spending and makes recommendations to Congress, has recognized that freestanding emergency rooms have lower cost structures than hospital EDs, and hospitals often build them in higher income areas where there are already emergency services in order to grow their market share. MedPAC actually recommended that they be paid 30% less if they're within 6 miles of an existing ED. Over the last 6 years, one of our members has seen a more than 250% increase in ER visits with the growth of these FSERs in our community. Much of this is for lower acuity care that could be more affordable for the patient and payer if treated in an urgent care setting. Some systems are investing in the growth of freestanding emergency rooms instead of cost-effective care options like a 24/7 urgent care. Patients do not always realize these facilities are not urgent cares and that they and their health plans will be billed hospital ED rates, draining resources away from care that's truly needed. FSERs are also seeing more lower acuity patients. Many of those patients could be seen far more affordably in an urgent care or primary care setting. We need 24/7 urgent cares. We need primary cares in our community, not expensive freestanding ERs. We've tried to address the impact of freestanding emergency rooms through legislation and contract negotiations for several legislative cycles, and the hospitals have always pushed back and refused to address our concerns in both settings. Another area that we're seeing the growth of extremely expensive care, not based on community need, is the state's recent designation of Sunrise Hospital from a level 2 trauma center to a level 1 trauma center. The state made the designation after Sunrise sued the health district after its Board of Health and 2 of its expert advisory boards had rejected Sunrise's application because the need had not been demonstrated. The Board of Health has actually voted to appeal the court's decision challenging the rejection of the Sunrise application. Ensuring we have a trauma system that's financially stable and meets the needs of patients when they need trauma care is critical for our members and all of our participants. Currently, there are 5 designated trauma centers in Nevada. Renown has a level 2 trauma center in Reno, and in Southern Nevada, UMC is the only standalone level 1 adult pediatric trauma care center west of the Mississippi and has been providing tremendous care for over 3 decades. Sunrise Hospital has a level 2 center. Sienna and O'Callahan have a level 3 center. The Southern Nevada Health District releases annual reports showing our trauma system has consistently met the needs of our community. There are no gaps in care, and we have excellent ambulance transport times. Our position has always been consistent with the nation's leading authority on trauma system expansion, the American College of Surgeons, that trauma center designations should be based on population need, not the desires of powerful hospital corporations seeking economic advantage. Unfortunately, trauma centers can be moneymakers for the hospitals because of high trauma activation fees, which are charged regardless of whether the patient is admitted, and many patients leave the same day. Also, some people think having more trauma centers is automatically better, but the opposite is true. An oversaturation of trauma centers can strain medical resources and financially undermine existing trauma centers. Research shows that trauma centers with high volume have better patient outcomes. We need smart trauma system growth based on demonstrated community need. We need legislative policies that address high and rising healthcare prices. We need appropriate expansion of healthcare services and guardrails to prevent or mitigate the impact of growth of expensive care that is not based on need. We need state policies to ensure health plans have the tools and flexibility to deliver high quality, affordable care to their participants. Some efforts on prior authorization and PBMs go too far and will drive up healthcare costs. Prior authorization should never be used to deny care for the sake of denying care, but has been a useful purpose in preventing fraud and abuse and ensuring patients are getting affordable care that's medically appropriate. PBM reform should not prevent plans from ensuring their participants have access to affordable prescription drugs. State policies should bring overall healthcare costs down, not just shift them around. For example, mandates and copay caps that do not address provider or drug company prices will increase premiums, deductibles, or other out-of-pocket costs, or force plans to reduce benefits elsewhere, or a combination to offset the cost increases. We applaud the state's efforts to address healthcare workforce shortages and urge the state to not only focus on areas with the greatest need, like primary care or mental and behavioral health, but also to track the report workforce investment outcomes by program and site. Are they reducing those shortages? Are those physicians, nurses, and allied healthcare providers staying in our community? We want to thank you for allowing us to present today, and we look forward to ongoing discussion on how we can work to improve healthcare in Nevada. Thank you.
That concludes your presentation. Thank you. Thank you for your presentation and all of the information. We will go to committee members. Are there any questions? Senator Steinbeck?
Thank you, Madam Chair. Question about the trauma centers. I mean, I've always been of the opinion that, us having more capabilities, you mentioned that you thought it kind of degraded the capabilities, but as we get higher designations and additional teaching capabilities within those trauma centers, which is what we get out of a level 1, that's going to be better for our community and bring in additional high-level doctors and providers. And I wanted to get your thoughts on
that. Maya Holmes, for the record, through the chair to Senator Steinbeck.
Go direct.
Go direct. Thank you. Thank you for the question. I think it is a little counterintuitive, but it's been clear in the research that actually you can oversaturate a system with trauma centers, and it is important to have high volume in the trauma centers. Additionally, for more than 20 years, the focus on trauma center, the system in Southern Nevada has focused on it would be expanded when there was a demonstration of need. And I think the concern is also setting a precedent when there hasn't been a demonstration of need. How do you maintain that in the future? Because you don't want to be in a situation, there's interesting research coming out of Arizona, there's been research in Florida where systems have been oversaturated, and it's not been good for the system. Part of it is also just sticking with the principle of there needs to be a demonstration of need to expand the system. I don't, if that answers your question.
It does. I appreciate it. I just think that, more resources are going to be better for our valley, better for our people. I mean, you have that golden hour, right? You have that finite time when you're had significant trauma that you have to get in and get the best care. And certainly that higher level of care does make a better outcome for you as a patient. Understand maybe possible strains on the entire system financially. But when it comes to medical care, more places with more resources is going to be better for you when you're in a car accident or having a heavy traumatic event that you have to have the right staff there at the right time.
Can I follow up? Thank you. I think those are important points. I think the thing is what our data demonstrates is we have excellent transport times. So we are well within the golden hour on our median transport times. And I think it's also thinking about where is trauma care actually needed? Where are the communities where it's actually needed? Are we seeing gaps in those communities? And so the idea is also that you're doing a comprehensive assessment to determine where the actual need is and addressing that need in that community. And that's why 2 expert advisory bodies to the Southern Nevada Health District and the Board of Health rejected the application because there was not a demonstration of need.
Thank you, Madam Chair. Thank you for your answer.
Thank you, Senator.
Committee members, any questions? I don't see any. I don't see any additional questions. I have one question and one comment. Well, first I want to say, I am a big fan of the culinary health insurance. My mom used to be a culinary member. Well, I guess she still is because, she retired from the culinary, but, my dad got cancer, and had it not been for culinary insurance, my family would not have been able to afford the great care that he received because of it. And so thank you. I don't know if I've ever said that. My second, I guess my one question is, so it's my understanding that UMC became a trauma level 1 hospital in 1998. We had about 1.2 million people in Southern Nevada at that time. Today we have almost 3 million. So, from an outsider perspective, obviously, I'm not in your space. We've doubled, essentially, almost. And so tell me what's the part of the demonstration that you have to show in order to go from a level 2 to a level 1 trauma center?
Well, I think it's showing that patients, Maya Holmes for the record. There's been a lot of discussion over the years at the health district and within the Regional Trauma Advisory Board, which I'm the payer representative on. It's looking at transport times. Are transport times growing? Are they exceeding what would be appropriate? They're not, and they've grown a tiny bit, but it's not been significant. Are patient needs not being met? The Trauma Medical Advisory Committee does an annual thing every year, and they've indicated the trauma system is meeting community needs. I think the other thing is also realizing, we're fortunate as a community because, as Stacy had mentioned in her comments, UMC is like the only standalone. It's actually a standalone trauma center, and it's a larger scale trauma center. So I think just looking at a number of a trauma center versus looking at what is the individual capacity of each of those trauma centers and what they're providing. But a lot of it is, again, the Southern Nevada Health District puts out an annual report. It's like over, I think it's 60 or 70 pages where they're documenting. And the report has not indicated that we have gaps in services, that our trauma system is meeting the needs of the community, and it's grown within those hospitals to meet the needs of the community as the population has grown.
Thank you so much for that answer.
And also, I just wanted to say thank you for sharing on your family. And we really, I mean, we're very proud of the benefits we're able to provide. And I know I've worked for the culinary, I had originally worked for the culinary union starting in 2003 before switching to the fund in 18. And the health benefits they're a massive priority for our participants. And so in contract negotiations and new organizing, health benefits are always, because a lot of these folks are coming from, you know, other parts of the country in this industry where these types of benefits don't exist. And so they know how important it is to know that I can take care of my spouse, I can take care of my kids if they get sick and need help. So, but thank you.
Assemblymember Miller.
Thank you, Chair. I'm not even sure if this was more of a comment or a consideration or a question, but in the data when it talks about, we're always talking about there's this many people in Southern Nevada, this many, you know, community members and residents, but we also have to be aware that on any given day, we could have hundreds of thousands, if not another million people who are here visiting our strip and all the rest of the corridor. So are those numbers taken into account when adding our residents as well as say another million people? Because again, we had a catastrophic event here, and I know we're doing everything to prevent that again, but in those situations, do we have the capacity?
Maya Holmes, for the record. I mean, I think we have demonstrated in the past. I mean, the hospitals should probably weigh in on this, but my understanding is when we have had, you know, whether it was October 1 or other significant events, we have had the capacity. And I think it's also when you think about the trauma system, our trauma system in Southern Nevada is an inclusive trauma system. So it includes all the hospitals as well as the trauma centers, which is, I think, what you want. You want the ERs, you want appropriate triage and, you know, folks to be able to go to ERs and get care, but then also those that need the higher level of care to get to the trauma centers. And to your earlier question of the report does take into account all trauma patients that are visiting, regardless of whether they're in-state, out-of-state. You know, those numbers are all in there. But thank you for the question.
Thank you so much.
Committee members, any additional questions? I don't see any. Thank you so much for being with us today and presenting. We do really appreciate it. We will move to our next presentation. With us today is Stacy Sasso. Oh, sorry. It's already a long day. I'm going to start over. Our next presentation is AHIP and Nevada Association of Health Plans. I saw you guys get up and then sit back down. Welcome. You may begin when you're ready. Please remember to stay and spell your name for the record.
Good morning, Chair Ms. Marzola and distinguished members of the committee. My name is Annie Mooney, A-N-N-I-E M-O-O-N-E-Y, and I serve as Western Regional Director for State Affairs at AHIP, the National Trade Association representing health insurance providers. Thank you for the opportunity to testify today on health insurance and affordability in Nevada. We look forward to productive ongoing engagement on this critical issue. This morning, I'm co-presenting in partnership with the Nevada Association of Health Plans. Shelley?
Good morning, Shelley Capurro, SHELLY-CAPURRO, representing the Nevada Association of Health Plans, which is a 12-member organization with both commercial and public plans.
Great. Since you may be unaware of AHIP, I will share a brief word about our organization. We are the National Association representing health insurance providers across every segment of the market. Our members provide coverage to hundreds of millions of Americans through employer-sponsored plans, individual market products, Medicare Advantage, Medicaid, managed care, and military coverage. Our mission is to advance solutions that expand access to affordable, high-quality health care. We believe strongly that coverage should work for all consumers. And with that context, let me walk through today's agenda. Our testimony will cover 5 key areas. We will begin with an overview of how insurance and premiums are developed. We will then discuss the regulatory framework that governs health plans. From there, we will address the specific cost drivers shaping 2026 premiums, followed by a look at Nevada's coverage landscape. We will conclude with affordability concerns and solutions we support. At its core, health insurance serves 2 fundamental purposes: financing future healthcare expenses and protecting individuals from catastrophic medical costs. What is essential to know is that health plans negotiate lower prices for medical care and prescription drugs on behalf of the individuals they cover. This negotiating function is central to the value health plans provide. Importantly, health insurance costs are not arbitrary. They must be actuarially justified, meaning a certified actuary must verify that premiums reflect the actual cost of delivering the coverage being purchased. The principle is straightforward. Inputs must equal outputs. Premiums are a direct reflection of the underlying cost of medical care and prescription drugs. When those costs rise, premiums follow. Now let me illustrate the scope of what health plans manage. Health insurance providers maintain a 360-degree view of patient care. On the medical side, plans coordinate physician services, hospital care, specialty referrals, and preventative services. On the pharmacy side, they manage prescription drug benefits, formulary design, and pharmacy networks. At the center of this model is the customer. Everything health plans do, from network design to care coordination, is oriented around ensuring that patients receive the right care at the right time. Turning now to oversight, let us discuss how the system is regulated. State regulators review and approve the rates health plans charge, the products they offer, the adequacy of their provider network, and their administrative costs. Regulators also oversee financial solvency, company licensing, consumer complaints, and broker conduct. I want to emphasize a critical point. Health plans are the only entity in the entire healthcare delivery system whose prices are reviewed and approved by regulators. Those prices are regulated on the front end with rate review and approval, and the back end when the price isn't right, health plans pursuant to the medical loss ratio rebate dollars back to policyholders. No other provider, hospital, or pharmaceutical company requires this level of scrutiny. Now let me show you where your healthcare dollar goes. This visual illustrates the breakdown of your healthcare dollar. As you can see, the vast majority of premium dollars go directly to pay for medical care and prescription drugs. Only a fraction is retained by health plans for administrative functions. This is not a matter of choice. It is required by federal law through the medical loss ratio standard, which I will detail on the next slide. Under the Affordable Care Act's medical loss ratio requirements, large group health plans must spend at least 85% of premium revenue on medical care and quality improvement. For small groups and individual plans, that threshold is 80%. The remaining 15 to 20% covers all administrative functions: customer service, digital tools, provider engagement, pharmacy benefit management, fraud prevention, regulatory compliance, broker commissions, claims processing, and operating costs. If a plan fails to meet these thresholds, it must issue rebates back to customers. This is a critical framework because it ensures that the overwhelming majority of every premium dollar is directed toward patient care. With that foundation, let me turn to the driving factors of 2026 premiums. First, the expiration of the enhanced premium tax credits creates substantial uncertainty for marketplace employees. Second, the Marketplace Integrity and Affordability Rule has introduced new regulatory dynamics. Third, increased overall uncertainty in federal health policy is making it more difficult for actuaries to price risk accordingly. Fourth, prescription drug spending continues to climb, driven by specialty drugs and new therapies. Fifth, state-specific factors, including benefit mandates and regulatory requirements, contribute to premium variation. And sixth, alternative financing agreements for small employers are fragmenting risk pools. Before we end this section, I would like to direct you to the American Academy of Actuaries issue brief that is cited on this slide for additional technical detail. I'm now going to turn our presentation over to Shelley, who will share the impact specific to Nevada.
Good morning again, Shelley Capro for the record. In breaking down how Nevadans are covered, 52% are covered with private insurance, such as individual, small group, and large group, and self-funded ERISA plans. ERISA plans, instead of the healthcare costs being transferred to an insurance company, the employers keep the risk themselves. In Nevada, our data shows that 21% make up Medicaid, 15% Medicare, and 11% of Nevadans are uninsured. Of those insured Nevadans who are insured through an employer, 51% are considered fully insured and 49% are those ERISA plans. Over 100,000 Nevadans found their insurance on the Silver State Exchange currently. Nevada health insurance companies are good employers in the state of Nevada, with almost 3,500 employees employed with insurers, and there are over 10,000 insurance-related jobs in the state. One example would be insurance brokers. All of these are good-paying jobs in Nevada. AHIP does have 2 white paper documents on some of the issues I've just discussed. Next slide. I want to talk about the managed care organizations, the MCOs. These are insurers who contract with the state. It's hard to currently estimate the true impact to Nevada with the HR 1, the big beautiful bill. I know that the Nevada Health Authority is still looking for more guidance, but some of the figures we have on here may be high, but it could be up to this amount. The Nevada Health Authority has been working with the MCOs on trying to figure out how we're going to move forward with this. There will be less funding for the state. There are going to be administrative changes to how the benefits are accessed, and the requirements to those receiving the benefits are also being changed. The importance of MCOs are, 39% of who are on the MCOs right now, 39% of those are children. The MCOs improve access to and quality of care for millions of Americans, and including Nevadans. MCOs improve the health outcomes through tailored care coordination. This flexibility allows for new and innovative approaches to address complex conditions, including referrals and connecting patients to appropriate resources, such as mental health support. It's the states that determine reimbursement rates, provider contracts, incentives for quality standards, and social needs. We do have a document, through AHIP that can help with this too. Next slide. So affordability is the top priority for AHIP and the Nevada Association of Health Plans. Some of the key cost drivers in our data is that hospital spending has accounted for 40% of national health spending growth between 2022 and 2024. Facility fees represent another cost. Consumers will pay a higher price for identical services, whether they are delivered in a hospital outpatient setting or in a physician's office. Research from Georgetown and Health Affairs confirms this. The facility fee reform could provide meaningful out-of-pocket relief without jeopardizing hospital financial health. On prescription drugs, in January, it was reported that manufacturers raised prices on 350 medicines at the start of this year, and the pharmaceutical industry's profit margins remain up to 10 times greater than other sectors of the drug supply chain. And finally, the independent dispute resolution system has shown to add $5 billion to the overall health system cost. These are factors that are driving premiums higher. And again, we can provide information on any of these.
Annie Mooney for the record. The most effective path to improving healthcare affordability is policy action that increases competition and transparency, especially in hospital services and pharmaceutical pricing, while enforcing existing consumer protections. In plain terms, costs will come down if policymakers increase competition, stop anti-competitive hospital and drug pricing, standardize pricing, meaning same service, same price, regardless of the setting, improve transparency through drug pricing and rebate flows, and strengthen protections by enforcing surprise billing rules. These are the core levers that we are highlighting to directly address the main drivers of rising premiums.
In closing, we would like to thank Chair Marzola for bringing all of us together today. We feel that this is an important issue that needs to be discussed. We also feel that all aspects of healthcare, if we bring them together, is the only way that the needle is going to move for Nevadans. And with that, we can take any questions. Thank you.
I'm always fighting with my microphone. Thank you for your presentation. Committee members, are there any questions? Senator Steinbeck.
Thank you for your presentation. And you had some excellent graphs there, and I kept taking pictures because I want to look through them a little bit more. On the one, you were explaining the costs of where a dollar of healthcare, your health insurance dollar goes to. I was wondering if you broke out the part that goes to the insurance company, but within that, can you tell exactly how much of the cost goes from the staff of the doctors in the hospitals that have to interact back to the insurance companies? Was that included back on the medical costs, or is that included in the insurance costs?
I don't know the answer to that question, but we can get with AHIP and look into that and get back to the whole committee on that.
Okay, thank you. Because when you go to a doctor's office, hospital, there's a tremendous amount of staff that's just dedicated back towards payments, right? Just dedicated towards approvals. That's dedicated towards getting the doctors paid. And I'm curious about those costs and what we can do to kind of streamline some of that, right? I mean, I'm not talking about necessary legislation here, but everybody in this room has had where they have to call the insurance company multiple times to try to get something paid. And then you call the doctor's office, they're like, oh, no, we submitted that. And then the insurance company says, I mean, you guys have, right? I mean, everybody has dealt with that. And I just want to get maybe your ideas on how we can improve that for Nevadans, because you hear it from your constituents quite a bit. Thank you, Chair.
From Annie Mooney, for the record, from the perspective of administrative costs, one of the things that AHIP is advocating for across the board is that all prior auths, for example, and other administrative documents be transferred by computer rather than by fax. You would be quite surprised at how many offices still use fax. And we believe that we could get quicker answers and get things addressed more directly if we didn't have to go through fax. Secondly, I think that by using electronic submissions, you would have the ability to complete a more complete form, because the majority of, let's say, denied prior authorizations have to do with incomplete forms that are submitted to the insurance companies. It could be something as small as a box wasn't checked, and it will be kicked out because that's not a completed form. So we really think that using electronics will really be a game changer, both in speed and in cost.
Assemblymember Kasama. Actually, before we go to you, I apologize. Senator Flores.
Thank you, Madam Chair. And I know that any one of these slides we can spend a lot of time on. I'm looking at the second to last solutions for affordable care. Just curious to know, in the patent abuse that you highlight there, if you've seen, I understand that a lot of these conversations are happening at the federal level, but have you seen states who have attempted to proactively go after some of these issues, and how are they addressing that at the state level? And please feel free to, walk me through it, because I am not the patent expert in it. So please, all the education is welcome.
So Annie is shaking her head yes, that there has been some things done in other states. So
Can you state your name for the record?
Oh, sorry, Shelley Capro for the record. So I think what we should do is look into that for you and try and get a list of which states and what has been done and send that to the committee.
We'd be happy to do so, because as a national, Annie Mooney, for the record, we'd be happy to do so because as a national trade association, we collect data from all of our states, including legislation that has been passed, that is pending, that is coming up, to be able to look at how they are problem solving.
Madam Chair, if I may have a quick follow-up. Yeah, I'm curious to know, because that would be an interesting conversation, that we see a patent abuse in you see an increase of generics in one state versus another, or something like that. So that, I think, would be a very fascinating conversation to understand how that even works. So thank you.
Thank you for your question. Annie Mooney, Annie Mooney, thank you for your question. And all of the documents that are linked to this presentation or anything else that you need from us, we're very happy to prepare and to share with you.
Assemblymember Kasama.
Thank you. Just kind of following up on your comment on electronic submission, which seems like such a simple thing we should be able to be doing now. What do you think is the major obstacle between providers or hospitals or, across all the groups for that not being implemented across the board?
I think sometimes it is easy to think about healthcare as a big machine, but when you think about doctors' offices, many of them are really small. Many of them run on a really tight margin. They don't have the ability to become more sophisticated, whether it's financially or whether it is staff. And I think that that's a big part of it.
Sorry, another thing is they all have different types of software that they use, and they don't connect a lot of times. So it's not just as simple where you require everyone. I mean, I'm sure it's doable, but there's just everyone uses different types of systems.
It seems to me most of these systems would be web-based, so you wouldn't require additional software and training. It seems to me if you have staff that can fill out a form, can fill out an on-screen. So I guess I'm still a little confused as to why there's impediments, or is it just because people don't want to change, or could you make that a requirement to speed up the process? I'd just like to hear a little bit more expansion on that.
You could. I do think some of it is the cost, especially like Annie said, some of these doctors' offices are very small. So when you do have costs, but like you said, if it's a web-based, I don't know, but we can look into that.
It seems like something we could all support to help drive down costs and efficiency. Thank you.
Committee members, any additional questions? I don't see, I have a couple of questions, or a question and an ask. So on your slide 13, where you talk about enforcing surprise medical billing protections and addressing abuses by some private equity-backed providers, do you have a list of who the abusers are? And if so, are you able to provide it to the committee?
In which aspect was that? Sorry.
That's okay. Slide 13, solutions for affordable care.
I can look into that.
Okay. Because
yes.
Okay. Because you guys stated in your PowerPoint, and so I'm wondering who are those private equity providers that obviously is abusing our system, and if you have that list, if you can please provide it.
Absolutely.
Thank you.
Additionally, that would also be something that we would reach out to state regulators about as well.
Perfect. Thank you so much. So now let's go to slide, sorry, I ripped all of my 7. Where does your healthcare dollars go? So you talked about 24.2 cents go towards prescription drugs. Does that include and take into account rebates that drug manufacturers provide?
Would like to be able to, Annie Mooney for the record, I would like to be able to provide you with more in-depth breakout of what that includes. As you know, with pharmacy rebates and coupons, it all becomes pretty messy. And so for me to most appropriately and efficiently provide you with your answer, I'd really like to be able to share the nuances and the breakouts, and I can do them for the rest of these as well.
Perfect. So my ask then is, does it include the rebates from the drug manufacturer? And if it does not, why not? So if you can answer those questions. Thank you.
Thank you.
Committee members, is that? I don't see any other questions. Thank you so much.
Thank you
for your presentation.
Thank you for the opportunity to speak with you today.
Our next presentation today is from AXME on the Public Employees Benefit Program and Healthcare Quality and Costs for State Workers. Good morning. Thank you for being with us today. You may begin when you're ready.
Good morning, Chair, members of the committee. My name is Cassie Charles. I'm the political representative for AFSCME, the American Federation of State, County, and Municipal Employees here in Nevada. And want to give my partner a moment to introduce herself as well.
Thank you. Thank you for allowing us to come to this committee today. I'm Tess Opperman, and I represent the AFSCME retirees.
We're here to talk today specifically about the member perspective of PEB increases, and just the general health costs for our active and retiree members. A brief overview of AFSCME Local 4041. We represent a very wide variety of workers. Our union is made up of nurses, social workers, technicians, and a dozen more specialties that provide essential public services and keep our great state running. With such a wide variety of membership, we are always searching for commonalities between departments, agencies, and offices. And one commonality has been clear. State workers in every office, every county, are struggling to afford their health care. This July, costs for a large portion of state workers will increase by upwards of 15%. Some workers are preparing to see their premiums increase by over $200 a month, on top of a $1,000 increase to the out-of-pocket maximums on all plans. This will be the first of 3 rounds of increases, with increases of similar sizes expected in July of fiscal year 28 and 29. Unfortunately, this is not a new reality for state workers. Increasing costs for health premiums and the slow degradation of coverage has continuously been a burden put on our state workers. Since fiscal year 24, we've seen a steady premium increase, with some plans have been increased by 134%. As you can see on the slide for you, we have 3 plan options for our state workers. The PEB board was fortunately able to prevent recent increases to the consumer-driven health plan, the CDHP, which is meant to be the lowest cost plan, and many of our lowest paid state workers rely on this plan for themselves and their families. However, as you can expect, this plan has the lowest amount of coverage for things like medications, hospital stays, ER visits. During the open enrollment period, we are actually currently in the open enrollment period for state workers. It's expected that we will see many workers transition to this plan because of the lower premiums, even if it has a higher out-of-pocket cost for regular care. Right now, many state workers will actively choose lower quality care because of the financial constraints of the growing cost of living. I think we're all very aware of how expensive groceries, rent, gas is currently, and our state workers are absolutely feeling it. This is significant specifically for family coverage. When you take into account pension contributions, a member earning around $65,000 would likely face significant challenge in managing both the monthly premium and out-of-pocket costs for most of the plans in front of you. As you can see on the chart, the premium increase chart, family premiums are significantly higher, particularly on the EPO and HMO plans. We've heard from many families, and especially single parents, that they are getting priced out of their coverage. On top of the growing cost of living in our state, I want to recognize the financial constraints specifically associated with being a state worker. Between PEB and PERS costs, state workers are cost burdened and are struggling to stay in state service. On the slide, we've broken down the reality of PERS and overall pay for many workers. This chart follows a salary scale of a worker in grade 32 in step 1. This represents hundreds of workers across our state right now. This worker also began in fiscal year 24. This chart breaks down the approximate average salary for the worker, considering the cost of living adjustments, both bargained for by the union and annual step increases. As you can see, PERS costs members 19.25% of their monthly paychecks right now. Additionally, from fiscal year 25 and fiscal year 26, workers actually saw a reduction in their gross monthly pay due to the underfunding of bargaining agreements last legislative session. The costs of PERS and PEB benefits are increasing at a far faster rate than salary increases. While the conversation today, of course, is about healthcare, I want to ensure that we're looking at the reality of being a state worker holistically. Because when we do, we can estimate for this hypothetical worker, after PERS, after taxes, after the cost of the premiums for their family, it is very likely that this worker is seeing bi-monthly paychecks less than $2,000 a month. And I think we can all recognize that that is quite unaffordable in today's economy. With the growing cost of living in Nevada, this leads to many of our state workers holding second jobs, picking up double shifts, and in many cases seeking different job with better benefits. Regarding their healthcare specifically, increased cost of care pushes more workers to prolong time between care and in some cases go without care completely. In the current economic environment, an unexpected $750 ER visit, a $2,000 hospital stay would be very difficult for many families to manage because premium increases have eaten so specifically into their pay growth. I have heard stories from members who are no longer able to afford daycare for their children and the ability to care for their elderly parents. As a state, we need to offer a more competitive benefits package to be able to retain our state workers who greatly enjoy their state service and serving our Nevada communities.
Thank you again, Tess Opperman for the record. And I'm going to present on some of the challenges faced by the AFSCME retirees. So to give you just a very brief idea of the AFSCME retirees, we were created in 1998, the Nevada chapter. We've got about 900 members. We're chapter number 4041, and we operate actually separately from the actives, though we work together quite a bit. And as you know, we've presented a number of bills together, but we are our own separate chapter. We are very active at the legislature. We work to protect the healthcare benefits of our retirees, many of whom worked for the state for 30 plus years, and want to make sure that their healthcare benefits, they continue to get those throughout their retirement. So with that, I'll go into some of the challenges that our retirees are facing. And I will admit these comments might sound somewhat repetitive. I think I've been telling this body about some of the challenges faced by our retirees for a number of sessions now. And so I apologize for the repetitive nature of it, but also they continue to face the same challenges. You all passed AB 188 last session. That bill would have been a really, really big win for our retirees. So we appreciate your efforts working on that and passing that for us. That said, unfortunately, it was vetoed. So we're back at square one, and we're here to tell you about some of those same challenges that we continue to face and truly only get worse year after year as healthcare costs increase. So for a very, very brief history, in 2011, in budget cuts, they decided to move retirees off of the PEB plan and put them onto Medicare. So it was cost savings to PEB to shift those retirees onto the Medicare plan. However, our retirees who worked for their state the entire time of their employment, they were promised healthcare coverage. So during this shift, when they were put onto Medicare, the state said, no problem, we'll create something called the Health Reimbursement Arrangement Account. And so they would work through via benefits, that's contracted by PEB. They work through via benefits to get their Medicare coverage, and then they have the Health Reimbursement Arrangement Account to help cover some additional payments that would come out of their pockets, so that all of their healthcare costs would be covered. Unfortunately, that Health Reimbursement Arrangement Account hasn't increased over the years. So now our retirees are facing a couple of challenges, and I list some of those out here. I list the first is challenges with VIA benefits, and I think that is getting a little bit better. I've heard from my members that some of the communication with VIA is getting better. However, over the years, it's been really difficult. Our retirees will call via benefits and not get a hold of anyone who understands the health reimbursement arrangement. And so then they don't know how to get the health reimbursement arrangement, either through PEB or through via benefits. So there's been a lot of challenges with communication. I know the Nevada Health Authority is aware of this struggle that our retirees have had, and I think they've been working to help make that communication a little bit better, and we appreciate all of those efforts. The next piece, and I just put this on the list because it's something we've talked a lot about, the coverage for pre-Medicare retirees. So I talked about that change in 2011. When they made that shift, they also took away pre-Medicare coverage for retirees. So if a retiree retires at 62, they don't have healthcare coverage until 65. This has been a big topic of conversation. We would love to see those retirees get that coverage back before 2011. They would have been covered for that interim timeframe between retirement and when they got Medicare coverage. The next thing, and I talk over and over again about the health reimbursement arrangement. So this is that supplemental account that is supposed to help cover Medicare Part B, supplemental plans, dental, vision, prescription drugs, and copays. We know all of those total a lot. My next slide will have some details on those numbers. That health reimbursement arrangement, it's calculated at $13 per month per year worked. So if someone has worked up to 20 years work. So for a retiree who worked for 20 years or more for the state of Nevada, then they get $13 per year worked. That's 20 years. That would be $260 a month that they get through their health reimbursement arrangement. And that's what they can use to put towards all of these additional costs that they face for their health care. Now, remember, in 2011, the idea of this health reimbursement arrangement is that it was supposed to cover all of their healthcare costs, because for 30 years, when they worked for the state, they were told all of your healthcare would be covered. This is a benefit you get for working for the state of Nevada. We know that our wages are lower. At least we will cover your healthcare. I'm going to go into this next slide to give you a sense of what those costs look like for some of our retirees today. So right before the last legislative session, so it's about 2 years ago now, we did a survey of our members to get a sense of how much money most of them were getting from their health reimbursement arrangement, and then what their costs looked like. So the average that our retirees receive is about $244 a month from that health reimbursement arrangement. And then here's the cost that they face. So the Medicare Part B premium would be $202. The dental is $55. Medicare Part D average, that's prescription drugs, the average there is $34. And then Medigap plans, those vary greatly. Retirees, when they go on to Medicare, they can choose which Medigap plan they want to have. So the costs there vary quite a bit. So you see $100 to $300. But the total there is $391 on average. And that's, as we know, significantly more than what the HRA is, the maximum HRA being $260. So that $391 is one of an average that we've gotten an idea of. I will say, and I'll go into this a little bit more, one of the challenges we're facing is that because it's via benefits that does all of this for our retirees, they help set up the Medigap plans, help them get on Medicare. It means that we don't have a good idea of the exact costs faced by our retirees. So one of the things, this was something that was part of AB 188, and we're actually grateful despite AB 188 being vetoed. I know that PEB is working on this, but doing a cost comparison study so that we can see exactly what our Medicare retirees, the costs faced by our Medicare retirees in comparison to non-Medicare retirees. So really the ask being that those who are, there's the group of retirees that are pre-Medicare, and then there's a very small group of Medicare retirees, non-Medicare retirees that are not on Medicare and are still covered by PEB. We want to make sure that the costs faced by those retirees are roughly equivalent to our Medicare retirees. So I know PEB is working on a cost comparison study. We haven't seen that data yet, but they're working with Via Benefits, and we really look forward to getting the numbers back from PEB so that we all can have a much better idea. I give some of these numbers from our survey, but this was just an internal survey done of our members. I don't think this is reflective of the entire body. And so we would love the support of PEB and the support of you to get some better numbers so that we can really look at that and know, hey, exactly how much our Medicare retirees are paying out of pocket for all of their healthcare costs. So one, I just want to give you a case study. Roberta, she was one of the respondents to our survey and said she was happy to let us share this information. So a quote she said, our premiums keep going up every year, but the reimbursement of $260 hasn't at all. So Roberta worked for the state of Nevada for 30 years and receives the maximum HRA of $260. However, between Medicare Part B, her supplemental plan, dental, prescription drugs, and other miscellaneous expenses, she is spending a total of $550 a month. This means after her HRA, she is paying about $290 out of pocket monthly, and this amount will continue to increase each year. So I know that is quite the deep dive into the HRA, but this is why my members every single session come back time and time again and ask for an increase to that HRA. It has gone up one time in 2015. It went from $11 to $13. And since 2015, it has not increased at all. And we all know how much healthcare costs have increased over the last 10 years. So we're hoping that in the next legislative session, I know that money is always a topic, and our AFSCME actives are facing some really major increases, but we also ask that the retirees are kept in mind, and we think about that HRA amount and the monthly amount they get.
Great. And so going into some of our policy ideas here, I want to thank the members of this committee who have had really robust conversations around this. I do know that we have 4 ideas on the slide here, but there are many solutions to improving the cost and quality of healthcare for both our retirees and for our actives. And so I want to ensure that we're looking at policy ideas for our active workers in 3 different ways. 1, how do we address the system of healthcare as a whole, with corporate health costs increasing costs across the nation and the impacts of HR1? 2, how do we give state workers more agency in the decisions regarding their own healthcare and their own health plans? And 3, how do we reduce the cost of healthcare for state workers overall? And so our first policy gets at the first piece here, which is looking at the system of healthcare as a whole. And this would be implementing hospital reference-based pricing. The state of Oregon reported over $100 million in cost savings in 2021 after establishing their cap at 200% of Medicare rates for in-network care and 150% of Medicare rates for out-of-pocket care. Montana has also instituted reference-based pricing and seen great benefits. I do want to acknowledge that Assemblyman Orentlicker introduced a similar bill to this in the last legislative session, and we had very productive conversations with him over this bill as well, especially as we see our workers in Oregon seeing great and tremendous benefits because of this policy implementation. The second policy solution that we see is amending NRS 2 Chapter 288 to include healthcare as a mandatory subject of bargaining for state workers. When collective bargaining for state workers was passed in 2019, healthcare was left off of the list of mandatory subjects of bargaining. This would bring state workers more agency in their ability to advocate for benefits that matter for them and their families. Finally, Nevada is well behind the national average in cost share for overall premium costs for state workers. State workers across the nation average at 20% employee contributions for premium costs. And right now, fiscal year 26, before the increases in July, every coverage tier for the EPO, HMO are well over 20% in employee contribution rate, as well as 2 tiers of the LDPPO and the family tier of the CDHP. I'm looking ahead, jumping ahead a little bit into the PEB presentation. I know that they'll go over these cost share percentages as well, but I do want to ensure that it is recognized that the national average here is 20% of the cost share on the employee. We bring the solution forward to cap the employee contributions at 20% because we cannot continue to shift the burden onto workers rather than working to tackle the underlying cost drivers here. I know that there are several policy solutions to tackle these underlying cost drivers. We just have to bring those forward and really tackle and have honest conversations about what it looks like for state workers in Nevada. On average, our workers are paying between 5 to 20% of their overall gross pay into premiums. On top of the pension contributions that we had mentioned earlier, these costs continue to contribute to higher turnover rate and the continued vacancy rate that we see at this state.
My members, my retirees, are quite clear that their single main most important ask is an increase to that health reimbursement arrangement. And tied to that, we ask for any support with PEB completing the cost comparison study so that this body and we all have a much better idea of exactly what those costs are that our Medicare retirees are facing in comparison to the non-Medicare retirees. So with that, thank you so much for your time this morning and for allowing us to present to you. We are open to questions.
Thank you for your presentation. Before I pass it to committee members, you said that healthcare was left off the table. Why is that?
Cassie Charles for the record. Thank you so much for this question. I was not privy to those conversations in 2019. I was not with the organization. I know that there was a long negotiation process in how we landed on what were the mandatory subjects of bargaining. I can absolutely get some more clear answers on that, but I know it was part of a long negotiation process.
Thank you for that answer. Yes, if you can get me that information, I have a lot of asks today, and you can provide it to the entire committee.
Absolutely.
Committee members, Assemblymember Roth.
Thank you, and thank you for the presentation. I don't know if you would have these numbers, but what I'm curious is if we know, when I talk to state workers, I'm hearing a lot from workers who are accessing services such as food stamps and other services from the state, and that cost is being borne by the state. And so do we know, have the number of state workers who are now accessing those kind of services such as food stamps or other services like that, has that increased since these changes and the rising costs of healthcare? Is that something we're seeing downstream?
Yes, absolutely. Cassie Charles for the record. Thank you so much for this question. We're currently conducting an internal poll on how many of our members are accessing state services. I would like to recognize just how critical it is that we have this robust conversation over the amount of our state workers that are relying on SNAP services. Many of our workers who do our SNAP eligibility find themselves within eligibility as they are doing the process for our community workers. And with the increases, especially from the PEB increases and the PERS cost increases, we are absolutely expecting to see more of our state workers relying on SNAP services. Yes.
Assemblymember Kusama.
Thank you, Chair. Thank you for all the information. I guess my question is, it's always concerning, to hear that we have certainly implied or said we're going to cover so much cost for retirees and we're not able to keep up with it. And we have budget constraints. We know healthcare costs are rising, so it puts tremendous pressure on everybody. My question is, I guess that we know will continue. So if a state employee is hired new today, are those promises still made? Or for a new state employee, is it said, we will contribute to your healthcare costs when you're retired? I'm just wondering how we're adjusting for this continued growth in healthcare costs and the impact it has on our state budget.
Tess Opperman for the record. I appreciate that question. And I don't know exactly what because I'm only covering our retirees now, I don't know what the promises are that are being made to those working for the state at the moment. So I'm going to look into that. I don't have that answer for you right now.
Thank you. Yeah, that'd be great to know. Thank you.
Committee members, any additional questions? Senator Ellison, do you have any questions?
Yes, thank you, ma'am. I had a question a while back from some of the people that received PERS in here in Nevada. And one of the questions was asked was, where does Nevada stand like other states? And I says, I have no idea if it's a nationwide formula or is it different. Could either one of the ladies answer that question?
Yes, Cassie Charles for the record. Thank you so much for this question, Senator Ellison. We stand quite higher than the national average in PERS contribution rates. 20%, nearly 20% is nearly unheard of across the country. We have workers across the state seeing 3 to 5% contribution rates. And we also want to compare this to our localities. It is very clear at the state or at the city and the county levels in our own state, the state workers are paying a far higher contribution rate than our public service workers at the state and local municipalities. Right now, as it stands, those workers are paying 0 to 5% into the PERS contribution percentage. And so as we can look into other states, I also want to ensure we're looking at our own as well. Thank you.
Thank you very much.
Any additional questions, Senator?
No, ma'am. I appreciate that. I could get that back to my colleagues that is asking that question. It's good to know that Elko's or Nevada's that high. So thank you.
Any additional questions, committee members? I don't think so. Thank you so much for your presentation today. It's always sad to see how, whether you're a state worker or a senior, anyone in a fixed income, how you have to pick whether you pay for your deductibles, your health insurance, your, food to feed your family. I don't know how in 2026 we're still here and it's gotten a lot worse, right? I'm gonna put this on the record just so I can make this real to some folks. I had a 90-year-old constituent who is in a fixed income, who is hard of hearing and whose hearing aid went out. He literally can't hear and lives on his own. He was stuck in his healthcare system and needed a copay of $2,000 to get new hearing aids. How was he going to do that? He wouldn't have been able to eat for the entire month. That's someone who is lost in our system. This shouldn't be happening to Nevadans. I had another constituent who was not my constituent, not sure how she got my number, who was trying to figure out, should she pay for her prescription? And if she did, she wasn't going to be able to eat for the month. How is that still happening in 2026 in the state of Nevada? And so again, when you're doing the presentations here in front of our committee, first and foremost, the most important thing I want you to keep in mind is affordability and how it hits every Nevada home. Thank you again for your presentation. We will move to our next presentation. We have HCA Healthcare presenting on Sunrise Health System. Welcome. You may begin when you're ready.
Clicks with the green. Yeah. Good morning, Chair, members of the committee. Connor Kane, CONNORCAIN, Director of Government Relations for HCA Healthcare's Far West Division. I'd like to quickly say a few unplanned remarks about Sunrise Hospital before we begin our presentation. And again, these remarks are unplanned, so bear with me as I read through my chicken scratch notes. Sunrise was verified as a level 1 trauma center by the American College of Surgeons following a rigorous examination. We followed the statutory process outlined in Nevada revised statutes, which at one juncture included a legal appeal, and were recently formally designated as a level 1 trauma center by the state of Nevada. We are incredibly proud to be recognized for teaching, research, and providing care at the very highest level. I am personally even more proud that we're doing this at the state's largest safety net hospital, caring for almost 1 in 5 Medicaid recipients in the state, and a facility whose doctors and nurses demonstrated on October 1st, treating 125 gunshot victims with only 1 patient who arrived with a pulse and did not walk out of the facility, that they are the best of the best and show up for our entire community. Now back to the planned remarks. Fortunately for you, and especially for my colleagues sitting at the table beside me, this is likely the most you'll hear me speak this morning. With that being said, I'd like to briefly introduce our Division President, Jackie Van Blaricum, and our Division Chief Medical Officer, Dr. Jeff Morawski. Ms. Van Blaricum will deliver a 10-minute presentation on our efforts to improve healthcare access and affordability. And Dr. Morawski will be on standby for any clinically focused questions. I'd now like to turn the floor over to Ms. Van Blaricum.
Thank you, Connor. And good morning, Chair and members of the committee. Thank you for the opportunity to be here today. As Connor mentioned, my name is Jackie Van Blaricum, JACKIE-VANBLARICUM, and I serve as the president of HCA's Healthcare's Far West Division. Today, I'd like to share how we're working to improve healthcare access and affordability for Nevadans, and how we can continue partnering with you and other state leaders to strengthen our system, even as we face challenging Medicaid coverage and funding headwinds. I'd like to begin with our core priorities for 2026, optimizing our network, creating access, driving down costs, and workforce development. These core priorities empower us to provide access to exceptional clinical care close to home and position us to meet the needs of our growing community in the future. Expanding access. I'd like to begin with how we currently provide and are expanding access to care. When most people think about HCA or Sunrise Health System in Nevada, they think about 4 hospitals: Southern Hills, Mountain View, Sunrise, and Sunrise Children's, which continue to grow and provide world-class care when our community needs it most. Our hospitals operate 7 freestanding emergency departments, fully functioning emergency rooms with the same doctors and nurses, equipment, and capabilities as our hospital-based emergency rooms. What is sometimes overlooked is that we also operate an expansive network of non-emergent care site locations, along with patient education and resources to help patients choose the most appropriate setting of care, both clinically and from a cost perspective. Urgent care expansion. We have expanded urgent care faster than our freestanding ERs and recently opened our 20th Care Now location. Today, our urgent care footprint is 3 times the size of our freestanding ER network and will continue to grow. Equally important, we're very intentional about where we place these sites. Urgent cares and ERs are often located near one another, giving patients clear, convenient choices for the right level of care. For example, our newest urgent care in Aliante is within 1 mile of our ER. This is about access and guiding patients to the right lower cost setting when appropriate. Patient education and resources. In addition to access, we're focused on clarity for our patients. We are enhancing signage at all freestanding ERs with larger, clearly marked emergency room identifiers so patients understand exactly what type of facility they are entering. We have also launched a free 24/7 nurse advice hotline. This allows patients to speak directly with the nurse, receive real-time guidance, and be directed to the most appropriate level of care. In many cases, this helps patients safely manage symptoms at home or avoid unnecessary emergency room visits. Since the launch, this service has already helped thousands of patients at no cost. At discharge, we offer free patient navigation services to help ensure that our patients have a follow-up visit scheduled with a specialist or a primary care physician. Scheduling these appointments before patients leave our ER reduces the likelihood that they will need to return to the emergency room for additional services. We're also expanding community education efforts and would welcome partnerships with Medicaid and commercial plans to ensure patients receive clear, consistent guidance. Preventing outmigration. Another important part of affordability is preventing patients from having to leave Nevada for care. When patients travel outside of the state, costs increase for both the system and for families. That includes travel, lodging, time away from work, and fragmented care. We are addressing this in several ways. First, Sunrise Children's Hospital, Nevada's largest, most comprehensive children's hospital with more than 200 beds, 60,000 kids treated last year alone, including the state's only pediatric congenital heart program, which is also one of the largest in the country, and the highest level of care, neonatal care in the state and region, which includes full service. ECMO is continuing to lead the efforts to expand the best pediatric subspecialty care in the region, including hiring a pediatric ear, nose, and throat doctor, the first in its state. Second, Mountain View Hospital has launched a bone marrow transplant and cellular therapy program, which is already providing cutting-edge auto and allogenic transplant to 116 patients who previously would have left Nevada. And third, we're actively working towards a comprehensive oncology campus, which will reduce fragmentation, bring more clinical trials, recruit physicians, and expand workforce training. These investments help keep care local, which improves outcomes and reduces total cost of care. Workforce. Workforce is one of the most important drivers of access and affordability. We are investing to expand the healthcare workforce supply in Nevada. This includes our graduate medical education program, the second largest in the state. With more than 300 residents and fellows, we are also investing in nursing education, with the program expected to graduate more than 400 nurses in a single class. Our simulation center is helping to train the next generation of providers as well. These investments increase supply, which improves access, strengthens quality, and helps reduce costs over time. In closing, we recognize that this is an uncertain moment with many Nevadans at risk of losing Medicaid coverage and with federal funding beginning to taper. But HCA Healthcare and Sunrise Health System remain committed to standing shoulder to shoulder with the state leaders to ensure we continue to deliver world-class care for every Nevadan. Thank you again for the opportunity to present today, and we're happy to answer any questions.
Thank you for being with us today in your presentation. Committee members, are there any questions? Senator Flores?
Yeah. Thank you, Madam Chair. You gave me the look. Thank you for your presentation. I know last session we had the conversations about freestanding ERs, and not to suggest it's the only time we've had that conversation, but I know it occurred last session. And I know some of the feedback we've heard at times is that there's this confusion within the community, but I just wanted to give you an opportunity to expand on that. Is there, on your end, are you seeing that is a confusion that exists at the time? What is the educational conversation that happens when somebody walks through that door? Just want to have a better understanding of what it is that you are telling folk. Is it being addressed on the outside of the building, et cetera, et cetera?
Chair Marzola, can I address directly?
Please remember to state.
Jeffrey Morosky for the record, J-E-F-F-R-E-Y.
I think your microphone might be off.
J-E-F-F-R-E-Y-M-U-R-A-W-S-K-Y for the record. Thank you, Senator Flores, for the question. What we find is we comply with the current state statutes about how we notify patients in our emergency rooms. However, emergency rooms do operate under very unique regulatory circumstances. EMTALA is the federal regulations that require that when someone presents, all individuals who come to an emergency room, and freestanding emergency rooms and hospital-based emergency rooms are the same in this regard, all have to have that medical triage exam completed at that point. So no one can be turned away when they walk into that space and receive that care. That is different than an urgent care location, which is basically a medical office that's focused on providing a visit for care. And they can turn someone away based on payer or other factors in receiving care. So what we find is people come in, they know what they're getting to. The signs on the emergency departments are clear. They are freestanding ERs have large ER signs, although we are investing in making them even clearer. We have the signage that's up that says this is an emergency room and this is what it's for. We do find as patients, this is when they need the care and it may not be available at that time.
Jackie Van Blaricum, for the record. I'd also like to add, in addition to the signage that Jeff talked about, when we talk about our urgent cares, we are also have an urgent care that's open 24/7, because what we do find is that when people do inappropriately access an emergency room, that could be a main campus ER or a freestanding ER, it's when all the physician offices are closed or urgent cares are closed. And so we have an urgent care that's open 24/7 to mitigate that issue. And we are actively evaluating additional urgent cares that we should keep open 24/7.
If I may continue. Thank you, Madam Chair. And I know that sometimes when I speak with constituents, it has more to do with the type of coverage that they have. When we often hear about frustration in our communities of how individuals don't have access to, for example, specialty care because they got to wait a few months, and it has nothing to do specifically with the freestanding ER. But I say that because I know that they at times have told me, just admitted, the only way I got anybody to see me because I didn't want to wait 3 or 4 months is because I went into an emergency room, right? And there's nothing necessarily we can do about that. I mean, that there's a whole other problem there. But that I feel like sometimes folk are very intentional in seeking out care because they feel it's the only way they can get somebody to see them. And I'm just curious to know, I imagine you wouldn't even know how to decipher that from an individual who's intentionally seeking you out because they realize otherwise I'm going to be waiting 3 or 4 months for something, whatever that may be, right? And but I'm just curious to know if you have noticed that as well, and that's a conversation that you've been having.
I can let Jeff answer clinically, Jackie Van Blerken for the record. One of our solutions is, again, GME, training the future. Our motto is train to retain. We're actively looking at expansion of fellowships, bringing more subspecialists into town so that we can reduce, that diagnosis from first treatment. That's really, really important so patients don't have to wait elongated times to see a specialist. So graduate medical education is a great way to solve those issues. Jeff?
Jeff Morosky for the record. Also, opportunities we look at in this space as people look for specialists when they present to any level of care. It's really the complaint that we're looking at, not the reason. And so we can't really parse out, oh, you're trying to skip. But we did, as Jackie mentioned before, the 24/7 nurse consultation line can also help to create connections that would help avoid those emergency room visits in the first place by connecting to specialists, and then we do navigate to help people get there. Another opportunity is in our urgent cares, we make sure people have opportunities to get preventative services. So maybe if they don't have a primary care provider, that urgent care while they're there, we're going to take advantage of that and just say, hey, have you had your colon cancer screening? Let's get you referred to get that completed. Or have you gotten your mammogram done? Let's take care of that. Low-cost services that reduce overall burden and time. So we've tried to take advantage of those things in building in our system. And as Jackie mentioned, right, we're retaining 57% of the people that we train in our GME program. And I think that's really the long play for future growth to solve the need of the physician shortage.
And then last question, or maybe not, Madam Chair. I know that anybody in the healthcare world in the state of Nevada, a lot, very true in Southern Nevada, we're serving a Latino population, right? I mean, it's just inevitable. And with them, there's conversations of members of our community who are still kind of in their fluid immigration status. There's folk that don't have insurance, et cetera. So 2 questions in one. What do you think is that educational component for individuals speak any other language and understanding the difference between an urgent care, emergency room? Do we feel that that's something that's happening now in trying to educate the populations in a language that they understand? And I'm assuming this is true in all healthcare conversations, right? Whether it's treatment, whether it's prescribing something, whatever it may be. I feel that this is probably always a question. I'm curious to know individuals from the moment they walk in, if we're engaging in those type of conversations to help them kind of understand what they're walking into.
Jeffrey Morosky for the record. Senator Flores, thank you for the question. There are federal requirements that ensure that we work in the language of preference of the individual that we're seeing. So any patient who presents, the first thing we're going to be doing is saying, in which way do you wish to communicate? And if they tell us that their preferred language is Spanish, then we have Spanish materials. We have the top 3 languages all pre-printed. We have Spanish materials that will help them. So all the educational materials that would be available about, hey, this is what an ER is, this is what urgent care is, those are also available in Spanish. To help, we also have translation and language lines for our medical staff who aren't certified to translate. We don't want people just guessing at it, so we use certified translation services, and those are available at all of our care locations to be able to help our patients communicate effectively with us. As a care provider, it's very important that I really hear the complaint from the patient in the language that they speak, or I won't do the right care. And so we really take that very seriously.
Yeah, that's fine, Madam Chair. I think we can give some questions to other folk and maybe come back at the end, maybe. Thank you, Madam Chair. Thank you. The only other thing, I guess, I know earlier in the conversation today, I know yesterday I had an opportunity to visit and hear directly from doctors and families and individuals who, kind of in their worst moment of their lives, were just thanking the humans who saved them, right? And the celebration of the level 1 trauma room, et cetera. Just curious to know, because I know there's some conversations, and I know, Connor, in the outset of your conversation, you started talking a little bit about the work that's been done, but if maybe to expand on that conversation of whether or not we need it, and or is this the right timing? I know there was a question about resources, and so I just wanted to maybe open the conversation to that kind of lane.
Thank you, Senator, and I'll start by responding, and Jackie and Dr. Morawski, please also weigh in. So first, I mean, what level 1 means, right? And going from level 2 to level 1, and this is very, very important, there's no volume impact to other facilities. So you're not diluting care, you're not taking patient volumes away from any other level 1 facilities in the community. It is a recognition of a certain investment in teaching and research. And then there are a few very, very specific subspecialties, which I've jotted down here. I can pull up. So things like microvascular, cardiothoracic, advanced spinal procedures, things that you need to do clinically that distinguish a level 2 from a level 1. We've been doing those things at Sunrise Hospital for several years. What we had not done, and what we recently did, and what we were verified by the American College of Surgeons, is we made a significant investment in teaching and in research. And so if you are somebody who's in medical school, you're looking for where to train, and you're looking at different places around the country, and you're thinking, I want to train with the best of the best at the very best facility, you want to go to a level 1 trauma center. And we are now that, right? We are investing in teaching, we're investing in research, and we're investing in providing the very best clinical care. And that's really going to help our community. So when you talk about, and I think there are a number of different examples I could give, but one particular thing that we sorely lack in the state of Nevada is providers, is doctors, right? And so that is something that we absolutely do not have enough of as a community. Being a level 1 trauma center and being able to represent ourselves publicly as a level 1 trauma center helps us to attract those doctors, helps us to get those residents, helps us to address those really significant shortages. And that is incredibly important. I think also when you do compare us to other markets and you look at trauma capacity, I would argue that we were sorely lacking in having the right trauma capacity for a community that has grown by millions of people. And so that also is really important. And that capacity will come into play when we, heaven forbid, have another mass casualty event like we did on October 1. We want to be at the cutting edge. We want to have the very best research. We want to have the very best residents, the best doctors, the best nurses. Having a level 1 trauma center is of huge value to our community. It is very exciting.
Thank you.
Vice Chair Pezzina.
Thank you so much, Madam Chair, and thank you so much for the presentation. I love hearing about the emphasis placed on graduate medical education because we do obviously have a provider shortage, and it's something we've been having a lot of challenges with because the formula for doctors in the state of Nevada is low when it comes to CMS providers. And I think everyone in the state could say that it's hard to get in and see a doctor, particularly a specialist. So looking at slide 4, I was really interested in your slide in regards to investing in the clinicians of tomorrow. And I noticed, and you shared it again, the 57% retention rate for those doctors that stay in Nevada in 2025. I was curious how many you're recruiting from Nevada schools, from UNR, from UNLV, from Touro, Roseman, how many graduates are joining your program?
Jeff Morawski for the record. Thank you for the question, Senator Pezzina. The residency recruitment is a match process that goes in through that. I just lived through that with my daughter from last year, who was a UNLV medical school graduate and went through the match. I wish I could have kept her in Nevada, which is my goal, long-term goal, is to get her back. But I think that we do a lot of effort with those medical schools to try to get those folks to come to our programs. And depending on the program, it could be anywhere from a third to half of those residency slots can end up eventually being taken by Nevada residents. But Nevada connection is really important to us when we do our interview process, when we're looking for residents, is, we want someone when we're looking for the match, and how we rank people is, how are you connected to Nevada? And that could be, I have family here. I've always loved Nevada. I like this area. There's something about the mission or the patient population that I want to serve. And so that's important for us in our interview process, just as the medical schools do in their consideration.
Thank you so much. And I think the statistic I heard was maybe something like 80% of students who study and graduate as a doctor in a state and then do their graduate medical education in a state will then stay to practice in that state. So, you know, obviously my hope is that over time, more and more Nevada students find their way into your residencies and fellowships, and then that 57% retention rate gets higher. And I guess my last question would be, looking at that rate, has that gone up over the years or has that stayed pretty steady?
Jeff Morosky for the record. Thank you, Senator Pacina. That rate's gone up a little bit over the number of years and continues to grow. As to what Jackie mentioned, we invest in new fellowship programs. So one of our gaps right now is not having enough of certain subspecialty training programs to keep people who are looking for something very niche. You know, we don't have certain programs, like there is no pulmonary critical care program, but we're going to have one that would then keep some people here. So we try to bring them back. But it's always, again, the rate is 80% if we get you for medical school and residency. It goes up to 95% if we get you for medical school, residency, and fellowship. And that's really what our goal is, to get that whole range of training completed.
And one last comment. I think you're all aware, and Connor, I know we worked on this in previous sessions, but the Advisory Council for Graduate Medical Education, when we're looking at some of those niche specialties, it's a great opportunity, I think, for some of the medical providers in the state and the deans at the schools who are working with students like yours, right? Can really find out what those specialties are that we're lacking, what we need, what their students are interested in, you know, what we need for Nevadans. So I would highly recommend, you know, speaking with that council and making sure that they're aware when they're making decisions as to where that money will go. So thank you.
Committee members, any additional questions? Senator Steinbeck.
Thank you, Madam Chair. I just wanted to kind of follow up on a question earlier that I had in the day about the timeliness and the importance during a traumatic event. To you, Doc. You know, Sunrise is 15 minutes away from our other level 1 trauma center, and I just wanted you to kind of comment on the importance of that, not only from a timeliness. Maybe you could talk about timeliness and volume that we see here in Southern Nevada.
Jeff Morosky for the record. Thank you, Senator Steinbeck. I think the easier comment is volume. Part of the ACS verification process, the American College of Surgeons verification process, is to ensure that a trauma center going for a level 1 has the volume to be competent and excellent at that care they're going to provide as a level 1 center. So part of the ACS designation is saying you see enough of this that you're good at it. And that is always the concern that, you know, if I don't do something often enough, I'm not going to be great at it. They ensure that they do that as part of their designation. So for us, it was, we're going to get that designation to really clarify that we have enough volume with even our current situation to do that really well. And obviously, you know, we want to make sure there's a trauma center on that side of town. It's important for distance, right? The golden hour is the golden hour. And while there may be not a significant difference in minutes do matter. 3 minutes can make a big difference. And when we look at things like heart attack care, you know, 3 minutes, between 63 minutes and 60 minutes to get your thrombolytics in and take care of that in a non-trauma patient, that has a 5% difference in mortality rate. And so it's really important that we have that timeliness. And so geography matters. And that means as we get busier and we actually get traffic in Las Vegas, that will matter even more. And so those things are really going to make a difference in the long run.
Thank you, Madam Chair. May I ask one more question? Thank you. About the urgent care, and that was an excellent answer, sir. Thank you. But about the urgent care facilities, I'm really glad to hear you talking about maybe having more that are after hours. It seems like a lot of people do end up at emergency rooms or standalone or full hospital just because of availability, right? Just because they're on the border of, hey, maybe I'm urgent care, maybe I'm ER, but I do need care. And this is the only time of day I can go, right? And so I'm glad to hear that, but can you expand on that a little bit?
Jackie Van Blaricum for the record. We are constantly evaluating our hours of our urgent cares and looking at our data of patients who access all of our access points. And so many of our urgent cares will stay open past 8 p.m., 9 p.m., some 10. And then, like I mentioned, we have one that's 24/7. And we're evaluating where we should have additional urgent cares that need to be 24/7. And then what's also really important is that when a patient does enter an emergency room, we have specific people who will schedule an appointment with a specialist, and they will even help arrange transportation if that's what's needed, so that they don't bounce back to an inappropriate care level. And I think that's a really important distinguishing factor that Sunrise Health offers. And I think it's really important that we navigate the patients the right level of care, and that we're constantly doing that education as well. And we offer that service in our urgent cares as well too.
Committee members, any additional questions? I don't see any. I do have one question. I've never been to a freestanding ER, and so this is where my question is coming from. So if I go and I'm not able to be treated, or obviously, there's an issue that it's more serious, it is my understanding that you're not able to spend a night. Is that correct? Okay. And if I need to be, is that correct?
Jeff Morosky for the record. I think the question would be, you can go to a freestanding emergency room or a main emergency room at a hospital, and you will spend the amount of time you need there to resolve the issue. And so that could be 2 hours or an hour if it's really quick, or it could be 4 or 6 hours if they needed to observe your condition to decide what to do.
Sorry, yeah, so that wasn't my question. So let me clear it up. So I go to the freestanding ER, my condition is more serious, that I have to be transported, okay? Once I'm transported, is that a cost to the patient, or is that a cost to the freestanding ER as far as the ambulance?
Chair Marzola, thank you for the question. Jeff Morosky for the record. When you go to a freestanding emergency department, you are physically going to a department of the hospital, which means that any movement cost from a freestanding emergency department to the main hospital is borne by the hospital. There's no pass-on cost to anyone. That would be the same as saying I have a transporter that's taking you down the hallway to radiology. It's the same transport for us because you're inside the system, as long as it's the hospital that's aligned with that freestanding department. So the Lakes freestanding ER is aligned with Southern Hills Hospital. That's the hospital you would go to. If you wanted to go somewhere else, that would be no different than if you were at a main hospital ER and said, my preference is to go to another hospital, please transfer me. But you can provide care for me, but I don't want to be here. That's a patient preference, and that does have cost.
Thank you for that answer. Any additional questions? I don't see any. Thank you so much for your presentation today. We will now move to our next presentation. We will now hear from Renown Health on the 340B program and contract pharmacies. You may begin when you're ready.
Good afternoon, Chair Marzola and Interim Commerce and Labor Committee members. My name is Chris Bosse, B-O-S-S-E for the record. I work with Renown Health, and specifically Renown Regional Medical Center is the only locally owned private not-for-profit level 2 trauma center, academic medical center, that was a mouthful, wasn't it, in the state of Nevada. We appreciate the opportunity to come and talk to you about HRSA's 340B program, including the intent of the program, how it works, how covered entities such as Renown use the resources to expand access to care to individuals like Medicaid and self-pay patients. In addition, we'll share with you how this program is being impacted by manufacturer policy changes and how in some states they've identified ways to protect those covered entities so that they can continue to provide that care. With me today is Adam Porath, Vice President of Pharmacy for Renown Health, and he is our subject matter expert. Adam?
Good afternoon. Again, for the record, Adam Porath, ADAMPORATH. And let's talk a little bit about the 340B program. The program was created by Congress in 1992. And it requires drug manufacturers to offer medications at a discounted price to covered entities. Any manufacturer that's participating in the Medicaid or Medicare program must offer a 340B discount. There are inflationary penalties built into the program so that if a drug manufacturer increases their price above the consumer price index, they have to lower their 340B price that they're offering to covered entities. There are no taxpayer dollars associated with the program. There is concern that there are rebate impacts to the Medicaid program, which is true. If you have a drug that is covered by the 340B program, Medicaid does not get a rebate on that. However, in our state, 340B providers are required to pass that cost along to the Medicaid program up front. So a pharmacy gets reimbursed their 340B cost plus a dispensing fee. So the discount really comes up front rather than in a rebate. The intent of the program is to allow covered entities to, and this is a quote from the Federal Register, stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So really the benefit of the program goes to the institution so that they can provide access to more care, provide more broad programs. There is no impact to the patient as far as if the drug is eligible for 340B or not. The price that they pay is going to be whatever their copay is if they're an insured patient. If they're a self-pay patient, many 340B providers will offer them a discounted price. That's not required by the program, but it's very common that 340B providers do that. Within our state, we have several different types of covered entities that qualify for the program. There are 2 disproportionate share hospitals, UMC and Renown Regional Medical Center, 8 critical access hospitals, so basically all of our rural health facilities that we have, 11 FQHCs that have 54 different locations across the state, 1 community health center, 14 family planning centers, 9 Ryan White clinics for HIV care, 12 STD clinics with 39 locations, 12 TB clinics, 1 hemophilia treatment center, and 1 tribal health clinic. The program is administered by HRSA, which is part of CMS. Our program at Renown Regional Medical Center, we enrolled in 2009. We qualify as a disproportionate share hospital. And how that qualification works is it's based on the percentage of Medicaid and Medicare SSI patients that you serve. There's then a complicated formula based on bed size that basically adjusts that overall percentage down. And so your adjusted percentage to qualify for the program has to be 11.75%. Currently, Renown Regional Medical Center has a DSH percentage of 18.39%. We were audited by HRSA in 2018, and there were no findings of that audit when they came through. We did a comprehensive third-party audit of our program in 2023. We annually do a third-party audit of our contract pharmacy program, and we have a robust monthly self-audit process where we look at 100% of our claims that go to our contract pharmacies. what do we do with the benefit that we get from the program? Primarily we use those funds to subsidize the cost of underfunded healthcare. Particular programs that I want to point out to you guys are that we fund 12 clinic-based pharmacist positions to provide pharmacotherapy services to both adult and pediatric patients. We now have one pediatric specialist pharmacist that's doing this work. This is a service that typically with current reimbursement structures do not cover the cost of the care of the pharmacist. I think there's a presentation later in the day that'll be talking about those clinical services. We also employ 22 clinic-based pharmacy liaisons to provide prior authorization and financial assistance services to patients. And so these are pharmacy technicians, and they interact with the patients. Anytime that there's going to be an out-of-pocket cost of more than $10, they will pursue any financial assistance for those patients. This year so far, they've secured over $10 million in financial assistance for our patients. We also have a position called a pharmacy patient advocate that works specifically in our infusion center. She has secured in 2025, secured over $5.1 million in financial assistance for our infusion patients. Renown Regional Medical Center provides pediatric subspecialties that operate at a loss and would otherwise not be in the Reno area because of the 340B funding that we get. We're the only chemotherapy provider in the Reno metro area that accepts Nevada Medicaid and self-pay patients. We have a primary care clinic dedicated to Nevada Medicaid patients called the Healthcare Center. We are now able to offer extended urgent care hours out to 9 p.m. at 2 locations around the Reno area. A couple of years ago, the one and only 24-hour pharmacy that was left in Reno decided that that was not financially feasible for them anymore to offer services. And so there was a period of about 4 months where there was no after-hours pharmacy services after 9 p.m. We looked at it and said, with these margins that we can get on 340B prescriptions, we think we can swing it to have an overnight pharmacist. And so we quickly came in and opened. So we've been running for a little over a year now, the only 24-hour pharmacy within the community. We also provide an extensive, what we call a meds to beds program. So basically patients get their discharge prescriptions before they leave the hospital. And we provide that service regardless of patients' ability to pay. So if they tell us, I just can't afford, I don't have insurance, or I can't afford those copays, we cover that with our charity care account. So lots of stuff that we do with this program. So just a little bit more in depth about what drugs are we really talking about here. So only outpatient prescriptions qualify for the program, and they have to originate from the covered entity. So in our case, we have other Renown hospital facilities. So there's Renown South Meadows, Renown Rehab Hospital. Those do not qualify for the 340B program. They have to come out of Renown Regional Medical Center. And they have to be associated with the service. It can't just be that we're just providing the drug to you at our pharmacy. You have to have had a visit at the hospital or an outpatient encounter with the department of the hospital in order to qualify. We mentioned we're going to be talking about contract pharmacies. So what's a contract pharmacy and why did they come about? Up until 2010, the benefit of 340B was really restricted to if the covered entity had an outpatient pharmacy where they could provide these drugs. I just said that only covers outpatient drugs. A lot of our covered entities in the state do not have an associated outpatient pharmacy. And so if you look at the critical access hospitals around the state, to my knowledge, none of them have an outpatient pharmacy. UMC does not have an outpatient pharmacy. And so the sole way that they can get benefit from this program is through a contract pharmacy relationship. This is also the largest area of controversy within the program. And so how a contract pharmacy arrangement works is that basically a covered entity can contract with with any pharmacy in the community to say that we want to extend basically our reach by contracting with a CVS, Walgreens, et cetera. That pharmacy then agrees to fill a prescription at a agreed to dispensing fee. The covered entity, the hospital in this case, would then replenish whatever drug was used to fill that prescription with their lower cost 340B drugs. So that drug would be shipped directly to the contract pharmacy. Any reimbursement that happened for that particular prescription would flow back to the hospital in this case. So the hospital is basically out the dispensing fee and the price of the drug to replace the prescription, and they get the reimbursement back on the prescription claim for that. So this allowed really a lot more benefit of these qualifying prescriptions to flow back to the covered entities. In 2020, started with a couple of insulin manufacturers that we saw manufacturers restricting how contract pharmacy arrangements could work. And this has grown now to, fast forward to 2026, over 40 manufacturers have put some sort of restriction around contract pharmacy arrangements. Often these have to do with if you have an in-house pharmacy, you may not have a contract pharmacy arrangement, and they will not ship 340B drug to a contract pharmacy. They may limit the number of contract pharmacies, often to one pharmacy that you could ship to, or there are several manufacturers now that are requiring claims prescription level data in order to maintain access to 340B pricing at your contract pharmacies, which really just is added administrative burden to the entire process. You know, the purpose of that claims level data, I think, is questionable, and I'm happy to answer more questions about that later. I think that these restrictions really have limited the benefit of the program, especially across rural Nevada. And I'd like to tell you what some other states are doing about this. So currently, 22 states have enacted state level contract pharmacy protection laws. You can see those states highlighted in green. The latest was Washington State earlier this year. And do they work? There's a lot of question as to whether they're, you know, this is a federal program. Why should we have a state level law about this? These pretty much universally, when a state passes these laws, they are sued by the pharmaceutical industry. And pretty much universally, the states have won when these lawsuits come about. So that there have been several Circuit Court of Appeals cases that have gone in favor. There has been one that has gone in favor of the pharmaceutical manufacturers. And so I'm sure this is probably going to go to the Supreme Court at some point. Additionally, right now, if we look at what's going on around the country, there are 5 states that are currently, 5 states and Puerto Rico, that are considering contract pharmacy legislation currently. So what would that look like? There is model legislation that is out there. The American Society of Health System Pharmacists has some model language. And really there's 2 things that a manufacturer can't restrict where a covered entity would like to ship their 340B drug to. And secondly, a manufacturer shouldn't require data in order to ship 340B eligible drugs. And so last interim, we had a committee bill related to contract pharmacy, and we would love to see the same thing again this time around. Any questions for me?
Is that in the presentation?
It is.
Okay, thank you. Committee members, any? Assemblymember Roth?
Thank you, Chair, and thank you for the presentation. Renown is in my district, and I'm very proud of the work that's done by your hospital. My question is just to help me kind of contextualize what it means if we have these limiting restrictions put on place of the amount of pharmacies that can participate. So I imagine if you're looking at somebody who lives on a fixed income, they rely on public transportation. If you can kind of just illustrate what I'm imagining, but what that would mean practically for a community that's already struggling.
So this is Chris Bossy for the record. I'll start and Adam can finish. The piece that I want to make, that's a great question, Assemblymember Roth. The bottom line is these contract pharmacies make it convenient for patients, which is why we have done, I think, a good job of contracting with many, if not as everybody that we know of, so that patients can get their prescription close to wherever they work or live. I think it's also important to remember that Renown Regional, as a trauma center, and the only one in the area, has a very large catchment area. So we have patients that return to their rural communities afterwards, and they should be able to go to the pharmacy that's near them in order to fill their drugs. Adam, would you add anything?
Yeah, Adam Porth for the record. Just to put it in frame of reference, we have 85 contract pharmacies for Renown Regional Medical Center. These are pretty much every major chain pharmacy within the Reno metro area, as well as Chris mentioned, some of our outlying communities, Fernley, Fallon, et cetera, that we contract with. We have this discharge medication program that I mentioned, but it's the patient's choice. And a lot of times they choose and say, no, I'd rather have that filled at my my local pharmacy. So.
Assemblymember Kusama.
Thank you very much. I have a question. I'm looking on, I don't see a page number to the slide, but history of 340B. And there's a section there that it says intent allowed covered entities to stretch their federal resources. And one of the bullet points there, it says benefit of the 340B discounts go to the covered entity to expand services and access to care. So the discounts come in and now you can use it for expanding services and access to care. And help me understand, since this is a program designed for drugs, why isn't that discount just going directly to the cost of the drug and passed on to the user? Because somebody's previous presentation, we saw that the cost of the drugs, I think, was 21 or 24% of the dollar of healthcare. So it seems to me it should just be passed on directly in the price of the drug, since that's such a large portion of the healthcare cost.
Yeah, thanks for the question. May I go direct? Adam Porth for the record. I think it's an excellent question. I think that if you go back to how did the covered entity qualify? They qualify because they're taking care of a disproportionate share of indigent patients. And so the program's intent, although it has to do with drug pricing, is really about subsidizing indigent care. And so there may be, as I mentioned, if you have a self-pay patient, that a discount is offered to that patient. But oftentimes what a patient pays out of pocket is completely out of the realm of influence of the pharmacy. It's whatever the payer dictates their copay is going to be their copay. And so the real benefit of the program is the pharmacy is going to get reimbursed whatever the negotiated rate is with that particular payer. They're just buying it at a lower cost. And then that delta goes to fund these indigent care programs.
Can I have another question? Yeah. So the other thing that you said for, and so a covered entity, if I'm understanding here, is for government owned or not for profit, basically. Those are the covered entities. And you're talking about, if they're providing a higher care for indigent services. What happens if a for-profit also provides a lot of care to indigent services? Would they have the ability to access this?
Adam Porth for the record. No, not under the federal statute, they wouldn't.
Even if they were providing a lot of services to indigent or
Correct.
Medicaid?
Thank you. Any additional questions? Senator Ellison, do you have any questions? I don't believe so.
No, ma'am. Thank you.
Thanks. For some reason, we can't see you, so. Okay. So walk me through, because this is a complex issue, especially for somebody that's not in this space. So Renown would be a covered entity, correct? Okay. So you fill a prescription for a patient, then certain amount of money comes back to Renown. Is that correct?
Adam Porth for the record, are you talking specifically in a contract pharmacy relationship?
Correct.
Yeah. So the prescription, there's a third party administrator that basically looks at prescriptions that are filled at one of my contract pharmacies and will say, this one is eligible. This patient had an encounter at the hospital. And so in that case, whatever the payer paid for that prescription claim, rather than staying at the contract pharmacy, would go back to the hospital. And then in turn, we pay them a dispensing fee for doing that work for us, and we replenish whatever drug was dispensed to the patient at our lower cost to them.
So that amount that comes back to the hospital, if you now contract with outside pharmacies, is that same amount coming back to the hospital, or is there a less amount coming, if any at all?
Yeah, so the big difference between if we filled it ourselves at our own in-house pharmacy versus if it goes out to a contract pharmacy is that dispensing fee. So if we filled the prescription at Renown, we're not having to pay that cost of the dispensing fee. Otherwise, the equation is pretty much the same. We're likely going to have a very similar contracted rate as one of the chain pharmacies that we would get reimbursed. And our 340B cost is going to be our 340B cost in that case.
Okay, thank you for that. So my last question is there any way, if you're contracting with outside pharmacies, that it could somehow be abused, right? Is there safeguards that you can put into place, or how do you stop that?
Yeah, so that, and I think that's one of the biggest concerns with contract pharmacies is there's the concept of diversion. And in this case, we're not talking about someone stealing drugs.
Right.
It's about drugs that are intended for 340B eligible patients going to ones that don't qualify. One of the biggest rules in contract pharmacy relationships is that Medicaid is off the table. And so you cannot include Medicaid prescriptions in contract pharmacy relationships because of this whole mess of how do we then determine, how does Medicaid determine which CVS prescriptions to pursue rebates on? You can't. And so in those contract pharmacy relationships, only non-Medicaid prescriptions are considered.
Thank you.
Yeah.
Vice Chair.
Thank you so much, Chair, and thank you so much for the presentation. It's always good to see you coming down from Northern Nevada. Okay, so let's say that Renown purchases drugs through the 340B program at discounts of 25 to 50% below market rate. Can you share with the committee what Renown then would charge patients and their insurers for those same drugs last year and provide a breakdown of the difference between the acquisition cost and the reimbursement that was collected? I think they get the drugs at a discount or below market rate. We're just trying to figure out if they charge the patients or the insurer more or the market rate or how that works.
Adam Porth for the record. Yeah, so the reimbursement relationships are set. And so we have by payer what they're going to reimburse based on it's typically average wholesale price minus a certain percentage And so that is the reimbursement we get, regardless of if it's a prescription that qualifies for the program or not. The cost that the patient pays, as I alluded to before, is really set by the insurance. So if you have a generic copay, you're going to pay your generic copay. If you have a brand name copay, you're going to pay your brand name copay. Again, it doesn't matter if whether it qualifies typically is unknown to the patient, with the caveat of unless you don't have any insurance, and then the covered entity would have the option to provide those 340B qualifying prescriptions at a discounted rate if they so choose.
Any additional questions? I don't see any. Thank you so much for your presentation. Oh,
yeah. I just want to thank the committee for being willing to hear this topic again. I think that we have this program with a limited number of folks who are covered entities in our state. I mean, it's not huge numbers compared to maybe some other states, and we appreciate your consideration of looking at policy protections for covered entities so that we can continue to provide those, additional services for those who need them most in our community. Thanks.
Can I ask you a question actually before you leave? I understand individuals who live in rural areas, correct? Like they have very limited resources. So would it be an option to maybe contracting to pharmacies that are in rural areas instead of open-ended? Does that make sense?
Adam Porth for the record. I think the options are endless as far as what this could look like. But yes, to your point, I mean, obviously access is more of a concern there than it would be. You could make the argument within the Reno metro area, barring transportation issues, et cetera.
Thank you. Assemblymember Kasama.
Thank you for the indulgence, Chair. It made me think of another question. My understanding, and perhaps you could correct me if I'm wrong, is that we've had more of our rural pharmacies closing. So it does provide, a lack of access to those services. And I don't know if you're the right people that might know why more of those pharmacies have been closing and what the cause is for that.
Adam Porth for the record. I think the independent pharmacies in general has become a very difficult business with the proliferation of pharmacy benefit managers, the buying power of national chains. It's just really hard to make a margin as an independent pharmacy. As to why we see particular chains closing in rural communities, I think a lot of that probably just has to do with the ability to recruit and retain pharmacists within those communities.
Any additional questions? Thank you. No more questions this time, I promise. Our next presentation, we will hear from Pharma on the introduction to the 340B program. Pharma, if you're in the room, do you want to come up?
Hi. Yes.
Oh, sorry.
I'm here, just finding my slides.
I apologize for that.
Oh, no
And just so everyone knows that after this presentation, we will take a lunch break for about 30 minutes. Obviously, we need to be fed. You may begin when you're ready.
Just confirming that you can see the slides. I've done that correctly. Okay, thank you. For the record, Daria McGrew, DHARIA MCGREW, on behalf of Pharma, Pharmaceutical Researchers and Manufacturers of America. I want to thank you for the opportunity to provide our perspective on this program and taking your time before lunch. I will try not to take too long between everybody and their food. So To repeat just a little bit of what the previous speaker said, this program, first let me go back and say, Pharma supports the original intent of the 340B program. And I want to agree wholeheartedly that safety net hospitals and clinics are an integral part of a healthy healthcare system. However, what started as a small safety net program has gone off the rails and no longer resembles how it was envisioned. So to boil this program down into its most simplest form, you just have to remember the old adage, buy low, sell high. Hospitals are able to buy prescription medication from manufacturers at a deep discount, sometimes as little as a penny, and then mark it up hundreds or thousands of dollars and charge your insurance company that spread. And that what they call the 340B discount is more accurately described as 340B revenue. The debate that you're hearing about is not about patient access to medicine. Patients access their medicine at the pharmacy in their community, or wherever their insurance company directs them to. That relationship is between them and their insurance. Patients don't know if they are a 340B patient, and they don't know whether that pharmacy is a 340B contract pharmacy. That is all behind the scenes. This debate is about covered entities trying to protect billions of dollars in revenue stream with little to no accountability or transparency. So the 340B program is not at risk of going away. I don't want you to feel a false urgency that your state needs to step in to save this program. Whether you take action or not in Nevada, the program has grown 20% year over year in the past several years. And that 20% is a very large number. In 2023, covered entities purchased $66 billion worth of medication at the discount price. And in just 1 year, in 2024, that went up to $81 billion in purchases. That hardly paints the picture of a program that is shrinking. But it is growing uncontrollably, and that growth is not sustainable for the healthcare system. So policymakers, we believe, should start by asking questions and asking for transparency. How much money are we talking about? Where is it going? And is it actually helping patients or being used for other purposes? Implementing transparency to start with will be the key to understanding the program. But I want to get a little bit more into, we can dig into the growth a little bit more. Hospitals, what started in 1992 with 45 hospitals, has increased to now nearly 3,000 hospitals participating in the program. That is more than 50% of the hospitals in the US are participating. Also, this contract pharmacy, which I agree with the previous speaker, is one of the major problems that we are debating over. We've seen massive growth in contract pharmacies. As was said, it's when the program started, if a small rural hospital or a clinic could not afford to keep an in-house pharmacy open, they could work with a community pharmacy, send their patients there. The pharmacy would dispense the drug and keep a small cut of the drug with dispensing fees, and then the revenue would go back to the covered entity. But however, in the last 10 years, that mechanism has been co-opted by mega retailers and vertically integrated PBM-owned pharmacies that learned that this program could be a very, very lucrative revenue stream, billions of dollars. So what started as a safety net program is now mentioned on Wall Street earnings calls as keys to their continued growth. Nevada hospitals and clinics have around 9,000 contract arrangements. But that's every entity and every pharmacy can have multiple arrangements. That breaks down to about 600 distinct pharmacies participating with Nevada covered entities. However, 40% of those pharmacies are not in the state of Nevada. And when you look a little bit deeper, only 5% of those pharmacies participating are independent local pharmacies. The program is dominated heavily by those huge retailers. And there is no transparency or line of sight into the financial arrangements between them. Some digging by Congress recently found as much as 30% of the revenue in 340B going to contract pharmacies, third-party administrators, and other middlemen. That's billions of dollars being siphoned out of the safety net and turned to into profit for these pharmacies. Previous speaker mentioned HRSA audits that we will say are very paltry and have not grown with the program. But what the HRSA audits do find when they are done is 60% of the time they come up with adverse findings, and many of those adverse findings are the duplicate discounts and diversion that was discussed. So as I said, I want to reiterate, this is a well-intentioned program, but it has deviated from the original mission and is growing uncontrollably. The program has become a behemoth that is more about revenue than it is about helping patients. So originally, what was the quote that is often said, stretch scarce federal resources, meant that the clinic could purchase drugs at a discount to be able to provide medication for their patients, and therefore spend the money that they had on other services. But that has been twisted, and that concept is flipped on its head to try to say that Congress meant for them to have an unlimited revenue stream. And what we're finding when you dig in is, why do we say this is not helping patients? There's lots of different ways that we can look at this and show that the program is not directly benefiting patients. First, we can look at where those contract pharmacies are growing. Those contracts are growing every year, year over year. And when you look at where they're located, the new contract arrangements are with pharmacies existing in higher income neighborhoods. They are less likely to be placed in neighborhoods that are underinsured or low-income neighborhoods. So you did hear that those contracts are needed for patients to access their medicine, and I want to reiterate again that this debate is not about where patients will go pick up their medicine, because they can go to that pharmacy if it's an in-network pharmacy already. So patients are not directly, this is just one metric that patients are not benefiting directly. Another way to look at it is to look at the hospitals. There is not a whole lot of line of sight into how the 340B dollars are spent by hospitals. And much of those dollars are spent on wonderful programs, but we believe that there needs to be far more transparency and accountability, because they are not required. The 340B program does not require them to give the drug at a discount to the patient or to reinvest in the patient. In fact, we know that 340B hospitals offer less charity care than their non-340B counterparts. We also know that 340B hospitals are more likely to engage in predatory debt collection when patients can't afford their bills. So again, we need more transparency on where those 340, how much are we talking, where is it going, and are patients benefiting? Now, this program, until recently, has been very inside baseball in healthcare. It's a program that only ever was heard about by policy wonks and bureaucrats. And how did we end up here at a state legislative hearing talking about this federal program? One of the reasons is investigative journalism started looking into shining a light on this program and calling attention to headlines like the ones featured here. And now, additionally, we have Congress, the OIG, the GAO, Congressional Budget Office, all start digging and uncovering issues. And the more digging they do, the more problems that they find. As recently as last month, both the Wall Street Journal and the Washington Post editorial boards highlighted a need for transparency and reform in the program. So I want to talk about some of the things that we're finding now that this digging is being done and there's more broad understanding about this program. You heard previous presenter mention that this is not state or federal or money that comes out of state coffers and is just manufacturer. But this is not just a fight between manufacturers and hospitals. In fact, the 340B markups are driving costs for taxpayers, patients, employers, and the healthcare system as a whole. 340B growth is causing an increase in insurance premiums from lost drug rebates. It is a factor driving provider consolidation. It incentivizes the prescribing of higher cost drugs that have a higher margin of revenue. And it is pushing patients into more expensive care settings. So I want to dig in a little bit into the point on the first slide and talk a little bit more about rebates. You have heard extensively about rebates in other conversations about healthcare reform, and it can be, you know, confusing. How do rebates play with the 340B program? So remember, I told you you need to remember buy low, sell high. That margin is the crux of this debate, but that margin is billed to insurance plans. That margin is billed to Medicaid, state, and commercial health plans, ultimately raising premium costs for employers, employees, and taxpayers in Nevada. And one reason is rebates. Manufacturers negotiate with payers and states to offer billions of dollars in rebates on the back end after drugs are dispensed and billed and purchased. But what happens in 340B is that the covered entity essentially cuts the line and gets a discount up front, and then the payer doesn't get a rebate on the back end. So these are federal dollars of estimated calculated loss rebate dollars, but we do have some slides discussing estimated losses specific to Nevada, that private employers are losing $28 million, state and local health plans, 13 million, and Medicaid, 3 million, and Medicaid, 13 million state share of lost Medicaid rebates. So in summary, I want to wrap up with a couple of thoughts. Again, as was mentioned, this is a federal program that needs a federal fix. These are contracts between manufacturers and the federal government. And you're thinking, but Daria, you just told me this is costing the state money. So I want to tell you, and I can understand why you would think the state should do something about that, right? So that something can be transparency. States have the power to ask important questions and are starting to do so. To date, over 10 states have passed legislation seeking transparency on what is happening in their state with those 340B resources. Most notably, Minnesota was the first state to do this. Their second annual report came out. They found that hospitals in Minnesota were retaining 1.3 billion net revenue. Largely, over half of that was retained by 4 large hospital systems. So we're talking significant dollars here. So you have the power to be asking, how much money are we talking? Where is it going? And who is it benefiting? And you are being asked to consider legislation that instead will write a blank check for hospitals with no accountability. They do not want to have to provide the data to show that the 340B medication is going to the right patient at the right time. But the program is growing and will continue to grow without your intervention. And policymakers should be looking under the hood to require transparency before considering any type of legislation that locks in this kind of growth. Thank you for your time, and I'm open for questions.
Thank you for your presentation. Committee members, are there any questions? Assemblymember Kusama.
Thank you. I'm looking at your slide number 3, where you have sales at the 340B price have skyrocketed, and you have the section there, the cost is 81 billion. And how much of that is for Nevada? I know on another slide you had different areas there, but in total, how much is going to of that cost is for Nevada?
Thank you for the question through the chair. Thank you. Daria McGrew for the record. That's a great question. The 81 billion, we know that's the purchase price of the drugs that are sold. So we don't have any good numbers on the revenue. We know that the average discount is about 50%, but sometimes it can be much higher than that. You know, we think that that is a great question for lawmakers to be asking, because we don't have state breakdown. That is not required in the federal program.
So that's a national number.
That's a national number, and there is no requirement to report that revenue back to the federal government.
Thank you.
Any additional questions?
Yes.
Senator Flores.
So I'm looking at your slide 12, where it's talking about costs for Nevadans. So just please walk me through it so that I understand. And I think the question was partially addressed in the previous presentation, not slide. Help me understand the rebate so that I understand this. We're saying that there is a reduced price for the meds, and at times there's a rebate, at times there's some form of savings there. And I'm trying to understand if what we're saying is that we're charging the full price at the beginning, or we're getting a rebate at the beginning, and then we're charging a full price on the back end to what person who's receiving it, the family, the individual who needs it. Or are we saying, yes, there's that rebate, and that rebate is somehow being passed on to the Nevadan at the very end of it, or you're suggesting that that's never happening? I'm just trying to understand that what's happening from the moment that we're saying we have a reduced price and there's a rebate there, and what's happening at the back end when that bill comes to the hands of the Nevadan. Can you just walk me through that methodically?
Yeah, thank you for the question. So in a normal insurance situation, setting 340B aside normally, the pharmacy would dispense the drug and then get reimbursed by the health plan. And then the health plan that paid the retail price for that drug will receive a pre-negotiated rebate on the back end from the manufacturer, therefore reducing their net cost. So their prescription drug costs are reduced by that back end after the fact rebate. In a 340B situation, the covered entity gets a discount upfront instead. So the manufacturer is not providing both, it should not be, except in situations where things go wrong and there are problems, but theoretically should not be providing a discount upfront on the drug and a rebate on the back end. So that covered entity buys the drug at the discount upfront, and then they are billing the insurance plan, the negotiated rate, and then that insurance plan that paid the negotiated rate is not able to claim the rebate on the back end. So it is increasing their prescription costs, and that savings that was going to reduce premiums or reduce drug insurance costs, that money in the system is now going to the covered entities instead.
And so, because of what I'm trying to understand is, if we're saying there's a reduced price and that reduced price is being billed to the insurance company versus in a different scenario where there's a rebate, I'm trying to understand why we're saying if you're charging a reduced price and you're billing that to the insurance company versus there's a rebate and you're also billing at that point. I'm just trying to understand why we're saying we're paying more if you have a reduced price from the very beginning and then you're billing that to the insurance company. Please help me with that. Yes. And I know that this is your world. Just help me get in there with you, please.
Thank you so much. I appreciate that. So I would say like maybe the disconnect there is that reduced price is not being billed to the insurance company. The covered entity purchase it at a discount, and they're marking up the drug to the negotiated rate with the insurance company. So they are keeping that revenue, that split, that margin is going back to the covered, is staying with the covered entity, and that discount is not going to the insurance company. So the insurance company is not getting the discount that they would have otherwise gotten via a rebate. And so that is increasing the costs that are, the insurance company is not getting a reduced net cost for that drug.
Madam Chair, if I may follow up. Yeah. And I appreciate it. And a lot of this is just you educating me, so I really do appreciate it. I'm trying to understand how that formula then works. You buy it, it's both, and I'm just going to do simple math for purposes of making it easy for me. That costs 10, we're giving it to you at 8, they're buying it at 8, and then you're saying they're billing the insurance company at 10. And I'm oversimplifying it again, but I'm just so that it's easy for me to follow. And if I'm not laying that diagram out correctly, please correct me. How does that happen? Why is it that the insurance company doesn't catch that if it started at this reduced price, that they're not catching that it's now being sold at a more expensive rate? Can you help me understand that?
Thank you for the question. I mean, I think that the insurance companies are aware that is not the acquisition cost for the covered entity, but they have an agreement to reimburse at a negotiated rate. And so different states have different mechanisms, but in generally speaking, that's just the way the law is designed. So, and happy to follow up with you after with additional. I know this is complicated, and so if I'm not describing it accurately, we can follow up with your office or the committee later with more.
No, you are. No, the way you're explaining it makes perfect sense. I'm just trying to understand because I was looking at the slide and you're like, it's driving up costs, it's doing X, Y, Z. And I just wanted to understand why it was not being caught. And you're saying it's known, everybody's participating with this understanding. It's supposed to be at this rate. We agree that we're going to charge it at that and we're going to pay it, send us a bill. So in essence, that's how we're simplifying this as to why it's happening. It's just standard practice and we've all agreed to it.
Essentially oversimplified, yes. Yeah, this is the way the system is currently designed and needs reform in order to lower costs for Nevadans.
Okay, understood.
Hi, my name is Flo Khan for the record. It's FLO and then KAHN. I'm also with Pharma. And I do want to say one of the problems that we have is that we do need transparency at the contract pharmacy level. Because what's happening is you have a number of individuals that are going in to these contract pharmacies. And again, as Daria mentioned, we don't know on the front end, right, who went into a covered entity, because they could be coming from anywhere, right? And so one of the reasons why we need data and the information, particularly that claims data, is to know whether or not that individual was actually seen at a covered entity. And that will help determine when a rebate is appropriate, right, on the back end, whether they're deserving of that rebate from the insurer because they were not seen at a 340B entity, or whether or not a rebate is not due at all because they were seen at a covered entity. So that's why the claims data becomes so important for our industry to have, to make those distinctions on who was actually eligible to receive a 340B discounted price. And that also plays in on the reimbursement side on the back end.
I have a lot of questions. I am going to reach out to y'all directly. And then I will send that to other folk who presented before to help give another angle to that, because I suppose there's another angle. And then hopefully I will have a much better understanding of this in a week from now. I appreciate it.
Thank you for your time.
Committee members. Assemblymember Miller.
Thank you, Chair. And as each question creates more questions and changes it. I've been hearing for years, and it seems that the PBMs blame insurance and insurance blames pharma, and then the practitioners and the hospitals, everyone keeps pointing the finger at everyone. And of course, what we're hearing sounds like a tangled mess of bureaucracy. It seems so simple. Why isn't there just a box that says, did you receive the rebate or not? Again, our goal is simply to get affordable, accessible medication to those people who need it. And yet what I haven't really heard in the conversation is, again, because again, where is the breakdown of getting that to the patient, to the discount? And the question's been asked before in previous hearings and briefings about how do we get that the discount should go to the individual. And so initially in your presentation, you did begin to touch upon what would have been my initial question, which was, how do we do this at a state level? What can we do at a state level to reach this goal? And you mentioned what Minnesota did by asking for transparency from hospitals. But I'm not sure, especially if you're claiming the biggest breakdown is between the pharmacy and the insurance company, then it would seem to me that we need transparency in all of these entities, pharma, the the contracted entities, the insurance companies, the hospitals, and will just transparency is just transparency enough, or do you have specific ideas? And I know you do, because we all sit around work, we all complain, we all text each other, we all talk in the break room about if we could just, and so whatever you're able to share, because I will ask the same questions of the other entities. What is it? This is our goal for our people. And I'm just not even talking Nevadans right now. I'm talking about anyone in the United States because we know the costs are astronomical. What can we do? Is it just transparency, or do you have specific action items or objectives that we as a state could do to, I'll just simplify it and say it, make this affordable for our Nevadans?
Sure. Yeah. Thank you, Assemblymember. Great question. I know it is a lot, and we don't want to just be finger pointing at other parts of the supply chain. We want to try to figure out how everything can work together to reduce healthcare costs. We think that for the 340B program, that requires federal reform to change costs. But what states can do is ask questions, and that transparency is the first step. That's not to say that we don't have other ideas in the healthcare system. We do have proactive ideas to help bring down costs for patients to get access to their medication outside the purview of this particular panel. But when it comes to 340B, we think that the federal program needs federal reform, but states can start by asking these good questions. Daria McGrew.
I think, and this is Flo Khan again for the record, it's a great question. And I think, as Daria mentioned, why we keep pointing to the need for federal reform in this program is you raised a great point. The program was intended to help individuals, low-income individuals who could not access care and who could not afford care. What the program does, however, though, is it's not directed or intended to benefit an individual. It's intended to benefit an entity. And that is where the disconnect has kind of happened. And I think the feds right now are really looking at, we need to get back to a situation where we are helping the individual. And so there's a lot of discussion at the federal level right now that the money, the dollar savings should be going to individuals and not necessarily to entities. Again, that is being debated at the federal level, and because this is a federal program, it's going to have to be addressed at that level. Now, are there things that we could be doing at a state level with respect to this program? Again, understanding we believe the federal venue is the most appropriate. But yes, understanding where the dollars are going today and who's benefiting and how becomes an important understanding at the state level. Because right now, patients aren't necessarily benefiting from this program. There is no requirement that patients see a benefit from the 340B program. As was mentioned, patients are going to be charged whatever the insurance company is charging from their payer perspective. And if you have no insurance and you go into one of these settings, the hope is that they would be able to receive care and receive these medicines at a discounted rate, but there's no guarantee that that's going to happen. And there's no requirement under federal law that happens. So that is the issue that needs to be addressed. And how is that money, that revenue that's going back to the covered entity, benefiting consumers? It may not be directly, and we understand that. It may be that they're going to help provide services to people who otherwise wouldn't have access to services. That's a good thing, but it's important to know. Where we have our most concern lies with the fact that there are contracted pharmacies that were never envisioned, right, to begin with, but now are a big part of the system that are siphoning more and more money away from that covered entity. It's no longer just a dispensing fee. That might be the contract with one particular hospital, but more and more we're seeing it's not only a dispensing fee, but now there's a fee for the third-party administrator, and now there's actually a percentage in some of these contracts going to that contracted pharmacy, most of which have been discussed are big corporate entities, and they're just putting that into profit with no requirement that they have to do anything to provide a benefit to those low-income individuals. That was never the intent of the 340B program. And that is where the rub is from our industry's perspective. So that's on the 340B. You mentioned something else on the other. I will just say, and we will have a discussion later, and so we want to get to lunch, but PBM reform is an important part of looking at and addressing the affordability of prescription drugs. We have found, and it has been reported both at the national level through a number of different reports, that PBMs are driving huge markups of prescription drugs, and they're selling them to their co-affiliated insurers and other parts of the system. So I'm going to stop there because we can go on forever, but it is driving up the healthcare costs, and we do need to rein those in. They play an important part of the healthcare system. We would not argue against that, but we need to have an evaluation of that. Thank you.
And we will definitely be discussing PBM at a later time.
Thank you so much, Chair. Thank you.
Any additional questions? I don't see any. Thank you. As I stated earlier, we are going to go to lunch a little later than expected. If everyone could come back, I'm going to give my folks 30 minutes to scarf down their food. And so 1:50, please. You go with that? Okay, perfect. We will see you at 1:50.
The meeting will come back to order. Our next presentation is from NVPCA on the 340B program in Nevada's federally qualified health centers. Welcome. Thank you for your patience. You may begin when you're ready.
Good afternoon, Chair and members of the committee. I am Nancy Bowen, Nencybowen, the CEO for the Nevada Primary Care Association. We are the association for the federally qualified health centers, also the lookalikes, and also some FQHC tribal organizations. So I just wanted to really quickly, before we get into the meat of 340B again, what is a federally qualified health center and what makes them unique and special? They receive federal funds because they provide services, comprehensive care in underserved communities across our state. The majority of their patients are either Medicaid or uninsured. They do have a payer mix that does include Medicare and also private insurance, but that is the smaller portion of our patients. They are required by law to serve all patients regardless of their ability to pay. So we are really the true safety net in our state. A unique thing about the federally qualified health centers is that 51% of their patients have, or 51% of their board has to be patients. But typically in our state, it is more, a lot of the FQHCs require that all of their board members, which is usually about 10 to 11 members, are patients of their health center. This really helps with governing, and it is governed by the community members. The other thing is that they all have sliding fee scales. So the uninsured patients are based on a sliding fee scale that goes from 0 to 200% of the federal poverty level. Right now, a family of 4, the federal poverty level at 200% is about $66,000 a year. Not a lot. They also provide integrated care. So they start with primary care. Every federally qualified health center has to start with primary care. Then they do integrated behavioral health and oral health, or we have a few health centers that do oral health and care coordination. And those are sort of the primary care services that they provide, but there's a whole list. This is our network. So there are about 14 or 15 health centers in our state that are FQHCs. 8 are Nevada-based. There are about 5 that are based out of state, but do provide services in our state. And then we also have the 2 tribal health centers, Washoe Tribal Health and Reno Sparks. They are both FQHC tribal health centers. And here's a map. So this shows where all the clinics are located throughout the state. As you can see, they're mostly in the urban areas, but we do have several in the rural areas. And a lot of the health centers, there are about 12 health centers that actually have mobile unit, or there are 12 mobile units. I'm sorry, I'm saying that wrong. There are 12 mobile units that go out to the rural areas, and they also do serve the urban areas as well. So in 2024, that is the data that we have at the moment. 2025 is still being calculated. It has to go through the federal review. In 2024, we served 128,000 individual Nevadans at 428,000 visits at 62 clinics, with 12 of those being the mobile units. 88% of the patients are at 200% or below of that federal poverty level, so that's $66,000 a year for a family of 4. And nearly a third of our patients are served in a language other than English. They're best served in a language other than English. So that really speaks to the diverse communities that our health centers serve. And we serve patients that can't be served by the regular market. So 30% of our patients right now in 2024 were uninsured or self-pay. So they're on that sliding fee scale. That's 5 times the national average of physician practices. We anticipate that number is going to continue to rise. I'm already hearing from the FQHC CEOs that number is rising, especially with the impending changes we're going to be seeing. So it keeps going up and up, and that is a very big concern for financial sustainability for our health centers. 39% of the patients are Medicaid, So that looks at 69% of our patients are either uninsured, self-pay, or they're on Medicaid. And that Medicaid number is about twice the typical physician practice. And I'm going to pass it over to my colleague, Steve Messenger. He is our policy director.
Thank you, Nancy. Steve Messenger for the record. This thing doesn't move, does it? I can't move that too much. All right, I am going to attempt to not duplicate anything that you've already heard. You've already learned about what a covered entity is and seen some slides on the types of Nevada organizations that there are. Basically, the two public hospitals, Renown and UMC, the critical access hospitals, are FQHCs. One thing that I think we haven't heard today is the acknowledgement of uninsured Nevadans. We typically have one of the highest uninsured rate in the country. And I think a lot of the 340B discussion has been around, you know, assuming a world that everybody is privately insured and we're just trying to decide which, you know, the dollar should go to the insurance company or the PBM or the drug manufacturer or the provider. It very much does not work that way for us. Like Nancy said, 30% of our patients are uninsured, and we have to find a way to pay for those patients. Not only do we have to find a way to pay for those patients, and that's what we've been talking about 340B revenue today, but those patients absolutely get the benefit of 340B program. I definitely want to dispute the idea that benefits are not going to patients. You saw before, we're federally required by law to have a sliding fee scale that does not turn away anybody based on inability to pay. So when you hear that there's no requirements for how you spend this money, it just does not really sound like the world we live in. You absolutely have to spend all those dollars. So anyway, what can you do with the 340B drug? You get a discount drug. If you have an uninsured Nevadan, which it's about 30% of the people who come in through our door, those savings go right to that patient. They're going to pay whatever they can afford to pay based on that sliding fee scale that's governing the whole rest of their services. So I had my guy look it up today because we were kind of baffled on some of the things we heard. We collected $7 million in 2024 on self-pay charges of about $56 million. So we wrote off almost $49 million. That was, you know, patients paying less than the cost of their services. Okay, so what can you do? You can reduce or eliminate copays. So sometimes your privately insured patients can't afford their copay. We mentioned before, what they're paying for their drugs really doesn't have a whole lot to do typically with the cost of that drug. It has to do with the way that their insurance is set up and their copay. So we can certainly take down their cut of the cost. We can give it to uninsured patients for basically free, or we can get the revenue that we've been talking about, which is dollars that, you know, yes, arguably could be staying with the pharmaceutical manufacturers. Perhaps that they could be passed through to privately insured folks. But what they really were designed to do is what Dr. Porra had on one of his first slides, for covered entities to stretch scarce resources. Congress definitely intended the 340B program to benefit entities. That's exactly what they were trying to do when they leveraged the privilege of doing business with Medicare and Medicaid for the benefit of having to participate in 340B. It was always meant to be something that subsidized our health centers. And while we agree that it has grown nationally, I think that in Nevada, there's not a whole lot of argument that I hear that makes sense for why you would really want to take those dollars away from where they're serving uninsured Nevadans now for some murky benefit. You know, assume a bunch of steps and then maybe your premiums will go down. I don't think that we can expect that. So here's some math for you. 2024, our average patient cost was about $1,900. Our federal FQHC grant paid for 12,821 patients. That was about a third of our uninsured patients. So 340B is our only source of extra revenue. We're not getting beyond cost for any other payer. And you can, as you heard, a third of our patients are uninsured, so we're not getting anything for them. The 340B revenue allowed us to serve an additional 25,185 Nevadans. We actually expect this data to show the revenues shrinking because of the effect of contract pharmacy restrictions. We also have not heard a whole lot about expectations for the uninsured rate to rise in Nevada. I think that we're very much, our members are thinking about this every day. And how are they going to take care of an additional 11% of uninsured that we expect to come out of HR 1? All right, so you have seen this slide before. Contract pharmacies, as Dr. Porath mentioned, these are basically just look like where you go and get your normal drugs for everyone. Here's where they are as far as the rural areas. And you can see we've talked about what it would mean to be, living in Austin and not have a pharmacy if you weren't able to access that discounted drug. But then the urban areas, I think it was suggested that, well, you could just drive to the pharmacy where you could get your discount. Most of our patients, it's not that they don't have lives that are that easy, right? They are not just able to drive across the valley to a specific place. And when they go to access healthcare, it's very critical that it be in the neighborhood that they're in. With public transportation in the valley, it takes a long time to get anywhere. And these come with childcare costs, and they come with costs of missing work. So, we definitely defend the idea of contract pharmacies being in urban areas as well as rural. I mean, again, it's like, well, why would you want to take that dollar out of clinics that are serving Nevadans and give it to someone else? So here's the three-legged stool of FQHC finance. Medicaid's worth about 31%. 340B is worth about 12%, and that's slightly larger than our 340 grant of 11%. I think you have seen the problem. Oh, one thing that also wasn't mentioned today is the 2023 AB 434. There was mysterious talk of vertical integration and PBMs capturing the benefits. This committee passed a law in the 23 session that prohibited pricing discrimination on 340B drugs. So that means that just because the PBM knows that we were getting a 340B price, they can't then adjust what they're paying us. They have to give us that wholesale acquisition cost. That's what they pay everyone else for that drug. And that's really the special sauce of how we're able to care for those uninsured Nevadans. So I think that we've pretty much solved that problem. That's not really the problem that we see. As far as that, we were getting a lot of money captured, before we passed that law. Now it's really all about these contract pharmacies and are we able to have our patients get drugs in their own communities. While I'm there, also there was talk of Medicaid. Dr. Porath did a good job on this. It's just not true that Medicaid is missing out on any benefits. If it's a 340B drug, we pass on the 340B price per Nevada law. If it's not a 340B drug, they get a rebate on the back end. There's just no, in other states, FQHCs are allowed to bill, for example, Medicaid managed care. And so, hypothetically somewhere else that's a problem, but it's just not true in Nevada. Here are just a short list of the pharmacy restrictions that we are tracking. And while I have that, I did a little bit of research too. So while you got some of these names up, we're talking about the three largest pharmaceutical manufacturers have profits that are measured in the tens of billions. Eli Lilly, 54.2 billion profit. AbbVie, 43.0 billion profit. Johnson & Johnson, $94.2 billion in profit. We would argue again that Nevada's safety net is a better place for these dollars to be and in protecting them than somehow subsidizing or putting the benefit back to pharmaceutical manufacturers that seem to be doing fine, growing their business fine. It's going to grow from $549 billion this year to $881.5 billion in 2031. So they are growing about the same rate of the 340B program, we would argue. You've seen this map. Glad we got it pretty even. I think that Renown said 22 states. It's probably because they've got a better association tracking this. But I would dare anyone to find any partisanship in this map. You can imagine what Oregon and Washington and Vermont have in common with Oklahoma and Mississippi and Missouri. It's really much more of a function of which states are inclined to protect their safety net and which have strong pharmaceutical constituencies. So the solution, we agree with Renown. I think that there is maybe some change to the specifics of the suggested legislation in reaction to some of the lawsuits that have been going through. But we basically agree the same thing that this committee, well, that the Health and Human Services Committee decided to put forward last session, which is a ban on discrimination against contract pharmacies. And with that, I will stand for any questions.
Thank you for your presentation. Before I pass it to committee members, I just have one quick question. On your PowerPoint page 16, the revenue streams, the 340B, the number you have attached to that, is that gross or net?
That is gross. No, sorry, excuse me. You're talking about, no, this is revenue. So this is not cost. We don't have any profit left over at the end of the day. So we, like, our balance sheet goes, you can look it up 2 years late, as Nancy mentioned, but you can go and you can look at the 2024 expenses and costs for FQHCs. And, there's very little retention there. They're operating on razor thin margins because it always goes to adding one more uninsured patient that they serve.
Are you able to provide those documents to the committee?
Certainly.
Thank you. Committee members, are there any questions? I don't see any. Senator Ellison?
Thank you, ma'am. I didn't have one, but I do. And I'm looking at the chart that was on there where it showed the state, United States, and then it goes down in the orange and it shows Nevada is 0. It says no. But is the pharmacies going into the red to where we might lose some of the smaller pharmacies into bankruptcy?
Thanks, Senator Ellison. Steve Messenger for the record. I don't have any information about pharmacy revenue or who might be in trouble. Is this first of all, am I showing the right slide?
Yeah, well, I was looking down at the bottom. I can barely see it. But if you look at Nevada and it says orange, you look way down there and I can barely see it. So.
Okay, yeah, no, you're correct. Nevada currently does not have contract pharmacy protections. That's what we're asking to join the green group.
Okay, but is there any way that any of these might be in trouble that they could actually end up in bankruptcy or disclose and move to another place?
So Steve Messenger for the record, again, I don't have specific information on the contract pharmacies themselves. Our FQHCs are certainly in danger. I mean, if we go from 30% to 40% uninsured, we are going to have to find more solution. Even with 340B, we don't have the existing resources to absorb that kind of expansion of the uninsured population. So yeah, there are definitely conversations being had about what services do we cut, what sites do we cut, how do we, shrink to be the right size to be able to prepare for this.
Okay. Well, thank you. I appreciate that. Thank you, Madam Chair.
Any additional questions, committee members? I don't see any. Thank you so much for being with us today in your presentation. Our next presentation is with Intermountain Health in Nevada. Welcome. You may begin when you're ready.
Good afternoon, Chair Marzola and members of the committee, and thank you for the opportunity to be here. For the record, my name is Damon Schilling, SCHILLING, and I serve as the Director of Government Relations for the State of Nevada for Intermountain Health. Excuse me. At Intermountain, my role is to help strengthen partnerships between healthcare systems, government, and the communities that we serve to improve process, affordability, quality, and health incomes for Nevadans. For those who may be less familiar with Intermountain Health, we are a not-for-profit integrated health system committed to helping people live the healthiest lives possible. We provide care across multiple states through hospitals, clinics, medical groups, virtual care, home-based services, and a health plan, all focused on improving the quality and access while lowering the total cost of care. In Nevada, Intermountain entered the market with a commitment not just to grow, but to invest in the state and become part of the fabric of our communities. Since that time, we have expanded services, invested in physicians and caregivers, advanced specialty care, strengthened community partnerships, and are continuing to make significant investments in the future of the healthcare of Southern Nevada. Today, I am honored to introduce Russ Williams, our new president of Intermountain Children's Hospital, and one of our key leaders in helping shape the future of pediatric healthcare in Nevada. Russ will walk the committee through Intermountain Health's footprint in Nevada, from our market entry to where we are today, and the vision for where we are headed in the future. Chair and the rest of the committee, thank you again for your time and consideration. And with that, Mr. Williams.
For the record, Russ Williams, RUSSWILLIAMS. Thrilled to be here to present a little bit about Intermountain Health and then specifically Nevada Children's Hospital that we'll be breaking ground on later this year. So as Damon mentioned, our mission and the elements that I would want to highlight here is focusing on extraordinary care with superior service at an affordable cost. And the way that we best do that is that very bottom right circle that we're better together, coming in here to partnership, to augment, to build upon, to fill gaps in care. And hopefully you'll see more of that throughout this presentation. A broad strategic framework, but the one I'd like to focus on is, again, bottom right, is extending our reach. Another way to say that is care closer to home. Distance is a barrier to care. So anything we can do to bring the right care at the right place at the right time with the right price is certainly value added work. Intermountain in general, it covers 6 primary states, over 68,000 caregivers, 5,000 of those being employed physicians and advanced practice providers. We fall within the desert region of Intermountain Health. And so there are currently 3 hospitals, Nevada Children's Hospital to be the 4th hospital there, over 6,000 caregivers and 768 employed physicians and advanced practice providers within the desert region. One of the things that we've done to be able to expand the ability to provide more integrated care, to build a continuum that really looks at the whole person from all the way primary care to specialty care and beyond, is some of the partnerships that we now have within Clark County specifically. Steinberg Diagnostic is now part of Intermountain Health as a way to further integrate, make sure that there's appropriate access, all the information flows back and forth the way that it needs to so that timely care can be delivered. A partnership with Corvetti Orthopedics and Sports Medicine. And then a very unique partnership with Shriners. Shriners will be the primary orthopedic provider at Nevada Children's Hospital. They remain independent. They're Shriners. They're not owned or had not been purchased by Intermountain Health, but they'll be practicing within our building on our electronic health record. So again, there's that seamless continuum of care for all of the children that will be seeking care with Intermountain. Focus areas now and into the future, and this is where in my role as the president of Nevada Children's Hospital, we'll speak much more specifically about pediatrics than about anything else. The very first thing we're doing, and this has already started, is growing our pediatric subspecialists here in Clark County. There are a number of specific specialties where there just are insufficient numbers to meet the demands and the needs of the children in Clark County.
and beyond. Things like pediatric neurology, pediatric endocrinology, pediatric rheumatology, pediatric pulmonary, many of the medical subspecialties where children just have to wait far too long or go without certain care. And so focused right now on growing that. The reason that we're growing these specific services is this is what the pediatricians in the market have told us they need. They're not necessarily the ones that generate a whole lot of revenue. We don't have a hospital at this point in time, but they said this is what the kids of the area need. And so that's where we're starting. Working also and have a pediatric clinically integrated network that is established and is now growing. That is an opportunity where we can bring together the pediatricians, general pediatricians, and subspecialists into an organization that can share data for quality improvement and safety improvement purposes. And then we can also provide certain benefits that just allow the practice that wants to remain independent, like group purchasing, vaccine access, et cetera. Things that a small practice can't do on its own, but as part of a larger organization has an opportunity to do that. And then clearly designing and constructing the children's hospital. We actually showed this next picture for the very first time to the county commission yesterday. We did receive our final entitlements approvals just yesterday. So it was a really big, very fun day yesterday to receive that. But bringing what we believe will be not only a beautiful building, but a truly comprehensive and standalone children's hospital. An opportunity under one roof for children to get a comprehensive level of service from primary care up to the highest level of specialty care needed. And very, very excited about that, about the facility. For those of you who might not know where it is, being relatively new to Las Vegas, my understanding is that most people in the state know where the IKEA is. So this is just north of IKEA, just on the north side of 215. That IKEA is on Durango. The hospital will also be on Durango. So hopefully, a relatively accessible place. It's hard. You can only put a big hospital in one place. We'd love to put it in 5 or 6 different places, but the consolidation of services is very, very important. Now, scope of the hospital will open with roughly 180 beds and really a comprehensive level of services. We'll have inpatient behavioral services, we'll have cancer, we'll have neuro, we'll have cardiothoracic, we'll have a emergency center that will open in pursuit of level 2 trauma. And we heard great discussion on the care capabilities that are needed for that. We'll have a neonatal intensive care unit. So really a full service children's hospital to be able to provide the needs of this area and much beyond. And I'll talk about that in a minute. Overall timeline and schedule, we are currently in the construction documents phase of design. That's the very last phase where they draw every single outlet and every door handle on every room throughout the plan. And with that entitlements approval that we received yesterday, we are on track to break ground later this year. It is a 40 to 44 month construction process. And then you'll notice a light pink, or maybe it's a salmon color in 2030. And it's a very simple term that's called activation, but I did want to spend a little bit of time on what happens in that activation. When you open a brand new hospital, you are bringing together not only a whole bunch of new providers, staff, pharmacists, et cetera, but it's people who have never worked together in great part. So we will spend a significant amount of that time doing active simulation in the space where they will work. We will work through every challenging clinical scenario that anybody can throw at us so that we have done the rehearsal, we've done the practice. So when the light turns on and that first patient shows up, nobody acts like it's the first patient that's showing up, that we're in a routine and can provide the level of quality and safety that people should expect from Intermountain Health. In addition to that effort, I did want to talk about the 5 crucial components that we're focused on right now. First and foremost is behavioral health. I don't know that it will be a surprise to anybody to know that the country And certainly Nevada suffers from a lack of appropriate behavioral health resources, especially for children and adolescents. We're working on putting a continuum of care together. And what I mean when I say that is embedding appropriate caregivers in primary care offices to be able to catch things before that child ends up in the emergency center or needs to be on an inpatient unit. Partial hospitalization, intensive outpatient, psychiatry, psychology, master's prepared behavioral counselors, so that children can get the right care as early on as possible. Within our primary care practices, we start anxiety screening as young as age 7 and depression screening at the age of age 12. Well, if we do that anxiety screening and that 7-year-old needs additional help, where do we send them? The perfect answer is right down the hall to the behavioral health counselor that's in that primary care clinic, so that literally the second we realize that there might be an issue, we're providing an appropriate care location for that child. Partnerships, engaging as broadly as we can in the community. We are coming here to partner, and partner in any way that our partner would like to partner with us. We do have a focus on philanthropy as well. There are a number of the wraparound services that we tend to offer at comprehensive standalone children's hospitals that are not reimbursed. Things like art therapy, music therapy, our child life program, school teachers, so that children don't get too far behind in their education. And we'll rely on philanthropic support for many of those programs. With physician alignment, I talked a little bit about the clinically integrated network and about some of the partnerships we've done. We are open to partner in any way that makes sense. If people want to be on the medical staff at our hospital and want to remain independent, fantastic. If they would like to join Intermountain through an employment agreement, great, happy to talk about that. Anything and everything in between, we're willing, and that extends to academic partnerships. And previous speakers have made really right on the money comments about the true future for all of us, and especially a standalone children's hospital, is growing our own clinicians. And that's true for pediatric subspecialists, and it's true for nurses and pharmacy techs and everybody that we will need at the hospital. And so working very closely with UNLV, with Turo, with Roseman, and I shouldn't have started naming names because I'll leave somebody out that I didn't intend to leave out, but a deep commitment to partnering effectively so that we can also support the workforce of the future and offer them opportunities at our hospital that they might not be able to get anywhere else in the state. In closing, I love the phrase, our kids can't wait. When I'm talking with parents, the key message I get is, why is it going to take until 2030 to be able to open the facility? And we're moving as fast as we truly can. And I'm really grateful for all of the help and support that we have received to date, and look forward to partnering and engaging even further to improve the health of the children of this region.
Does that conclude your presentation?
Yes.
Thank you. And you did leave someone out. You left UNR out.
I did. And I knew I would, which is as soon as I started naming names, I'm like, I'm in trouble. So
It's
thank
fine.
you.
Thank you for your presentation. Committee members, are there any questions? Assembly Member Kasama?
Thank you, Chair. In general, I feel like we need just as many healthcare providers as possible. We have such a shortage throughout the entire state for all kinds of services, whether it's the hospitals, clinics, or pharmacies. We just, everything is short. And so, but I was just curious as far as, obviously we have the Sunrise Children's Hospital, and then I know you keep mentioning this is a standalone. Is there a difference? I mean, the other one is connected to the hospital. This one is the is it the same? I'm just wondering, it seems like, grammatically we have a difference there. Is it complementary services, just providing more to our community? Just, if you could just elaborate on that a little bit, that'd be great.
Yeah, Russ Williams for the record. I'm happy to answer that. I want to make sure that no comment I make would be taken as being negative towards any of the fantastic care that's being provided. So, I mean, there are elements of it that will be consistent. There are a lot of the offerings we will offer, will be the same. We do think that there's insufficient amounts of that. And then I do think the way I talk about a standalone children's hospital is that when you walk in that door, every single person that walks into work that day is solely focused on the care of children. And again, that's not to say that there aren't phenomenal caregivers everywhere, and I think we'll have phenomenal caregivers as well. But we do have the opportunity to be solely focused on the care of children, and we tend to be able to then also provide just a depth of service in some of those medical subspecialties that might not be available other places. Again, I can speak to what I know our plans are, and don't want to speak to what anyone else does, but confident that from an expertise standpoint and from an experience standpoint, we'll provide world-class exceptional care.
Any additional questions? Senator Ellison, do you have any questions? I don't see him. Welcome to Nevada. We are very excited to have you guys here. With that being said, I think we can all agree we have a shortage when it comes to healthcare providers in our state. And so my question is the intent to bring additional providers here, right? So we can help this massive amount of Nevadans, with you guys specifically children. I guess what I don't want, right, for what I'm thinking is, people come here and then they start, I don't want to use the word poaching, other weather doctors or what have you, and then we are in the same scenario, right? We still have a shortage. And so is your intent to bring other professionals here who are specialized, so our healthcare isn't at the bottom of our country and can slowly but surely start to rise because we do have specialists here?
Russ Williams for the record. Absolutely. I would say bring specialists here and then assist our colleagues to grow more specialists for the future. We have done the analysis specific specialty by specific specialty and looked at what we have in Clark County, what we have in the state of Nevada. How does that compare with the national average? How does it compare with Colorado, with Utah, with Arizona? And almost to a specialty, we are short regardless of who the comparator is. So this is about bringing new capacity, new depth of specialty coverage to the state of Nevada. The other thing that helps us do is it will create a destination of care. The kids from Cedar City and St. George, Utah, from Northwestern Arizona, from Southeastern California, in addition to that, we'll then have that comprehensive ability to draw and provide that full continuum of pediatric, general, primary, and specialty care.
All right. Thank you. Vice Chair.
Thank you so much, Chair, and thank you for the presentation. I think all of us are excited to see more healthcare options, especially for pediatrics. And this is really a follow-up to the Chair's question, but with the current specialty, with the fellowships, with the residencies that Intermountain Health has now, are you looking to bring in any pediatric residencies?
So at the right, we've got Russ Williams for the record. Thank you, Damon. So short answer is yes. Longer term answer is that I would say residencies and fellowships over time. And one of the things that I think we will be uniquely able to offer is in some of those really, really hard to find pediatric subspecialties, that we will have the medical staff that would also be able to support residents and fellows in those subspecialties. So when you look at pediatric neurology, there are not enough pediatric neurologists in Las Vegas right now to take care of the children, let alone to also provide residency and fellowship opportunities. So as we recruit in from the outside, not only can we provide the care, but we'll have that depth of service that would then allow us to create fellowships specifically, but residencies as well in those extra hard to fill pediatric subspecialties.
Thank you so much. I think one of the things that parents never want to hear when they get the worst news in the world is that they have to leave the state for the care of their child. So I think a lot of us are very excited to see more pediatric fellowships, residencies, and this children's hospital open. So thank you.
Any additional questions? I don't see any. Excuse me. Thank you for your presentation today and waiting all day with us. We do appreciate it.
Absolutely. Thank you for your time.
Of course. Our next presentation is on an overview from the Board of Medical Examiners. Hello. You may begin when you're ready.
Okay, thank you. Presentation will open. Or do I need to click on it? Sorry about that. Good afternoon, Chair Marzola and members of the committee. Sarah Bradley, I'm the Deputy Executive Director at the Board of Medical Examiners. And I do send apologies from Dr. Spiritos. He is the board president and did intend to be here with me today, but he was called into surgery this afternoon. He sends you all thanks for the hard work that you do, and he hopes to join us next time. The board issues a variety of license types. This is just a list of all of the kinds in each one, but essentially we have 6. So we have physicians, and that is medical doctors, because there is a board that licenses the doctors of osteopathic medicine, which would be the DO degree. Physician assistants, practitioners of respiratory care. They're often called RTs, but our statute calls them this. And it's a lot of words. I have to always take a deep breath to say it. Genetic counselors is a newly licensed profession. We just started that January 1st. Perfusionists and anesthesiologist assistants. So for an overview of the licensing process, essentially all of our applications are available online with the exception of genetic counselors, because we are just now implementing that. That will be online shortly as soon as we can. So essentially the applicant would submit the application online, pay the application fee. Then the applicant's file would be opened and board staff would run initial reports regarding that licensee, or the applicant, excuse me, and it will be assigned to a licensed specialist. The way we assign to licensed specialists is actually done by last name. And so that's how those assignments are given, unless it is the Interstate Medical Licensure Compact. We'll talk about that, but we have a couple staff members who are assigned just to those applications. The licensed specialist will review the application, make sure it's complete, and they'll also double check to make sure the person's eligible. Sometimes we do get DOs applying to us for licensure, and we forward them to the other board for that. We then would send an acknowledgement to the applicant and tell them we received your application and here's the things that we're waiting for. We also would send them the fingerprint card and ask them to complete that. We are doing that electronically now, and that's a new and a kind of a more exciting thing we've been able to do the last 2 years. And that licensed specialist, again, is assigned that person, and they would stay in contact with them throughout the process. So this way the person has one person to talk to that's monitoring their file, answering questions for them, and hopefully fully aware every step of the way where their application is. After all of the documents are received, so we're talking about transcripts from school, verifications of residency and other training, exam scores, proof of certification for most of our license types, then it would go to final review. So essentially that licensed specialist says, yep, everything's here, the checklist is complete, and then it goes to another person. It's either a senior licensed specialist or our deputy or chief of licensing, and they would review that application just to make sure truly everything is there that needs to be. And once that's done, then the person would be approved for licensure, and they're notified then that they're approved, and then they can log in and pay the registration fee and their license will be issued. If there's missing items or corrections needed at that stage, it would be referred back to the licensed specialist and they would reach out to the applicant and ask for those things. So I mentioned the Interstate Medical Licensure Compact. This allows much more quickly for physicians to be licensed in Nevada. Right now, there are 41 entities, so it's 39 states and 2 territories licensing through the compact. And so that would allow someone, if they're licensed in one of the member states, I'll use Washington for an example, they have a license in Washington, they can then ask that the Washington state issue a state of principal licensure. So it does convert their license just a little bit for that, but then they can go to any of the member states, including Nevada, and be licensed in a matter of days. For us, it's 1 to 3 business days. Essentially, the day after we receive that letter from that other state, we can issue the license. So it is it's much more expedited, and we are excited that there's so many member states now in the compact. I think that just a few years ago when I spoke in front of one of the other committees, I think it was Health and Human Services, we were at about 35, and so we're over 40 now. So I've given you a graph here that does explain that. Oh, I can go back if you want. I realized I was on that a little bit fast. So there are 5 states that are gray, you can see on there, that have not started the process to even join the compact. And one of those is unfortunately California, which is right next to us. And it might be nice if they, there'd be more portability there. Another one that's close to us is Oregon. And for some reason, they're not a member yet or even starting that process. So if we want to talk about total licensees in Nevada, I have that for you here on this slide. And this is as of April 30th. So my numbers are as April 30th was the cutoff that we did. So we have a total number of licensees in the professions that we license of 19,231. As you can see, we do have a handful in comparison of inactive licensees. For physicians, there are 14,632 licensed physicians, and I've kind of laid it out for you regarding license type. For residents, you'll note on here we have 564 residents. So that's not a lot, but those are the doctors that are in training in Nevada. And I know research shows if they do their residency here, they're more likely to stay here. The other interesting thing to highlight is we have a specific license for telemedicine, and we only have 140 of those. Most of our practitioners doing telemedicine have that unrestricted license because then they can do anything. If they have a telemedicine license, they actually agree to only practice via telemedicine, so they couldn't see someone in their office. We have approximately, we have 600 inactive physicians, and then we have 1,818 physician assistants. We do have 75 right now that are inactive. That's actually a new option for physician assistants. Prior to recent legislation in 2023, they weren't able to go inactive. They actually were just all active or not licensed. We have 2,003 practitioners of respiratory care, 75 genetic counselors, and that number I know is growing every day. We have a very active and interested population of genetic counselors excited to provide care in Nevada. 94 perfusionists and 9 anesthesiologist assistants. I was asked in the request to come today to talk to you about healthcare in the rural areas and licensees. And these numbers are definitely very low, but I want to tell you how we obtained them. So what I gave you on this slide is all of our license types that have addresses that are not in Washoe County or in Clark County. And it's just the public address that they provided to us. That's what I'm able to pull and analyze. What this does not show you, and what I know to be true, is that many, many, many of our licensees travel to the rural locations to provide care. And I also can tell you, the governor's office asked for some information back in November, and I did a little analysis to them. And I was very surprised that at the time when I looked at active physicians, we had 51% of our physicians had an address outside of Nevada and 49% with an inside Nevada. So that tells me that many, many, many of our physicians are providing telemedicine care or they're coming here on a limited basis. So if they live, for example, near the Utah border, they may come several days a month or a week or whatever it might be to provide care in Nevada, because of course they do have to be licensed here if they're providing care here. In the last year, so our from July 1, 2025 to April 30th, we have a total number of new licensees of 2,297. So we've added in that time period 1,858 physicians. However, you can see there on that unrestricted number, more than half came through the compact. And so again, that's that faster way to be licensed, but also those licensees are most likely to not live in Nevada or have an address in Nevada, probably providing telemedicine care, coming here for specific situations, maybe doing radiology or something else where they're really providing care in different time zones and assisting in other ways. We also issue special event licenses for individuals who come here to do demonstrations or things like that at conferences, and where they will be actually providing care in that demonstration to a patient. And then again, telemedicine licenses, we added 25, but I really think most everyone is getting the unrestricted license through the compact probably, and providing telemedicine in that way. We added 220 physician assistants, and 33 of those are also licensed with the DO board. And that's just interesting to note because there is that simultaneous licensure for that category. Practitioners of respiratory care, we added 147. Genetic counselors, we added 75 because we just started that in January. And then perfusionists, we've added 12, and anesthesiologists, we've added 5 since July 1 of last year. And we have not had any application denials in that time period. So the average licensing time, again, in that same time period for physicians, and this includes the interstate medical licensure compact, it would be 35 days. And if we're not including the compact, the average time was 92 days. And then the fastest time for someone not being in the compact is 8 days. And I can talk about some of the reasons for the time period you see. A lot of times the reason is they submit their application, but they haven't requested transcripts, residency verifications, other things like that, that sometimes take time to reach us, unfortunately. The person, I can tell you that the 8-day person, that person had to have requested all of that prior to their application. And so that way we were able to receive the application. We had all the documents. They were licensed in just over a week. Physician assistant average licensing time is running at 63 days in that time period. Practitioners of respiratory care, 71. Genetic counselors, 18 days. Perfusionists, 31. And anesthesiologist assistants, 55. So we are working on things we can do, and we have been, to try to increase our licensure times. Oh, and I did want to note that last time I presented in front of the Joint Interim Standing Committee on Health and Human Services approximately 2 years ago, our licensure numbers, those days were a lot higher. So we have reduced our numbers. In most of those categories, it's about half reduced. But we're working on getting new licensing software. We're hoping that that will help us interface better with our applicants and our current licensees. One of the things we added the system we have now in 2020, and it was what I was really excited about, and I think many others, is we have a portal. So a licensee and an applicant, either one, can log in and see their information, update it, things like that. So that's really helpful. We do want to add a chat function so they can chat with staff about different things as they go through the process, bring enhancement to the portals when they do log in. One of the biggest things was in 2020 when we implemented it, they could change their address real time online. Before that, we had to have forms sent to us to update addresses. And it also would allow the new software entities to create an account so that they can track and pay for residents. That's something that we kind of work out with the different programs because we don't have a way for them to do that in as streamlined a way. We do have regulations pending to implement a priority processing procedure for applicants that will be practicing in that underserved area or specialties that are designated as underserved, pursuant to the 2 bills from last session that asked us to do that. So we do have those regulations pending, and we will be having them on our board meeting on June 5th for the board to hopefully review and adopt, and then we'll send them to the Legislative Commission. Other changes that we have done to try to help speed up the time from a person being licensed to working. So obviously getting a license is only one step needed to work in Nevada. And so what we have done here is in our bill, we brought changes to NRS 630.336 that would allow us to share information with credentialers, employers, other people credentialing licensees. And then in the governor's bill in the special session, SB 5, there was it added to that and said we have to have an electronic system that will allow those entities to verify the licensure. We are working on putting that in place. Again, we're working on getting a new licensing software, and so this will be a part of that. So we may not have that automatic query at this time, but we can share documents with people that ask us if the applicant, of course, authorizes that. And so the goal would be to speed up that time from I have a license and now I have to wait 2 to 3 months for the hospital to credential me to work. Potential bill draft requests that we think we may bring this coming session. One is just some administrative cleanup and updating a few outdated areas. We know that there's a concern among all of the healthcare boards regarding medical spas and regulation of those. I know that's also a priority of the Nevada Health Authority. And so I think hopefully we'll all work together in some way to try to address that better, because we have had some very unfortunate incidents regarding that area. Also, we are working on removing, there's a requirement right now in Nevada that our practitioners of respiratory care have to have 2 licenses, one with us and then one with the Nevada Health Authority as a laboratory personnel. We tried to change that last time, but we didn't get it. The bill wasn't written quite right to get rid of that second license, so we're working on that. My understanding is we're one of the only states in the country that requires that 2 licenses for them. We are also updating some intern requirements for practitioners of respiratory care to make that more usable so that they will be able to graduate and be working while they're waiting to get certified and take their exam instead of having to be already certified to work. There's some thought about adding nutrition and metabolic health continuing education. I know a lot of that has to do with the Rural Health Transformation Grant. And so we are looking at what we can do there to require that and include that as a continuing medical education. We're not sure exactly how that will go and who will lead that, but that is a conversation we're having. And then we would like to enact both the Physician Assistant Compact and the Practitioner Respiratory Care Compact. Right now, the Physician Assistant Compact is working and has enough states in it that it's issuing licenses. The Respiratory Care Compact is not yet. I believe there was 11 states when I looked last. So it's not active yet, but we're hoping it will be, and we'd like to be included as one of the first states to enact that compact. And I am ready for questions, Madam Chair and members of the committee.
Thank you for your presentation. Committee members, are there any questions? Assemblymember Kasama.
I have 2 questions if possible. One is easy. Forgive my lack of knowledge, but what is a perfusionist?
Oh, that is a very wonderful question, because when I started at the board, I had to look it up. Perfusionists they have a master's level education, and they assist physicians during usually heart and lung transplants, as well as heart surgeries. Not all heart surgeries, but a lot of heart surgeries. Basically, it's when the body is on a bypass machine of some kind. They help run that. They also assist in harvesting of organs, again, in that helping with the machines that are needed to keep the person alive and monitor that.
Oh, thank you. The other question I had was, you had the overview of the licensure process, and I think we've all heard, one of the frustrations with our state was the delay in licensing and getting more people in here. So it's fantastic to see how that's been speeding up. And but I had one question here. There's no page number here, but licensee specialist stays in contact with applicant to obtain all necessary documents and verifications. You have, for example, verification, postgraduate training, and other things. And you happen to mention when you were speaking, like exam scores. Mm-hmm. And I'm just wondering, for example, why would we need that? I mean, it'd be nice if everybody that, we went to had a 95 plus on their scores and that, but why are we asking for that? If they've been in good standing, let's say in California, which is not part of the compact. So if they've been in good standing in California, almost like a compact for 20 years, a good practicing physician, they come over here, they have no, violations for their license, again, in good standing. Why would we ask for that so long as we get their, their school, they've graduated, they've passed the exams, and they're in good standing? I guess I'm confused why we need more, and perhaps that would help speed it up.
Sarah Bradley, thank you for that question. Basically, when I say exam scores, I mean proof that they've passed the exams. We're not really looking at specific scores. The USMLE, at least for physicians, it's the United States medical licensure exam, they set the passing rates. And so really what we need to know for licensing is that they have passed them, and they've passed them in the time periods that we have allowed. So no more than 9 attempts total on all 3, and the time period that they took them. Most likely California, may already have that same rule. I don't quite know, because again, we don't have, they're not in the compact, so they may have some different requirements, but really it's just making sure they've passed the exams. And then for the other license types that we issue, they need to be certified to be licensed. And so really what we're getting is a verification of the certification from that national entity that will tell us they've passed the exam.
I see, that makes more sense. Thank you.
Any additional questions? Senator Ellison, do you have a question? We will move on. I have a quick question. So when we're talking about yes, the average time for licensing here is quite extensive. 55 days for anesthesiologist assistant, 63 days for a physician assistant, 92 days for a physician. Just seems like a long time, especially when we have such a shortage here in our state. And I know that in your slide, you said that you guys are actively working on getting the new licensing software. Can you tell me where you are in the process and how long that process is going to take? And what do you see, if you can see, in the future of the wait times for these licenses to be a lot less?
Sarah Bradley, thank you for the question, Chair Marzola. We are actively talking with vendors now and receiving, I think, demonstrations and things like that. So we're doing some research at the moment regarding which software may work best for us and our needs. So that's where we're at with that. I don't know exactly the timeline wherein we'll have that chosen and implemented, but I would be glad to follow up with you on that as we work forward on that. And as far as licensing times, I think that a new software will help us in some ways, but much of the licensing time is really waiting for the information that's necessary to support that application. So once we have a complete application, meaning we have the transcripts, training verification, certifications, if necessary, verifications, the person is licensed within generally 1 week. Because we have everything, it is sent over to final review, and that's about 7 days, I think, on average. Often less, I think it's about a week, and then they'll be notified that they're approved, and then they can pay the licensing fee. So the times you see on here are really us waiting to receive the documents that we need to complete their application and approve it for licensure.
Thank you for that information. So when we have folks coming to us and complaining about the wait time, it's really on them not having their entire file complete and not necessarily you guys. But if you can come back to, you don't have to present, if you can just provide us with the information of some sort of timeline of when your office is going to decide on which software you're going to go with and when that implementation is going to happen.
I would be glad to. Thank you, Chair.
Perfect, thank you. Members, any additional questions before we end this? Thank you for being with us.
Thank you.
Our next presentation, we will hear from the Nevada Pharmacy Alliance. Welcome and thank you for being with us. You may begin when you're ready. Please remember to state and spell your name for the record. We can see your presentation.
All right. Good afternoon. For the record, my name is Evan Williams. That's EvanWilliams. I've been a pharmacist for about 15 years. I've been licensed here in Nevada for about 10 years. And I'm going to speak today a little bit about pharmacist training and maybe a way that we can try to help bridge some of the gap with access to care for Nevadans. The committee today has already kind of acknowledged that there is a problem with limited access to primary care provision here in the state. Nevada currently ranks 48th for primary care physicians per 100,000 residents and would need something in the neighborhood of 2,300 additional physicians to meet the current national average. One of the things that might be able to help this is that we have over 2,700 pharmacists licensed in Nevada and living here. These individuals are highly qualified healthcare professionals who have the education, clinical training, and expertise, and oftentimes postgraduate training to provide some of these primary care that's needed for our people in the state. And so we have the training and expertise to help bridge that care gap. Two main barriers kind of exist to really fully implementing this, and that has to do with legislative barriers related to scope and then getting paid for the services provided to ensure that we can have these as sustainable practice models. Starting with pharmacist education and training, I've been an academic here for about 15 years now in my professional role. To become a pharmacist, you must graduate from a graduate professional degree program. The entry level degree for the pharmacy profession right now is the Doctor of Pharmacy degree. In order to sit for your licensure exam, you must graduate from an accredited college of pharmacy and earn a Doctor of Pharmacy degree before sitting for the North American Pharmacy Licensure Exam, or NAPLEX. Once that's passed, pharmacists are able to go and practice. However, many do choose to pursue residency training post-licensure to specialize in areas such as cardiology, outpatient medicine, psychiatry, critical care, things like this. During training, pharmacists get quite a bit of information about pharmacology, pathophysiology, pharmacotherapeutics, and patient assessment. And there's quite a bit of clinical exposure built into the requirements. The Accreditation Council for Pharmacy Education requires that a minimum of 716 hours of clinical practice hours prior to graduation. In many schools of pharmacy, you're going to require more than that. The basis of pharmacy practice is rooted in evidence-based medicine and clinical guideline-directed patient care. One of the ways that this is instilled into our students is through something called the pharmacist patient care process, which begins with collecting patient information, interviewing patients, assessing data that would include stuff like lab work, the management of their current disease states, what other medications they might be on, and how those would work together. A plan would be created. Oftentimes this plan will include referral to other providers that have specialty training in those areas. And then implementation of that plan and follow-up, which would include monitoring, which also again, usually includes lab work as you go forward. A lot of, I think the common perception of pharmacists and pharmacist training is that, you tend to encounter pharmacists in community pharmacies, and you're thinking that they must be really well trained in how to dispense medication. And that's not quite the case. And it really probably hasn't been the case for the last 20 or 30 years. Pharmacists are really educated in how medicines are used to treat disease. And that basis of information is used then to make good decisions while dispensing medications. But it also allows them to provide other services, as you can see through that pharmacist patient care process. Historically, that dispensing medication pathway really kind of focuses on that drug product and the pharmacy benefits manager and that payments pathway that we've already kind of discussed earlier today with some other presenters. If we're talking about clinical services, though, and helping with some of those primary care tasks, that's generally billed through the medical benefit, and that requires a little bit of a different model to approach that. When we're talking about data supporting pharmacists providing clinical,
I don't want to interrupt you, but if you're trying to change your PowerPoint, it's not changing.
I'm not sure what is displayed here currently.
You're about to get some help.
Okay. So I've just presented all these slides with nobody seeing any of this.
But we were paying attention to every word.
All right. We are on the second slide, is that right?
We should be on page 3.
Madam Chair, can we just start the whole day all over again, please?
Please. I'd like to see presenter view. I was not able to do that. All right, the slides are changing now. All right. Thank you for that support. I apologize for running through all of that. So again, as we were mentioning, there's limited access to primary care providers here in the state. We would need something like 2,300 additional physicians to meet the current national average. There are over 2,700 pharmacists living here that are highly qualified and well-trained healthcare professionals that might be able to help bridge some of this gap. I discussed kind of some of the basics of pharmacist education and training, that it requires a professional doctorate is the entry level training for this. You must graduate from an accredited institution in order to sit for licensure to become a licensed pharmacist. Training, again, really kind of focuses on how we use medicines to treat disease rather than any specific task like dispensing or something like this. There's training in pharmacology, pathophysiology, pharmacotherapeutics, but also patient assessment, patient communication. And clinical exposure is required in all of these programs with a minimum of 1,716 hours required to graduate, but again, many schools requiring much more than this. Post-graduation, pharmacists can choose to practice, or they can choose to specialize by completing postgraduate training in the form of a residency or a fellowship in various areas, including cardiology, critical care, infectious disease, or psychiatry, and a handful of other specialties as well. And again, this is rooted all in evidence-based medicine and clinical guideline provided care. Pharmacist education and training encompasses the whole scope of patient interaction and patient care, including interviewing patients to collect data, seeing how other medications, disease states, and other labs are there, and how those are all interacting together to create a plan that is safe for the patient, is going to treat all the disease states, and oftentimes will include referral to other providers when necessary. And then on the back end, following up and making sure that the medications and the treatments that are in place are being effective and safe. Historically, we think of pharmacists in a dispensing role. However, again, the education hasn't really focused on that dispensing role as much as just how medications work. And so if we're talking about trying to use pharmacists to help provide primary care services here in the state, we're kind of shifting over into more of a clinical service provision model, which is going to have to go through like a medical billing benefit. And that's one of the barriers that we're experiencing right now. And so here's where I think we realized that my slides weren't working. So there is quite a bit of data to support pharmacists providing these clinical services. About 15 years ago, there were already nearly 300 papers that were included in a meta-analysis that came to the conclusion that pharmacists provided direct patient care has favorable effects across different healthcare settings, and that incorporating pharmacists into the healthcare team can be a viable solution to help improve U.S. healthcare. Regarding costs of this, again, other data will show that for every dollar that a pharmacist that's spent on a pharmacist providing this care, the healthcare system is going to receive about $4 back in savings due to reduction in emergency room visits, hospital readmission rates, length of hospital stays, and slowing of disease progression and death. Since these studies were published, the vast majority of the data is highly positive, saying that pharmacists are capable of providing these in a safe and effective manner, and that it does generally save health systems quite a bit of money. Public policy research organizations have also come to this conclusion, saying that full practice authority is a proven safe and effective solution to helping the primary shortage crisis. By letting pharmacists practice at a higher level, we should be able to help address some of those needs. Now in Nevada, we already have the ability to do this as pharmacists in many cases, but not every case, and there are some barriers that are in place. Inside of hospitals, there's generally protocols that will allow a pharmacist to adjust doses. Many times an antibiotic or something like that will just say pharmacy to dose, and we'll take care of that. There are antimicrobial stewardship pharmacists that will assist physicians in selecting the correct medications that would maybe be beneficial for that patient there. That's been happening since the 60s. Even 30 years ago, in 1997, within federal sites, the VA, over 2/3 of VA centers 30 years ago had prescribing privileges already established for pharmacists. And inside the Indian Health Services, those were done as early as the 1960s and 70s in some cases. Pharmacists already in law are able to perform CLIA wave tests. The CLIA wave test is a test, something like a rapid flu test or a COVID test. We might be familiar with maybe a blood glucose finger stick. They are deemed to be, fairly innocuous, and there's a low risk of having an errant result come out. Again, the Nevada statute already allows pharmacists to conduct these tests. However, only in some cases are we allowed to prescribe these tests, and that's important for monitoring on the back end of any sort of medications that the patient's already on, and seeing what might be indicated more formally. Collaborative practice agreements exist here in Nevada. We've been able to do that since 2011. However, uptake of this has been limited, partly due to issues around reimbursement and making this a viable model. There's other recently passed state legislation that also allows some expanded practice in the areas of HIV prevention, opiate use disorder prescription and treatment, and things like hormonal contraception. One of the questions that we'll get then is, well, is this safe to allow pharmacists to do this? Again, we had about 300 papers 15 years ago saying that yes, it was safe and effective. But when we think about this, pharmacists are trained to use evidence-based medicine and clinical guidelines to help direct their care. And pharmacists gain clinical experience within the setting they're practicing in, whether they've chosen to do a residency and gain experience that way, or just working within that area for a while. What we'd really like to avoid is limiting pharmacists from serving a particular population at the highest level of their scope, as that would be a disservice to patients who would benefit from that expertise. Also remember that, in a community setting, most pharmacists are going to be employed by a company. That company is going to have their own policies and protocols that are there to protect patient safety and limit their liability. Pharmacists providing clinical services will include collaboration with other healthcare professionals. It would include things like documentation of the services and referrals to other to other healthcare professionals, just like we see in other areas of practice. And what we do see is that the other states and the federal government that have adopted these advanced pharmacy practice models, they've seen improvements in patient safety and optimized medication use. To further discuss some of the barriers that these pharmacists or pharmacists here in the state of Nevada are facing, I'm going to turn it over to my colleague, Zach Roscoe.
For the record, I'm Zach Roscoe, Z-A-C-H-R-O-S-K-O, and I'm currently the president of the Nevada Pharmacy Alliance, and I'm also a licensed pharmacist. So as Evan mentioned, there are a lot of services we are already providing as pharmacists in Nevada. One of the most common services that you may be familiar with is called medication therapy management. This is where a pharmacist works one-on-one with the patient to look at their medication use and identify medication-related problems. So problems in how they're using their medications or the outcomes. But we also have authorities within the state to provide both preventative and disease management services. And right now, all of the services we're going to talk about in the fixes we're hoping to see put in are simply to remove barriers that exist to services we already can provide. These barriers, Evan kind of alluded to them already. One of the first barriers is in laboratory testing. We're already authorized to perform CLIA-waived tests within the state, and we do have some authorities, some pathways to order laboratory tests for our patients if it's for HIV prevention autonomously. If it is for something that we have a collaborative practice agreement for, we can order under the collaborative practice agreement. But if we're working with patients outside of the realm of those two authorities, and we identify potential issues either in their management of a disease or in their use of medications, we cannot autonomously order that test. We also cannot, for the tests we can perform that are CLIA waived, we cannot be designated as the laboratory director of a CLIA waived lab to actually perform those tests on site. We would have to find another medical provider of one of the types enumerated in statute who can be a lab director, and this includes obviously physicians, but this is other professionals including chiropractors and nurse practitioners and PAs, but pharmacists cannot fill that role presently. Another barrier is in administering medications. And again, pharmacists are doing this already. We certainly administer immunizations on a routine basis and other medications. But there are authorities within the state to administer medications are tied to the definition of dispensing, which actually in practice limits us to administering medications other than immunizations. There's some other regulations that play in there. But we cannot administer medications in a site that is not authorized to dispense. So that means only within a pharmacy. We can't work within a physician practice or other office and administer medications. The third barrier here is prescribing and adjusting medications. And again, we can be delegated authority through a collaborative practice agreement with another provider right now to manage any medications within the state. And there's a few authorities we have to autonomously prescribe medications. But right now, that remains a barrier for many communities where we have examples in the rural area and with some large organizations who are able to provide services within their community pharmacies for test and treat services. And that's something like screening for a respiratory infection when a patient has symptoms, performing that CLIA waive test, and then issuing a prescription if appropriate for potentially an antibiotic or an antiviral. We have pharmacies doing that right now. But again, this is not every pharmacy where you can access this. And the limitations are such that if you cannot form that relationship with a physician or another provider who can issue a collaborative practice agreement with you, your pharmacy cannot participate and deliver these services to your community. And then the last barrier, which Evan also mentioned, is getting paid for services. Now, there are, with some of the authorities that have been granted in the past legislative sessions, the recent ones for contraception, opioid use disorder, and HIV prevention, we are granted the ability to bill and be reimbursed by commercial payers and state Medicaid, so that is already in place. But the majority of services that we are already providing cannot be billed to or reimbursed by Medicaid by current policy. We can work with commercial payers to try and get a contract with them, and they can elect to cover more than what's required by the state. But without additional action, Medicaid will not be able to reimburse for those additional services. And on the screen here is just a list of some of the services right now that we can provide and are providing, but cannot bill to patients who have Medicaid or provide in that scenario. What that looks like in practice often is that if a pharmacy is offering one of these services, whether they have a commercial contract or a cash pay rate, if someone walks in with Medicaid, they either would have to charge them if they're able to, but more often they'd be referred elsewhere and told they cannot receive service. So what is the current state in Nevada? Are we comparative to states around us and the nation? We're going to look at some additional documents put out. I think Evan mentioned the Cicero Institute earlier in one of his slides. They're a policy research organization that conducted a report that was published in 2025 called Unlocking Pharmacist Innovation, Policy Strategies for Full Practice Authority. This looked at the state of pharmacy practice throughout the nation and ranked each state on pharmacist ability and autonomy to administer medications, order and perform laboratory tests, and independently prescribe medications. This scoring system was used to rank every state from 0 to 10. What you can see here, we scored 3 out of 10. And that puts us in the lower tier of readiness to assist in the delivery of non-dispensing services and to fully utilize pharmacists to their training and education. If you look at the states around us, other than on the West Coast or Western half, other than Wyoming and Arizona, we're lagging pretty far behind, and a lot of our bordering states are in that highest tier or just below it. So they're either in a needs a little bit of work or ready to fully implement or have implemented pharmacist services. And we do see that also in practice. I think Evan could comment on that, but a lot of the pharmacists we train and educate here do not stay in the state, especially those going through residency programs. They are pharmacy students, are newly licensed pharmacists, want to engage in the services that they're trained to provide, and they often go seek that position or the state where they actually can engage in services. On the payment side, so we talked about payment, where do we sit as far as payment for services? This is a map put out by the American Pharmacists Association, and it again ranks each state in how they are reimbursed or what state mandates exist for reimbursement of pharmacist services. The purple are states that have commercial reimbursement mandates. The aqua are states with Medicaid reimbursement mandates, and the blue are states with commercial and Medicaid mandates. That very last color on there are states that have coverage for just specific services, and that's where we fall right now. We have mandates for coverage of contraception prescribing, for HIV prevention, and MOUD services. What we are hoping to move towards is to the teal color, where we have mandated Medicaid reimbursement. Now, is it worth the spend? I think Evan mentioned some of the literature on that before. There's evidence that shows for every dollar spent on pharmacist services, the health system saves roughly $4. Just taking an example from another state, in 2022, pharmacy associations in the state were trying to similarly get coverage for pharmacist services in Maryland. Their legislature instead convened a work group. They passed a bill to form a commission to look at the evidence behind paying for pharmacist services. After completing their work the next year, the work group universally recommended covering pharmacist services, and then they did pass a bill that implemented both commercial and Medicaid mandates for pharmacist service coverage. And so what have we been asking for? What are we advocating for? We do have solutions in language that we promoted in the last legislative session. And again, we would ask to reintroduce language similar to that which was in AB 186 in 2025. And this is one specifically removing barriers to delivering pharmacist services. So that's removing those barriers we have with prescribing, removing barriers with laboratory services and administration. And then again, reintroducing a form of a bill In 2023, we ran a bill that had both a commercial and a Medicaid mandate. We can directly work with commercial plans, and in a lot of states where it's not required, they do still opt to cover services. So in 2025, we were looking just to get Medicaid coverage. And again, we think that's the approach to take. So we're looking to ask for Medicaid coverage of pharmacist services. And then just in summary, pharmacists are already providing clinical services. We know there's a need in Nevada, and we believe we can help fill that gap.
Thank you, and we're happy to answer any questions you might have.
Thank you for your presentation. I'm very familiar with AB 186. I know a lot of work went into that bill and amendments, and so I'm sorry that it didn't go anywhere. I think it would have been a great bill if implemented. Committee members, any questions? Senator Ellison, do you have any questions?
No, ma'am. Good presentation, what I could hear of it. Thank you.
Thank you. Thank you again for being with us today. Our next presentation, we will hear from the Nevada Pharmacy Alliance. This time, it is related to PBM laws. Welcome. You may begin when you're ready.
All right, thank you, Chair Marzola and the members of the Joint Interim Commerce and Labor Committee. My name's Ken Kunke, K-E-N-K-U-N-K-E, and I'm a licensed pharmacist here in Nevada, practicing since 2003, and I currently serve as the Executive Director of the Nevada Pharmacy Alliance. Today we're going to be talking to you about pharmacy benefit managers. And I know that many or all of you are familiar with pharmacy benefit managers because multiple bills were introduced and failed or passed in the last session. The first one I want to mention is SB 389 that was introduced by Senator Scheibel. That was a bill that created transparency and regulated. All right, technical difficulties. All right, so SB 389, it was creating transparency and regulating pharmacy benefit managers in Nevada Medicaid and the managed care organizations. That one did pass, so I want to thank everybody for that. Another bill that was introduced, and it was SB 316. It was introduced by Senator Wynn. It did pass the Senate 19-2, and it passed the Assembly 42-0. But it did have an amendment, and when it came back to the Senate, it did not have time to get conferred on the last day. So unfortunately, that one did not pass. So the slide you're looking at now is a description of where pharmacy benefit managers fall in the drug distribution chain. And as you can see, they have a role in a lot of different things here. The key point of this slide is that PBMs determine which medications patients can access and how much they pay at the pharmacy counter. The reason why I want to point that out is because when patients come to our pharmacies and they have problems accessing their medications or their medications are really expensive, they always blame the insurance company, but it's actually the pharmacy benefit manager who actually decides what the patients are going to pay and what they're going to access. So where did things go wrong? Pharmacy benefit managers were created because they were going to solve a problem. At first, patients would have to go to the pharmacy, pay full price for their medication, then they'd have to get a receipt and submit that receipt and get reimbursed. Well, when technology started coming along, Pharmacy benefit managers were that bridge. So the pharmacy would transact what the claim was, and then the PBM would send back how much the patients would pay. So the patients would only pay their copay, they got their medicine, and there was no further paperwork that had to be done. Somewhere along the line, PBMs realized that they weren't being regulated. There wasn't a lot of transparency around them. So they started doing things that would make their companies more profit. The top 3 PBMs are listed there. This is an alarming figure. The top 3 PBMs reported $27.6 billion profit in 2022. That is not an M, that's a B, $27.6 billion. What's concerning is that's a 438% increase since 2012. And this accounted for more than half of the parent company's total profit. And I want you to remember that on the next slide, because the actual parent companies, they have a lot of different lines where they're making money, but this PBM is making over half of their profit right now, or in 2022. There's a lot of different revenue streams that PBMs can use to make more money. The first one is manufacturer rebates, where they're actually partnering with manufacturers of drugs, and they're charging them rebates in order to get that drug put on their formulary. It'd be great if those manufacturer rebates went back to the patients or to lower healthcare costs, but what we see is the PBMs themselves retain some of that rebate. Also, spread pricing. This is the difference between a payer pays a pharmacy. The payer pays and the pharmacy receives. So if a drug costs $100 and that insurance company pays $100, that PBM can reimburse the pharmacy $80 and keep that $20 as a spread pricing. So we see that a lot. They do make money on administrative and service fees. And then we also see them steering high profit medications to their own pharmacies because, like I said, I'm going to show you on the next slide, they're vertically integrated. So here's a slide of the PBM landscape right now. As you can see, there's 6 major players. Those 6 major players, they process 95% of the prescription claims that are submitted in the United States, with the top 3 PBMs processing 80% of those claims. As you can see, the PBMs are now all owned by major insurance companies. And like I said, the top 3 PBMs are Express Scripts, owned by Cigna, CVS Caremark, owned by Aetna, and Optum Rx, owned by United Healthcare. Another thing I want to point out is that they do own their own pharmacies. So when companies are vertically integrated like this, they can play games where they actually direct medications to their own pharmacies. And what we see a lot is that they actually direct the medications that can make the most profit to their own pharmacies so it could stay in their system. So do PBMs save the healthcare system money? The problem we have is that PBMs control the data and what is shared between who. So that's between the manufacturers and the insurance companies, the pharmacies and the insurance companies, and the pharmacies and patients. My question is, if they're saving so much money, they should be promoting these plans that increase transparency. They should be coming to you saying, please pass these laws. Let us show the American health system how much money we're saving them. I just want to point out $27.6 billion. Just imagine if that came back to our patients instead of these top 3 PBMs. If you don't believe me, every day there's an article that comes out, a study, a report. The first one started in 2018 in Ohio. They realized that a PBM, the one PBM that was doing their Medicaid, was keeping $208 million in spread pricing in 1 year. From there, a lot of other states started looking at PBMs, and a lot of these laws had started passing. In Congress, there's been a lot of committees that have looked at PBMs. I'm happy to report that Congress just passed a comprehensive PBM bill that is going to roll out in the next couple of years. Unfortunately, that's only going to be Medicare patients. It's not going to be our Medicaid, which SB 389 takes care of, or SB 316, the commercial plan. So we need to concentrate on those commercial plans. The New York Times published a couple articles. They did a lot of research before they published these. And just the lines here, pharmacy benefit managers are driving up the cost for millions of people, employers, and the government. And then the second one is the powerful companies driving local drugstores out of business. The attorney generals can see the issues that are going on. Recently, 43 attorney generals wrote a letter and are calling for PBM transparency and laws to be put in place, including our own Attorney General Ford. The Federal Trade Commission also did some reports looking at PBMs. The first one, just like we were talking about before, these PBMs are profiting at the expense of patients and inflating drug costs and squeezing Main Street pharmacies. The second report, the FTC, they looked and they showed that the PBMs were charging significant markups for cancer, HIV, and other critical specialty drugs. Just the numbers that came out of that report, PBM affiliated pharmacies generated more than $7.3 billion in dispensing revenue, above the estimated cost of the medication between 2017 and 2022. In that same period, another $1.4 billion they say they kept through spread pricing. So these are the types of things. Every day you see articles like that. Just yesterday, the University of Michigan and the University of Kansas filed lawsuits against their PBM. And they're saying that the PBM took $66 and $60.2 million from them. So those are two articles that were published yesterday. So if I take all those articles that I just had on those previous two slides, I'm not going to go through these one by one, but these are just in patient terms, things that the residents of Nevada can understand. And all these things that PBMs are doing are raising their own profit centers. They're not helping patients in this capacity. So what happens after a state passes PBM reform? The state of Tennessee was one of the early adopters in many of the policies that were passed. But what they noticed is that even though this policy passed, the PBMs were not following them. They were completely ignoring them. So they had to start overseeing the PBMs. So I've been told that they have 10 people working in their Office of Insurance that are regulating and making sure PBMs are doing what they say. And they also are paying a third-party company to make sure what they're reporting is true. And as you can see, for the three biggest PBMs, they're still doing these actual audits were published in 2025 or 2026, so they're very new. They identified spread pricing, paying their own pharmacies more, and failing to comply with the laws. The National Community Pharmacy Association does have best practices for enforcement of PBMs. I'm not going to go through these, but I just wanted you to have this handout. I provided it over here. Just because when we do pass the comprehensive PBM commercial bill, we want to make sure that our Attorney General and the Insurance Commissioner can regulate those and make sure that they're doing what we're asking them to. Another thing, pharmacies are closing. Nearly 30% of US drugstores closed in one decade. Back in 2016, Nevada did a cost of dispensing survey. And what they found out is that pharmacies should be able to get paid for the drug. So if they pay $100 for the drug, they should get reimbursed that $100. And then they should get paid an extra $10.17. And what that does is it covers their staff, their rent, the lights, the prescription vial, all that other stuff. So for a $100 drug, the pharmacy should be reimbursed $110.17. Is that happening? This is real data from a rural pharmacy here in Nevada. It was just pulled a couple of weeks ago. As you can see, the gross profit on the right, it's in the red because it's negative. So not only did that pharmacy pay $1,059.33 acquisition cost for that medication, the insurance or the PBM only gave them $1,045.73 back. So that's a loss. In 2025, that same pharmacy had 1,656 claims that were below the cost of the medication. And if we extrapolated that times $10.17, that pharmacy lost $13,534. Now let's play another game where if you take those claims, you times them by the $10.17 that they should have got paid. So they should have got paid $16,841, but they actually lost $13,500. So the pharmacy, it was a $30,000 swing. No pharmacy can stay in business with this type of practices. Remember I said they were paying their own pharmacies more? This is that report from from Tennessee. It was published on March 2nd, 2026. And as you can see, the pharmacy was paying, or the PBM was paying their own pharmacies, the ones they owned, a lot more than the drugs, than the pharmacies that were not owned by them. So not going to go through this slide, but these are the 5 laws that we've passed, and I thank you so much for that. I just wanted you to have that information, what PBM laws have passed here in Nevada. But the lack of policies is what's really concerning. The National Community Pharmacy Association that track 18 different policies in each state, and they identify which states have enacted statutes to regulate them. Nevada ranks last. We've only passed 2 of those policies. The first policy we passed is licensure and registration, and the other policy we passed was SB 389. It prohibits spread pricing in Medicaid, but that will not be rolling out for quite some time. So overall, in the United States, out of the policies they track, which, like I said, we already passed 5 bills, but they only track 2 of those 5. There are 417 policies that passed, and we're only responsible for 2 of them. So do healthcare costs go up after PBM policies pass? First off, for the commercial plans, there's a lack of data and studies. Remember, the PBMs own the data. They get to share what they want to share. So when they go to employers, they can share what makes them look good. But we would have to collect money from every healthcare plan in every state to see when policies pass, does the price go up? But what we do have is entities that are closed. So Medicaid managed care plans, Medicaid. So what we've seen in Kentucky when they actually rolled out a bill like SB 389, the 2 years following the bill's implementation, Kentucky saved $283 million. Ohio, they saw a savings also of $140 million after their Medicaid managed care bill passed. We also have data from the Federal Employees Benefits Program. There was an audit for the claims that were done in 2018 to 2021, and this showed that the PBM overcharged the program over $615 million with those things that we talked about earlier. So it's just time to unmask the middlemen. We need to make sure we pass policies that help our patients here in Nevada. I'm not going to go over all these key provisions in SB 316 because I did provide a handout, but it's going to increase transparency and oversight, protect patients, protect non-PBM affiliated pharmacies, addresses anti-competitive practices, and strengthens enforcement. That is an amazing bill. We were so upset when it didn't pass last session. We woke up thinking it passed and then found out it did not. But now that we have some time to work on it, what we would ask is that it does get reintroduced, which we've heard from Senator Wynn that she has filed the reintroduction of it. And then we would like to add a policy that requires fair pharmacy and reimbursement standards. So one thing that we look at is paying the pharmacy the cost of the medication plus that dispensing fee that we're talking about. And then also, we just want to make sure that the bill sponsors work with the Division of Insurance and the Attorney General's office to make sure that we have the things in the bill that once it does roll out, that they can enforce it. So I do have Sam here with me, which I'd like to give him a chance to speak. He is one of our pharmacy owners here in Nevada, and he can give you a real life example of what happens.
Good afternoon, Chair and council members. My name is Samuel Wild, SAMUELWILDE for the record. And I'm a pharmacist licensed here in the state of Nevada. And I also own a rural pharmacy here in the state of Nevada. Every day, my staff and I work hard to help patients navigate illnesses, rising medication costs, and an increasingly complicated healthcare system. And I wanted to provide a few real-world examples that I see from my pharmacy about how PBMs affect us in our day-to-day business and how they affect our patients' lives. Recently, we were audited by a PBM over a prescription that had been filled correctly for a patient. The patient had been processed through the insurance exactly as approved at the time. The patient had no out-of-pocket cost, and the claim was paid without issue for 3 separate refills. Then, more than a year later, the PBM decided that the medication was suddenly considered a covered item billed as a non-covered item billed as covered. As a result, they recouped nearly $400 for that prescription from my pharmacy. Think about that for a moment. The medication was approved and dispensed appropriately. The patient received the therapy that they needed. There wasn't any fraud, There was no waste or abuse, no mistake in how it was billed. But yet, over 12 months later, the rules changed and my pharmacy was forced to absorb that loss. No small business can survive under those rules that shift so frequently and that are out of our hands. Number two, pharmacies are routinely reimbursed below acquisition costs, as Ken stated a few slides back. In 2025 alone, my pharmacy had over $13,500 in negative profit prescriptions. Those are medications we dispensed at a financial loss just to ensure our patients received care, and we're on track to significantly exceed that number this year. Imagine any other business being forced to sell products every single day for less than what they paid to buy them, and then being expected to stay open, pay employees, keep the lights on, and continue serving the community. Independent pharmacies are being squeezed from every direction, and we're told to provide healthcare access, counseling, vaccinations, medication management, and emergency services. Yet the reimbursement system punishes us for doing just that. Another example involves a medication used to treat a disease called ulcerative colitis. A patient came to us with insurance coverage and was quoted a copay of $302 to cover her medication for 1 month. The insurance company itself paid $0 towards the medication, zero. The patient's insurance benefit actually made the medication more expensive than it should have been. If that same patient had walked into my pharmacy with no insurance coverage, the medication would have cost them roughly $90 per month. How can we honestly tell patients the system's working when insurance coverage triples the cost of a medication? Patients assume their insurance is negotiating lower prices on their behalf, but too often PBM pricing structures inflate costs through spread pricing, hidden fees, and rebate arrangements that benefit the middleman instead of the patient. And then there's the issue of manufacturer rebates. Many PBMs require patients to use expensive brand name medications, even when lower cost generics are readily available and clinically appropriate. Why? Because PBMs often receive substantial rebates from brand name drug manufacturers. The higher the list price, the larger the rebate opportunity. Meanwhile, patients pay higher copays and deductibles based on inflated prices. Pharmacies are reimbursed below acquisition cost, and PBMs continue to profit in the middle. It creates a system where the incentives are completely backwards. And as pharmacists, we're trained to help people access safe, effective, and affordable medications. Yet too often, PBM policies prevent us from dispensing the most affordable option because the business model rewards higher prices instead of lower ones. Thank you for your time.
And that is our presentation. We're here for questions.
Thank you, and thank you for your presentation. Committee members, are there any questions? Senator Ellison, do you have any questions? Yeah. Well, if he does, he'll reach out. I think he just has a bad connection. It is my understanding that Senator Nguyen has submitted her bill from last session. What that looks like, if it's the same language, I don't know, but I would recommend you reaching out to her so you guys can start having those conversations way before session starts. I don't see any questions. Thank you for hanging in there with us all day. And with that, thank you. Our next presentation, we will have another overview on PBM, and that will be by Pharmaceutical Care Management Association. Welcome. You may begin when you're ready.
I don't have a PowerPoint, so I'm just going to read my testimony for you today, and looking forward to the conversation. For the record, Sean Stevenson, SeanStephenson. Thank you, Chairwoman Marzola and members of the Joint Interim Standing Committee on Commerce and Labor. My name is Sean Stevenson. I'm Senior Director for the Pharmaceutical Care Management Association. PCMA is the national association representing America's pharmacy benefit managers, also known as PBMs. PBMs administer prescription drug plans and operate mail order and specialty pharmacies for more than 289 million Americans with health coverage through their employers, health insurers, labor unions, state and federal, local units of government. There are three things I want you to remember today. It's this. One, no one is ever mandated to use a PBM. Two, PBMs are the only entity in the drug supply chain that looks to put downward pressures on costs. And three, in the total dollar drug spend of a prescription drug, 65 cents goes to the drug manufacturer, 25 cents to the pharmacy, 6 cents to the PBM, and 4 cents to the wholesaler. If the public policy objective is to look to create lower costs on prescription drugs, you gotta look at where 90% of that spend is, which is with the drug manufacturers and the pharmacies. The core mission of PBMs is to reduce prescription drug costs, as I said, for all the entities that provide benefits to their employees. And in return, they provide their employees access to the needed prescription drugs that they get. To that end, PBMs are a third-party administrator that simply execute the plan that employers choose. While employers could negotiate directly with drug companies and pay the prices each pharmacy charges the general public, nearly all choose to work with PBMs because of the value our companies provide to them and the patients that they cover. Over the next 10 years, PBMs will save employers, health plans, labor unions, state and federal local units of government more than $1.2 trillion. In alignment with the theme of this hearing, we strongly believe that competition is key to lower drug costs. That said, the quickest, clearest, least prohibitive path to lower drug costs is for drug companies to simply lower their price. PBMs focus on enabling access and lowering prescription drug costs for patients in the wide range of health plan sponsors that choose to hire them specifically by negotiating manufacturing rebates from drug companies, negotiating discounts from drugstores to reduce costs for patients, their family, and health plans. Again, saving an average of $1,154 per patient per year. It is important to note that these savings are fully under the control of the PBM client in every aspect. PBMs also encourage the use of more affordable alternative drugs, such as lower cost brand names, generics, and biosimilars. PBMs offer services that benefit patients, such as home delivery, adherence programs, and drug reviews. PBMs also help manage and help patients with access high-cost specialty medications. PBMs are also helping identify and root out waste, fraud, and abuse, and preventing potential harmful drug interactions. I want to take just a quick moment to talk about the value of what PBMs do. So getting drug rebates from manufacturers, that creates savings for the payers of the plans. Ultimately, they get to decide what to do. So in the Nevada Public Employee Plan, they use a PBM, Express Scripts, they get rebates. Ultimately, they get to decide what they do with the savings from that. It's not the PBM dictating the terms and conditions of that, but rather up to the payer do what they will with that cost savings. There's a couple pathways to do that. You can make drugs cheaper at the point of sale. You can use all that money to aggregate it to reduce everyone's premiums. But ultimately, that savings is up to the payer of the benefit to decide what to do with that. Mail pharmacy services. For the federal government alone, studies have demonstrated that encouraging the use of lower cost options like home delivery results in significant savings. Mail delivery is expected to save Medicare Part D and Medicaid managed care programs for $100 billion over the next 10 years. Home delivery pharmacy programs are also the most cost-effective option for patients. DOD and CMS found that mail service pharmacies cost less than retail, with a savings of 16.7% for TRICARE and 16% for Medicare. Specialty pharmacies. Specialty pharmacies offer higher discounts than average retail drugstores and dispense drugs with nearly zero errors. Specialty pharmacies are projected to save the healthcare system $554 billion from 2020 to 2029. Adopting preferred pharmacy networks can also help lower the cost of drugs. In private insurance plans in Medicare, it was deemed to save 2%. In 2017, roughly 50% of all commercial plans did not have a preferred pharmacy network. Had those plans had a preferred pharmacy network, they would save more than $1.3 billion a year based on 2018 numbers. Creating formularies, which are simply a list of drugs covered by your benefit. Formularies are just a list of prescription drugs that have been clinically evaluated by specialists before being included in a drug benefit. They emphasize high-value, effective drugs that help patients and plan sponsors get the best outcomes for the lowest net cost. A pharmacy and therapeutics committee are independent clinical experts which evaluate clinical safety, quality, and cost effectiveness evidence to determine a plan's formulary. P&T committees ensures that a formulary is up to date with the latest clinical guidelines and drug availability. Health plans and PBMs use formularies and cost-sharing tiers to provide medications at various price points based on a plan design. Claims processing. When you go to the pharmacy counter, it's PBM technology that in an instant you scan your driver's license, your medication, and that in that split-second moment, the PBM will be able to determine that you have the right medication at the right amount, at the right dosage, and at the right price. Drug utilization. Utilization management encompasses many tools PBMs use to encourage safe and cost-effective medication use, such as prior authorization, step therapy, drug utilization review, and a refill too soon checks and quantity limits. Prior authorization ensures that a medication is clinically appropriate, safe, and cost-effective for the patient. Prior authorization is necessary for drugs with dangerous side effects. With those drugs, interactions, and those only intended for certain health conditions, or those prone to abuse and misuse, or when an equally effective, less costly drug is available. Step therapy. Step therapy ensures patients receive the safest, most cost-effective drugs by requiring them to try proven, more affordable therapies before more expensive options. Generic drugs are typically much less expensive than their brand name counterparts. Step therapy is designed to capture savings while achieving the desired clinical outcome. Disease management for specific diseases. Diabetes, for example. PBMs can monitor and measure a patient's glucose level through a smart glucometer and conduct outreach if the patient needs medication support. Wearable digital devices. PBMs offer continuous glucose monitors, which are small sensors placed under or near the skin for continual monitoring of blood glucose levels. These sensors test every few minutes and send data wirelessly to the PBM patients. Now I want to go into how PBMs get paid, and we heard a little bit about this, and I just want to clarify any confusion that there may be. So PBMs get compensated in a combination of one of three ways: spread pricing, rebate retention, or administrative fee. Again, how does spread pricing work? Pharmacies charge different amounts for different drugs. For example, prices for a drug can vary based on whether a pharmacy is in or out of a consumer's network, or whether the pharmacy purchased more or less expensive versions of a multi-source drug. To manage the fluctuating costs, an employer or a health plan may ask the PBM to carry the risk that the patient chooses a costlier pharmacy to fill their prescriptions, allowing the plan sponsor to pay a set reimbursement for each drug, regardless of which pharmacy they chose. If what the pharmacy charges the PBM is more than the reimbursement rate agreed by the plan sponsor and the PBM takes a loss. The pharmacy charges less, the PBM earns a margin. Smaller employers often choose a spread contract because of the pricing and predictability and savings they derive. Rebate retention. Employers and health plan sponsors may also choose to compensate and pay their PBMs by asking them to retain a portion of the drug company rebates, aligning incentives towards cost savings. This is a less common payment model among larger employers. Administrative fee. Plan sponsors may choose to pay the PBM a fee to administer claims and pay the PBM whatever the pharmacy charges based on the contract between the pharmacy and the PBM. Many large employers prefer this compensation model over a spread model because they have the scale to absorb the variability. Plan sponsors may also choose to pay administrative fee for rebate administration in lieu of allowing a PBM to keep a small portion of the rebates to pay for those services. So just to kind of talk about what one of the last presenters said, that we are doing, we are keeping the rebates or we're conducting spread pricing. Those options are ultimately left up to the employer. Again, I'll use the state of Nevada's public employee plan. They choose how to compensate their PBM, and they can do it in one of those three ways. I don't remember which method they prefer, but it'll be one of those ways. So a lot of that gets conjectured, but ultimately that's just how PBMs get compensated by people looking to provide benefits. I want to talk about transparency because that was a big topic in the last presentation too. Transparency helps patients and payers, and it's necessary across the entire prescription drug chain. PBMs support and practice actionable transparency that empowers patients, their physicians, those sponsoring health coverage, and policymakers so that each of those actors can make informed decisions that can lead to lower prescription drug costs. Actionable transparency encourages consumers to shop for coverage that best fits their health needs and budgets, and once covered, use the most cost-effective, highest value healthcare goods and services. It enables prescribers and patients to avoid pharmacy counter surprises and helps ensure that physicians can prescribe drugs that are affordable for patients. To that end, PBMs provide patients and prescribers with real-time benefit tools. The detailed cost-sharing information found in these tools include information on exactly where the patient is with respect to progressing through a deductible or another benefit phase, what drugs are on the patient's formulary, and as noted above, exactly what the cost-sharing a patient should expect for a given drug at the pharmacy. PBMs also provide patients with information on in-network pharmacies, premiums, general cost sharing, and benefits for the prescription drug plan. Again, as it was alluded to by the previous speaker, as you may know, the Consolidated Appropriations Act recently passed by Congress this year is the last mile on the PBM transparency journey. The transparency PBMs provide and the reporting that is required is second to none. Soon data on every claim, every drug, every contract, and every fee will be easily accessible to employers, unions, and the government. The enactment of the CEA subjects PBMs to a broad range of detailed reporting mandates, including PBMs will report drug by drug, claim by claim, and pharmacy-specific pricing to employers, unions, and government programs. These reports will dive deep on generics, biosimilars, rebates, agreements with drug makers, and in some situations, additional information about drug coverage. For Medicare Part D plans, employers and unions will have greater authority to audit PBMs during a plan year. While the audits have always been available, standardizing the terms and the frequency will make the results more usable for plans. The legislation commissions a new comprehensive public report on compensation and payment structures tied to prescription drug prices within the retail prescription drug supply chain under Medicare Part D. Additionally, Congress will receive annual reports on trends and patterns in PBMs contracts for Part D, building on early reporting on PBM rebates and fees. Just want to give you a couple of brief metrics in terms of how PBMs impact the folks that live in Nevada. 2.7 million lives are covered by PBMs. PBMs will save Nevadans $8.7 billion in all insurance markets over the next 10 years. PBMs will save the Nevada Medicaid program $852 million. Enacted laws. Nevada has been regulating PBMs since 2015, enacting 10 state laws. In 2015, a law was passed that required prompt pay for paper and electronic claims within 30 days. 2017, duty of care, which states a PBM is obligated to act in good faith and fair dealing toward a third party or when a pharmacy performing duties pursuant to a contract. 2017, biosimilar substitution. This allowed the pharmacist authorized to substitute a prescribed interchangeable biologic unless prohibited by the prescribing provider. 2017 was a series of disclosure and transparency requirements. One of them being the PBM must submit to the Department of Insurance a report of the previous year that includes the aggregate of all rebates PBMs negotiated with manufacturers, aggregate amount of rebates retained by the PBM, and aggregate of all rebates negotiated for drug purchases. PBMs contracted with the state must disclose to the Department of Insurance any information including dispensing fees, measures of cost control, rebates paid and collected, and other fees imposed. Again, in 2017, generic substitution, this would allow the pharmacist to substitute a prescribed medication with biologic equivalent or generic alternative unless prohibited by provider. 2017 was a frozen formulary measure, which states that a health insurer or PBM that offers a plan is prohibited from removing a prescription drug from a formulary or moving a drug to a higher cost sharing tier during that plan year. 2019 was a gag order repeal. PBMs cannot include clauses in its contracts that prohibits pharmacies from disclosing cost sharing information to patients, including the availability of lower cost alternatives. 340B, PBM cannot set lower reimbursement rates for 340B pharmacies. And finally, a $35 copay cap on insulin. In terms of what is also happening in Nevada, I love looking at, I was briefing myself in preparation of this, looking at what one of the reports I put out from Express Scripts, and it just highlights, again, with the goal of these discussions, lowering prescription drug costs, I wanted to point out a few things. So in the most recent report, when you look at Q2 of fiscal year 26 and from Q2 of fiscal year 25, net claims is down. And that just means, obviously less people are using prescription drugs, but at the same time, prescription drug costs are increasing 10% from 22 million to 24 million. And when you dive into those numbers, the cost of generics has gone down by 200,000, but the cost of name brand prescription drugs went up $2 million. So again, as I stated, we can look at a lot of things, but when you drill down to the numbers, it's lowering the list cost of drugs from drug manufacturers is what's going to ultimately help achieve that goal. So that's what I have from my prepared remarks. I do want to just dovetail off the previous presentation and state right at the top, we need pharmacies. We need independent pharmacies. We need brick and mortar. We need specialty. We need mail. We need them all. Without pharmacies, being located in your districts, your constituents aren't going to be able to get their prescription drugs. So it is not the objective of a PBM to have pharmacies go away. That is not our objective at all. And I know that sounds silly to say out loud, but I want to make that clear. In terms of the waste, fraud, and abuse, and the gentleman spoke that he had a claim processed and went through $400 and then was clawed back a year later. All the provisions that would stipulate a clawback would be drawn out in the contract that they make with the PBM. So there's nothing slight-handed going on here. This is something that the pharmacy and the PBM sign jointly, that we have the ability to do this. So we are simply exercising the terms of the contract. And again, as one of our reported tools is to find waste, fraud, and abuse to get that out of the system, we are absolutely take that seriously and will continue to do so. Under reimbursement, is it true that PBMs under reimburse pharmacies for prescription drugs? Yes. As the last presentation showed you, they cherry picked a handful of data. But when you look at the 30,000 foot view and the contract that they sign, They are signing a contract with the PBM on reimbursement rates. And what they didn't say is the overall package that they agreed to and signed, they're making a net profit. And I don't know what that number is. That's between the PBM and the pharmacy. But if you lose a drug that you dispense one time, and you lose $100 on that drug, let's say, you are making up for it by a drug you dispense, let's say a couple hundred times, and you mark it up 20%. So they are signing a negotiated package that makes sense for them to stay in business. No one would ever sign a contract that, where they would be losing money. They wouldn't stay in business that long. So that's the other half of that story. He also made the comment that PBMs put high list they put drugs in front of generics and in favor of high list price drugs. Also incorrect. So the other half of that story is you have list price and you have net price. We are always going to put forward the lowest net price on the formulary. So if the $1,000 drug and we get a rebate and negotiate that, or let's say we negotiate the $1,000 drug down to $200 and the generic alternative is $300, we are absolutely going to put that negotiated name brand drug in front of the $300 generic. And it does happen. Generics can be more expensive than name brand drugs. And so it's disingenuous to say that they are putting favorable or higher price drugs on. In terms of list price, that may be true, but the net price is absolutely not the case. So I did want to call a few of those things out from the presentation. But with that, I conclude my presentation. I'm happy to take any questions you have at this time.
Thank you for your presentation. Are there any questions? Senator Ellison, do you have any questions? Well, I'm sure if he does, he'll reach out to you. So I have a question, and I just may be a little confused. Okay, so we have the PBM world. That is a very complicated world. In your presentation, is it my understanding that you're stating that the PBM space does not make a drug more expensive?
Correct.
Okay, and so what you're essentially charging to the pharmacy, that amount is not passed to the consumer or the patient.
So I
Am I making sense?
thank you for the question. Yes, through the chair, for the record. What you're asking, so plan design is all borne by the employer. And I think that, if we take a step back, that's an important thing to remember. So you as an elected official have a benefit plan through the Nevada State Employee Plan, and they determine your co-payments, what drugs are on your formulary, and what you're going to pay when you go to the counter. So again, you use a PBM, Express Scripts, and they're going to process that claim for you, and they're going to execute the contract as laid out with the state of Nevada. And that's that.
I guess the PBM space makes billions of dollars. And I'm trying to figure out, if you guys didn't make those billions of dollars, does that money trickle down to the patient or to the pharmacies? And I know you referenced, the pharmacy gets into these contracts and they know the terms, and I do understand that, but it doesn't mean that the term of the contracts is best for the pharmacist. And so I'm just trying to figure out why prescription's so expensive. Nevadans can't pay for them. We have pharmacies closing down, but the PBM space is making millions of dollars. Or I'm sorry, not millions, actually billions.
So thank you for question and comment, Chairwoman. I guess I'd say this. We need independent pharmacies. We need pharmacies so that people can get their prescription meds. Absolutely. Now, the people that hire PBMs, whether it's the state of Nevada, private employers, the casinos down the strip, whomever, they hire us and say, get us lower costs on prescription drugs. So that's who we are servicing. It is, and we are going to do everything that is in their best interest, which again, why, pharmacists and drug manufacturers tend to go after PBMs politically in the media, et cetera, is because we're pulling at their bottom lines. In a world without PBMs, if you were to snap your fingers and we were gone tomorrow, there would be no price concessions on any prescription drugs. There would be no rebates getting from drug manufacturers because there'd be no leverage, and everyone would be subjected to whatever list price that they put on the open market for the drug that they put out tomorrow. Same thing with pharmacies. If there was no downward pressure being put on pharmacies, as you heard in the last presentation, they would like to get their ingredient costs and then have a $10.19 dispensing fee. Again, it is our job to provide benefits at the lowest possible cost. And, there's going to be tension in two entities when we're pulling at their bottom lines. And I understand that friction, but it's also, the private sector force is in play here, and we are going to, do everything we can for our for our customers to provide the benefit.
So you don't believe that PBM needs any sort of reform?
No, I think you let the free market take place, continue to let us find creative ways to help reduce costs, because that's the question of the day, right? Like, costs are going up. How can we bring them down? Why would we go after the one entity that is looking to bring downward costs? I mean, and this is, from where I sit, it was a super interesting dynamic I saw play out in the last 4 years, and I've been with PCMA for 4 years. The other side has convinced you that rebates are a bad thing, when rebates are a tool to lower prescription drug costs. They have a sense poisoned the idea that rebates are bad and that they do nothing except go to PBMs. But in reality, they are price concessions that we get from the drug manufacturers. But they've convinced you that they are this awful thing that PBMs get, and that's simply not true. And again, we pass that cost savings on to our employer. And again, I started this conversation out by saying no one needs to use a PBM. They don't. People choose to because of our proven ability to lower prescription drug costs. And if we didn't have the ability to do that, no one would hire us, and we would be gone like that. But we do have value. We do add value to the prescription drug chain. We do lower prices, and that's why the federal government uses us. The state of Nevada uses us. And most employers, 289 million Americans, choose to use a PBM. They're not forced to. We're not an essential part of the supply chain. Supply chain is drug manufacturer, wholesaler, pharmacy.
Any questions? Senator Flores.
Thank you, Madam Chair. But just for clarity, in your presentation, and thank you, and I do appreciate you leaning in on the fact that you are going to the employer, you're putting it on the table, and the employer is ultimately making a decision. That's important to understand. But in your presentation, I thought you originally had indicated that there were concessions and different points that were raised in the previous presentation that you were willing to make and work on to continue to move in a direction of transparency, accountability, et cetera, et cetera, et cetera. But then Madam Chair just asked if you think we need to make any reforms, and you indicated no. So I just wanted to understand, and I may have misunderstood you.
Thank you for the chair. For the record, in terms of And it just depends on which part of the presentation. If you could reference it one more time, please.
And I apologize. It's just when you were going through your presentation. Yeah. I know that you had mentioned that, the previous presenters brought up these issues. Yep. And we are open to continuing to work on these issues. And I guess I took that just as signaling, yes, we're going to continue to work together. We're willing to come to the table. We understand that there's some changes we can work together on. But I think what I heard at the end here when Madam Chair asked, so you don't think we should make any changes?
I don't. And when I'm looking at my notes that I wrote down, I was talking about the previous presentation, talking about waste, fraud, abuse under reimbursement and rebate list price versus net price over generics. That I was kind of dispelling those three things. So
understood. So
my apologies for the confusion.
Understood. Thank you.
Thank you.
I don't believe we have any other questions. Thank you.
Thank you so much, Madam Chairman.
Our next presentation is from NVHA concerning the implementation update for single PBM under Senate Bill 389. Is there anyone in Carson City presenting? Hi, welcome. You may begin when you're ready.
Chair, committee members, Dr. Keiko Duncan, Nevada Health Authority Senior Clinical and Pharmacy Officer for the record. Thank you for having me. I'm here to hopefully briefly discuss the single pharmacy benefits manager implementation from SB 389 of last session. So just to provide, I'm going to do this as chronologically as I can to keep my brain in order. So immediately following the bill passage, we engaged an expert vendor in this space that helps us look at operational and financial modeling for how we might structure a single state PBM. And then from there, January 1st of 2026, we started what I like to call the first phase of unification, which was the implementation of a single preferred drug list in Nevada Medicaid. So this, as the name suggests, unified the drug list across all managed care organization plans and fee-for-service. That has been going well, and we're in the middle of a standard 6-month transition period, or towards the end of that transition period. Some people might know this period as like a grandfathering phase or a legacy coverage phase. Essentially, it just allows members to continue their current prescriptions, even if they are not compliant with the single PDL. And take some time to evaluate with their prescriber the appropriateness to change medications to the preferred drug list. So that process, hopefully we are minimizing some care disruptions along the way, but we have certainly learned a lot in the operationally through this process. So in the beginning of May, we released a request for information for vendors that would bid on a pharmacy benefit manager procurement, trying to look into different operational and technical capabilities, as well as requesting some scope recommendations and scalability. So that RFI closes next Friday, May 29th. And from that, we'll take the answers and analyze that to inform our final procurement strategy. So really our next steps here is actively drafting that formal RFP for release. And I can say we are most certainly on track for the target release date of January 1st, 2030, for our implementation, which is the legislatively mandated deadline. So I do want to call out a couple points in this process. That's kind of the overview of the timeline. So I think the financial modeling is really important here, trying to evaluate the cost of this. I think at this point we've determined that there is some version of a cost. However, we're looking into where the balance might lie. I know we've talked a little bit today. I've heard about rebates and spread pricing and such. And so I just want to call out a couple points as well. Spread pricing in SB 389, it was explicitly banned in legislation, but I would say in Nevada Medicaid, our managed care organization contracts already require a pass-through pricing model. So that requires the plans to validate that the amounts that the PBMs are paying, reimbursing the pharmacies at, are the amounts that they are charging the plan. So essentially no spread pricing being that the PBM reimburses the pharmacy at a lower price and then charges the plan at the higher price and pockets the remainder. So essentially, we have required a check to occur in addition to that pass-through pricing model. And I would note, specific to rebates, there is a requirement already in legislation, actually, that our managed care organizations must pass through their rebates to the state, less a 1% administrative fee. That administrative fee, I believe, was removed in SB 389 once that single PBM becomes goes into effect. But again, it's just a 1% administrative fee as a part of those rebates that are passed through. Additional points of SB 389, there was also the Nevada average acquisition cost that was requested to be implemented. So we have also engaged an expert vendor in this space to develop that scope of work for that RFP release. And so we are on track to release that hopefully towards later 2026, so we can move that pricing reimbursement model to the start of next year. So a lot more to come, but that's the updates that I have for you today. I'll stand for any questions.
Thank you for your presentation and thank you for the update. It seems like you guys are doing PBMs a little different. And so we will probably look, to the state as a great model and maybe talk about how, pharmacies or different spaces that use PBM can do it the way we're doing it. Because I think that affords us a lot more protection. And so the protection would go further to the pharmacies as well. So I don't have any questions, committee members. I don't believe we have any questions. Thank you. Our last presentation today, believe it or not, is from the Nevada Health Authority. And I believe Mrs. Weeks is with us today.
Chair, committee member Stacy Weeks for the record. We're just trying to find our presentation for you real quick, so just bear with us. I apologize.
No problem.
Okay. I think we found it. Okay, thank you. All right, I'm going to kick us off, get us started, and we'll try to move quickly. I know you guys are all really tired. It's been a long day. Thank you for having us. I'm Stacy Weeks. I'm the director of the Nevada Health Authority. I'm here with Teresa Carson, our executive officer at the Public Employees Benefits Program. And we'll just go ahead and dive right in. So real quick, I just want to give you guys an update on the team at PEB. Since session ended last 2 years ago almost, we've been busy implementing the Nevada Health Authority, and part of that was moving over the Public Employees Benefit Program. Teresa Carson is the new executive officer. We also have a new chief financial officer, Monica McJoy, and then also, as you can see there, Nick Proper is still with the PEB, and Brandy Moonahan is the agency counsel. We are in the process of hiring a quality control officer at this time. And just a reminder that PEB covers about 70,000 state employees and retirees together. And as you can see, that's retirees are both Medicare retirees as well as those that may retire earlier in their career and lifetime in Nevada, and so they're pre-Medicare. PEB is governed and ran essentially by a board. There are 11 members on this board. They are appointed primarily by the governor, but there are 2 appointments that were added last session by the Senate Majority Leader and the Speaker of the Assembly for state employees. State employees representatives make up about 5 of the members, 2 retirees, and then INCHE actually gets 2 seats to themselves. But also they, at this time, do make up some of the state employee seats. We also just have 2 experts right now on the board, 2 expert seats. The authority of the board under state law is to design benefits, select vendors and support contracting. They set the premium rates, they adopt the regulations, and they should be acting as a fiduciary to ensure the financial soundness and solvency of this program. And as I mentioned earlier, just to point out, also I forgot to mention, one of the state employees is represented by the Department of Administration. And I am going to kick it over to Teresa so she can carry on the rest of the presentation. Thank you.
Good afternoon. Teresa Karsten for the record. In this slide, we talk about PEB and our benefits program. We have, as Stacy said, we cover administrating health insurance, medical, dental, vision, and basic life insurance for state employees, retirees, and their dependents. And then we have optional benefits, inclusive of additional life insurance, long-term disability, accident and illness, home and auto coverage. PEB offers HSA and HRA pre-tax options to help cover medical costs for health insurance programs for employees and retirees under certain programs, one being our consumer health driven health plan. So this slide shows our plan offerings and the vendors that are contracted to run them. So our consumer-driven health plan operates a nationwide network under UMR, as does our low-deductible health plan, which is a self-insured plan as well, with a nationwide network. The EPO has a more limited network for Northern Nevada, also operated by UMR. And then we have one health maintenance organization with the highest actuarial value. It's a fully insured plan, and it's limited to those that reside in Southern Nevada. Additionally, we have Medicare Exchange for those that are eligible, and our PBM is Evernorth, also known as ESI. So employer and employee contributions make up PEB revenues. Therefore, PEB has to collect employee premiums set by the board and the legislatively approved employer contributions each year to pay for the costs. So this table shows a little bit about how PEB receives those subsidies and then how we transfer that to pay for our healthcare expenses. So AGIS stands for Active Employee Group Insurance Subsidy, and REGI is Retired Employer Group Insurance Subsidies. And those come into their own separate accounts. We collect them from each of the agencies, and then we transfer what is needed to pay for healthcare expenses to our administrative account. It's important to understand that this is the only revenue that PEB has. We do not receive state general fund, and therefore we cannot seek interim contingency funds to reduce employee premiums mid-biennium. We do have catastrophic reserves, and in some instances they have been used as an option to cover unexpected costs that need to be replenished by the state. This is a timeline of our annual process. So every year the PEB board reviews and adopts any plan design changes and benefits, and reviews and approves premium rates for employees and retirees. So before every plan, the September before the following plan year, the board comes together to elect what ideas they want our actuarial vendor to come up with and analyze. Then that occurs in October. There are additional discussions and conversations that happen in November. In December, usually the board votes on what changes will be implemented for the following plan year. Then in January, final plan documents get updated and approved for the plan design coming up. And by March, rates have to be set. There is a time in statute that requires us to have rates set by a certain time, but really we have to have the board approval in March in order for all of our systems to be updated, tested accordingly, and processed for the following plan year on July 1. Me or is it? Okay. So So there were minimal plan year 27 design and rates changes. In December, the board elected to increase the out-of-pocket maximums for certain plans, and then later voted on rate increases over the next 2 to 3 plan years, depending on plan type. So for the consumer driven health plan and the low deductible PPO, those rates were phased over a 3-year period, and then those rates for the EPO and the HMO were phased over a 2-year period. Over the last several years, since program year 22, there's been a shift in costs from the members. They were paying 33%, and as recent in 26, it's looking at like 28%. So all of those costs shift to the PEB program, which this last year was in an amount of about $30 million. And that has increased due to several reasons are contributing to rate increases. One being the growth in medical and pharmacy costs. Medical trend has increased about 9%, and pharmacy trend has increased about 16%. Those were all well above what we projected and asked for in our budget. Additionally, there was some surplus that was found a couple of years ago that was depleted, and then the funding didn't get reestablished for those plans, and so we were collecting less than what the plans cost. Did I hit all of those?
Chair, committee member Stacy Weeks, the record. I think it's been a long day for all of us. Teresa was at a board meeting all afternoon. So on that last point, really there are two things and I'll just go to the next slide because I think I kind of can cover it there. But we did an audit of PEB pretty quickly after when Teresa moved into her role. We noticed some of the financing and accounting pieces being problematic. So we did hire a fiscal auditor of sorts and someone to come in who understands state budgets and accounting. And we looked at that and found pretty quickly that in addition to just having high medical trend and pharmacy trends, which we see across all markets right now, unfortunately, and nationwide, we experienced this situation where after COVID, there was some surplus, and that surplus was used to buy down premiums, and the board did approve that. And in doing that, that kind of offset the reality for state employees of what really the prices were and the costs were. And that was nice, but that money went away. And when that, I think it was between 27 and 30 million. My brain's going blank right now, but that money went away and was depleted. And during that time, the board did not reset the rates to account for that, and neither did the system. So when I say system, that means the way we collect the premium collection. So we were under collecting. And also just not and charging premiums that were much lower than we needed to be. So that is a problem, and the board did not readjust at that point those rates because that would have been a spike. And then the other piece I would just note is going back to the other bullet, which is around the accounting issues. Those things we're working on right now. We have been implementing, working on a new workbook, also working with LCB as well as GFO on ensuring next session that whatever is approved by the legislature is the correct workbook. There were issues with that as well that we found. So I think needless to say at the end here, we're working really hard to get the train back on the tracks. And I think going forward, we're looking forward to working with the board as well. Teresa and her team working with them, as well as some of our experts at the Health Authority, including Dr. Duncan, who was testifying earlier around the PBM about what can we do to control costs. We hired Milliman as part of our directive under state law to look at a purchasing strategy as well as actuarial modeling of new options for PEB. And so we're working on that right now and hope to have an options report later this summer, early fall. Everything I wish happened sooner and quicker, but we're doing the best we can with the time that we have. But I'm sure many of you have questions, so I'm just going to stop there and open it up. Thank you.
Thank you for your presentation, committee members. Are there any questions? Senator Ellison, do you have any questions? I don't believe we have any questions, but thank you so much for all the information and your presentation. I can't see you. There you go. Thank you so much. I will let the committee members know that they can also take any questions offline if they do think of any. Thank you so much. And that ends our last presentation. I will now open up for public comment. Please remember to address your remarks to issues that fall within the jurisdiction of this committee. Is there anyone in Las Vegas wishing to provide public comment? I don't see anyone. Is there anyone in Carson? Welcome. Thank you for hanging in there with us. You have 2 minutes. Please remember to state and spell your name for the record. You may begin when you're ready. Can you turn on your microphone, please? Turn your microphone on. Perfect.
Good afternoon, Madam Chair and council members. My name is Catherine Nicholson, C-A-T-H-E-R-I-N-E, Nicholson, N-I-C-H-O-L-S-O-N. Thank you for allowing me to speak today. The reason why I came to speak is in regards to workplace abuse and workplace violence. And I'm so sorry that I missed HCA's presentation because it's actually in regards to their facility. In July of 2024, I had false accusations made against me. In regards to these accusations, I'm sorry. I was accused of doing something that I did not do. My name was slandered. My reputation was damaged. And the reason why that is so important is because right now I am a psychiatric mental health nurse practitioner. So we had a lot of discussion in regards to mental health and why that is so important. The PBMs, all of that. Everything makes a difference when it comes to workplace violence and mental health. I had 3 individuals who falsely accused me, intentionally set aside after my son's wedding in June to say that I did something that I did not do, all because I decided to speak up. This hospital was Mission Hospital in Asheville, North Carolina. And so I went to EEOC and I filed complaints, and I thought maybe it is just these individuals, only to realize that it was well over 11 individuals who falsely accused me. Not only did they falsely accuse me, but I would like to say I filed a lawsuit. So it was 2 things, EEOC and a civil rights lawsuit. And on March 27th, because I am a resident here in Nevada, I spoke with my attorney. And my attorney said, HCA is willing to settle with you. They want to offer you something. But what they wanted to offer could never replace what I had to endure, what I had to go through.
Can you wrap up your comments? And just so you know that you can always submit your comments in writing, and we'll make sure the entire committee gets it.
Absolutely. And I did not take this settlement. So May 2nd, I had a gun put to my head, all because I did not agree to this lawsuit settlement. I have been followed. I have been stalked daily. I have been harassed. I am a psychiatric mental health nurse practitioner with my own practice, and my practice is not even open as of now. As of April 21st, I had a cyber attack from them.
I'm gonna need you to wrap it up, please.
Sure.
Thank you.
So what I would like to say is, while HCA is recommending and suggesting that their facilities are great facilities, they are not. They bully in the workplace. They have mob issues within the workplace, and people are afraid to go to work, such as myself, scared to speak up.
Thank you for being here with us today.
Sure.
I really do appreciate it, but we do need to let others give public comment as well.
Absolutely.
Thank you.
Thank you so much.
Is there anyone else in Las Vegas wishing to provide public comment? Please remember to state and spell your name for the record. You have 2 minutes.
Hi, my name is Jamie King, Jamie King, King. I'm the Director of Pharmacy at University Medical Center of Southern Nevada. UMC has been a part of the 340B program since its inception in 1994. We signed a pledge many years ago to provide transparency about our savings and how they're used. We publish that annually on our website. We use our 340B savings to reach more eligible patients and provide more comprehensive services, which is the stated intent of the 340B program. Our HIV care at the Wellness Center and the Healthy Living Institute and our infusion center are all examples of services that would be at risk without the 340B savings that we get. We're happy to follow up with the committee with any follow-up questions, but just wanted to advocate on behalf of the 340B program and the importance for our community.
Thank you. Committee members, do you have any questions for her? No, thank you, but thank you for being open for questions today. Is there anyone else in Las Vegas wishing to provide public comment? I don't see anyone. Is there anyone in Carson City wishing to provide public comment? Please remember to state and spell your name for the record. You have 2 minutes.
Hi, my name is Netochi Adeolokun. My first name is spelled Netochi. Last name is spelled Adeolokun. And I'm a Director of Clinical Pharmacy Services at a federally qualified health center here in Washoe County. My FQHC is called Community Health Alliance, and we participate in 340B. And I just want to follow up with everything everyone has supported regarding 340B. Our FQHC, our model is to help any patient regardless of the ability to pay. And those 340B savings help keep our lights on. They help serve our patients. A lot of our patients come in and they aren't able to afford their medical visits if they go anywhere, but those 340B savings is what helps all of our patients. So I just want to advocate and support that. And secondly, I want to just advocate the clinical pharmacy services as well. We as clinical pharmacists, as pharmacists in general, we see patients with several chronic disease states that we help serve with our medical providers, and any form of reimbursement services will help support these vital services and full wraparound care in the healthcare setting. So again, I just want to advocate for all of those, and thank you for your time.
Thank you so much for your testimony. I don't see anyone else in Carson City. Broadcast, is there anyone on the line?
Thank you, Chair. If you would like to participate in public comment today, please press *9 to take your place in the queue. Once more, that is *9 to join the queue.
Good afternoon, committee. My name is Brooke Malath. You've heard from me once or twice before. First, the presentations today have been absolutely incredible, and a lot of very smart people, dedicated people that are trying to be able to look after the health of Nevada citizens. It's incredibly important that we don't leave anybody out in these conversations. After all, one of the principles that we originally started this country about was that every individual ought to be able to have life, liberty, and the pursuit of happiness. That includes the access to health care. We have a huge disparity right now in being able to offer health care to transgender adolescents. This is primarily primary care. It's ordinary with just a little bit of other types of things that need to be able to be done to affirm and accept their identity and who they are and keep them alive. When we see these types of services being withheld, we see a 50% increase in suicidal ideation of these transgender kids. One of the things that we need desperately are pediatric endocrinologists, both in the north and the south. Intermountain's ability to put together a children's hospital and recruit pediatric endocrinologists is incredibly important. There are two main issues that pediatric endocrinologists are having to treat. First is juvenile diabetes, and the second is for transgender kids. Most of what that looks like are simply puberty blockers. You notice I did not say surgeons. I did not say anything about surgery. We are talking about simple, ordinary medical procedures that can be done with chemistry that is completely and totally reversible if a person decides to detransition. Unfortunately, we are also experiencing a huge amount of what I will call the corporate practice of medicine, where corporations, organizations are taking threats primarily from the federal government, including the Kennedy memo, and disallowing their doctors to be able to treat transgender adolescents, or what they call adolescents, because it includes 19 and under, and 18 being the age of majority, legal adults. And we need to be able to stand up for our own providers to be able to allow them to practice medicine as they are trained to do in a way that is ethical and moral and keeps these kids alive.
Can I have you
The Kennedy case was over.
testimony, please?
Yes, it'll be done in just a second. The Kennedy case was overruled recently in a major ruling out of Oregon in the federal court. There was a Kansas ban that was overturned with 345 notations of the lies that were presented in support of the bill. California is put legal action on the Rady Children's Hospital in San Diego to reopen their program. And we, unfortunately, in 2 sessions, neglected to pass a shield law protecting our providers because
I am going to ask
our
you
eminent
to
governor
wrap up your testimony and submit the remainder
I'm
of your
finishing up.
writing.
I'm finishing up. Our eminent governor vetoed those bills that would provide protection, and I look forward to seeing the shield bill come back in our next session. But please consider banning the corporate practice of medicine. And I thank you. I appreciate all of your time. Thank you very much.
Broadcast, is there anyone else on the line?
Yes, Chair, one moment. Caller with the last 3 digits, 194, please press *6 to unmute yourself.
This is Tom, T-O-M, McCoy, M-C-C-O-Y, Nevada Chronic Care Collaborative. As was shared in the presentation, the purpose of Section 340B is to use discounted drugs to help vulnerable patients gain access to more affordable medications and more comprehensive services. We support that mission. Unfortunately, the program has few restrictions or oversight provisions, and abuse has followed. Over time, the program has drifted off course and now faces national scrutiny. The amount of charity care has been declining for nearly a decade. while for-profit revenue streams have increased for corporate pharmacy chains and pharmacy benefit managers. Originally, safety net providers dispensed drugs directly to patients. 340B today runs more through contract pharmacy arrangements. Partnerships where hospitals allow retail corporations to dispense externally, often at higher prices. We also heard earlier about the expansion of multiple thousands of contract pharmacies. Some are located thousands of miles away from the covered entity. We have a bifurcated health plan system in the U.S. and Nevada. ERISA, government plans controlled by federal law, and state-regulated plans. The recent PBM reform legislation at the federal level did not remove the need for PBM reform law in Nevada. We need to take care of that next year. The 340B drug pricing program is solely federal. Any issues with the program need to be addressed first in Washington and then Carson City. Recent proposed model legislation and that passed by state laws regarding 340B are centered on protecting contract pharmacies and not transparency or accountability of program abuse problems. I've used a lot of P words in these short comments. The one P word that must have priority when considering anything to do with 340B is the patient, helping the needs of Nevada patients. Patients over profits. That was and should continue to be the goal of 340B.
Thank you for your testimony, broadcast. Is there anyone else on the line?
No, Chair, there are no further callers for public comment at this time.
Thank you. This will conclude our meeting for today. I would like to remind everyone that the committee has posted a solicitation of recommendations. If you wish to offer any recommendations relating to the committee's jurisdiction for consideration at our final meeting on August 20th, 2016, please do so by July 16, 2026. And with that, that concludes our meeting for today. Thank you so much, members, for hanging on with me today, as well as everyone in the audience. We do really appreciate everyone that participated today, especially in public comment. This meeting's adjourned.
Thank you.